Hello, and welcome to my first video of the Step 2 course. I'm Dr. Chris Lewis. Now, some of you might remember me from our Step 1 course, Graphs, Data, Factors. Something in my teeth? Booger? Hey, I don't have narcissism. I'm the Black Stallion. You're my little pony. Okay, so I performed a bunch of silly intros for the Step 1 course, but I'm all done with that nonsense. I am a serious teacher, not the clown of USMLE Step Prep. Travis, we talked about this. I said no jokes. This is obviously a hilarious hat. No props this year. Are you kidding me? Pajamas? Who would lecture in pajamas? You see, Travis, you can't make me do anything stupid this year. I don't have to be funny. Okay, so we're going to start off talking about atherosclerosis today, and this isn't very hard material, but it's going to set the stage for future videos. Now, atherosclerosis is usually a disease of large and medium-sized vessels, and it's characterized by accumulation of fatty materials in the walls of the arteries. Now, atherosclerosis usually begins in childhood, but generally does not become clinically significant until later in life. So the risk factors include hypertension, hyperlipidemia, obviously, and when we say hyperlipidemia, we're talking more about elevated LDL and possibly low HDL. Other risk factors are going to include diabetes, big one, smoking is a huge one, family history, and then of course the good old-fashioned American sedentary lifestyle and poor diet. Now, another interesting association with atherosclerosis is hyperhomocystinemia, so elevated homocysteine levels. Now, elevated homocysteine is an independent risk factor for things like CVA, peripheral vascular disease, and coronary heart disease. But it's not as important as hyperlipidemia. This was thought to be a potentially very big deal, but most experts nowadays are not advising routine screening of homocysteine levels. But you could get a question about treatment though. If a patient has elevated homocysteine levels and maybe a very poor diet, like say maybe a chronic alcoholic patient, then you might supplement them with some vitamins. More specifically, vitamin B6, B12, and folic acid. So atherosclerosis, so this is a progression of events that leads to atherosclerosis. And the first thing that we're going to see is endothelial dysfunction. So the beginning of atherosclerosis begins with some level of loss or damage to the endothelium of the arteries. Now this leads to something. This leads to increased vascular permeability, leukocyte adhesion, and even some thrombosis as well. Now, endothelial dysfunction is associated with many of the traditional risk factors that we just talked about: hypercholesterolemia, diabetes, hypertension, and smoking. So what happens next? Well, we see the next step as being accumulation of lipoproteins. So the endothelial dysfunction is going to stimulate the accumulation and the oxidation of lipids in the vessel wall itself. And these lipids, again, are mostly going to be things like LDL. The next step is going to be what we call monocyte adhesion to the endothelium. So next we see migration of monocytes, and they're actually going to move into the intima, and then transformation of these cells into macrophages and foam cells. So what's a foam cell? Well, it's really just a macrophage that's full of lipids. So all that LDL that was accumulated is now being taken up by these macrophages, and now we're going to call those macrophages foam cells. The next section is going to be factor release. So inflammation continues to play an active role, and we see activated platelets, macrophages, we see inflammatory mediators, and cytokines. So atherosclerosis and inflammation really go hand in hand. Next, we have smooth muscle cell proliferation. So as this inflammation continues, we see a proliferation of smooth muscle cells and a deposition of extracellular matrix, things like elastin and collagen. Now, normally we see smooth muscle cells primarily in the media of arteries, but now we see migration of all these smooth muscle cells into the intima itself. And then finally we have lipid accumulation. So there is a continued accumulation of lipid both extracellularly and actually within macrophages and smooth muscle cells themselves as well. So now we have a bulging atherosclerotic plaque, which then can later become disrupted. It can kind of rip apart and actually trigger further thrombus formation. So next, let's move on to how atherosclerosis presents clinically. Now, patients are often asymptomatic for most of the disease progression, but over time, atherosclerosis will lead to symptoms like angina, claudication of the lower extremity, stroke symptoms, and even hypertension and retinal changes. Now, many of the symptoms will obviously rely upon where that atherosclerosis is developing. Now, when you have atherosclerosis of your coronaries, you're going to have anginal symptoms. Atherosclerosis of the popliteal arteries or your femoral arteries, that's going to lead you to claudication. So what is the association of atherosclerosis with an abdominal aorta? Well, that atherosclerosis is going to lead you to a AAA, so an abdominal aortic aneurysm. So one of the main risk factors of that AAA is atherosclerosis. Now, don't get confused, smoking is actually considered the biggest risk factor. So how does atherosclerosis, though, lead to or contribute to that AAA? Well, that atherosclerotic plaque compresses the underlying media of the artery, which leads to a problem with nutrient and waste diffusion. So you get a kind of degeneration and a necrosis of that media, which is going to lead to arterial wall weakness. So this was the primary theory behind those AAAs, but more recent data suggests that there's multiple risk factors that are going to be contributing to that formation of the AAA. It's not just secondary to atherosclerosis, but still a pretty big risk factor. And we'll talk about AAA screening and treatments in a lot more detail in another video. But back to atherosclerosis in general. So how do we test for atherosclerosis? Well, in asymptomatic young patients, we really tend not to directly. Not everyone needs to have invasive or expensive tests to evaluate their own personal atherosclerosis level. However, we often screen for diabetes, and that can lead to atherosclerosis. We check fasting lipid panels to look for hyperlipidemia, and we even check fasting glucose levels. That's to monitor for the presence of diabetes. Now, we measure blood pressure again to rule out hypertension, but the presence of problems only suggests a higher risk of having atherosclerosis, not atherosclerosis itself. So when do we go to that next step? Well, it's usually when patients become symptomatic, things like chest pain, lower extremity claudication, or a pulsatile mass. That's certainly going to prompt us to look more closely at the arteries that might be susceptible to atherosclerosis. And to do this, we use a lot of things: stress tests, echocardiograms, nuclear studies, angiography, ultrasounds, all that type of stuff. So let's talk about this in a little bit more detail. First, let's talk about how to evaluate for coronary artery atherosclerosis. The first test is an exercise stress test. So the exercise stress test should be used basically with anyone with a prior history of coronary artery disease or who is at an increased risk of having coronary artery disease. The exercise stress test is usually the next best step for a patient who complains of things like stable angina or maybe new shortness of breath or fatigue with exertion. Now, this is assuming the patient can physically handle the exercise. So you put a patient on a fitness machine, usually it's a treadmill. They run faster and faster, you raise the incline. The heart rate is going to go up, and as the heart rate goes up, the oxygen demand on the heart is going to go up as well. And any sort of ischemia is more apparent with higher heart rate and that higher oxygen demand. Now, you have to stop the test early if there's any signs of ischemia, like chest pain, dizziness, claudication. Maybe you get a sudden decrease in blood pressure in the setting of increasing work. And of course, ST segment changes on that ECG as well. So any of these would certainly suggest the presence of an ischemic heart disease. Now, after a positive exercise stress test, then you would need to do something else to determine the degree of that coronary artery disease. And that next step is usually something like an angiogram. We'll cover that here in just a minute. Now, there are other versions of the exercise stress test. You have the nuclear exercise test, and this is a thallium or maybe a technetium acetaminophen test. So either of these substances can be used. They're injected during that exercise testing, and then scintigraphy is a kind of planar or single positron emission CT scan that's performed to assess myocardial perfusion. So we use this in cases of suspected ischemic heart disease in which the results of maybe a regular exercise test was maybe equivocal. Now, exercise stress tests with echocardiogram is another option. So this is where you do that regular exercise stress test, but then as soon as you hit potentially the maximum level of exercise there, you have them lay down and you do an echocardiogram. And it increases the sensitivity, and it's going to also detect that myocardial ischemia a little bit better. Now, the echo will also be very helpful for finding wall motion abnormalities, big portion there. And that's going to be present during exertion that might not be present during rest. You're going to see that abnormal motion. So it's used in conjunction with that exercise stress test, and it's going to improve the sensitivity overall. Another wrinkle here is the pharmacologic stress test. So this is administering a cardiac inotrope/chronotrope, something like dobutamine. You're going to speed up the heart and how hard it's beating as well. And that's going to be done in place of exercise. And that's going to, again, increase that myocardial demand. Now, another class of drug is going to be the vasodilators, something like adenosine or dipyridamole. But you want to be careful with those specific medications in patients with asthma or if they're already hypotensive. Now, these drugs in general can also be used in conjunction with that nuclear stress test. So if patients are not fit enough to run on a treadmill, then you can use these drugs to stress that heart and you can do all the same tests. By the way, though, patients hate this test. It kind of makes you feel like you're dying. And then there's also a PET myocardial imaging, the PET test. So that's the positron emitting isotopes. So this is a three-dimensional detection imaging to evaluate the heart for perfusion again. So you're looking for perfusion defects and tissue viability. So when you look at these scans, you see the heart kind of light up when there's adequate perfusion. There are areas of ischemia, then you're going to see black areas on the heart. And sometimes these black areas only show up during the exercise, but some are fixed, which may be due to a previous MI with subsequent scarring. And then finally, that ultimate test for coronary artery disease is coronary angiogram. So it's the gold standard for identifying the degree of coronary artery disease or occlusion. But it's more invasive than some of these other techniques, and there are potential complications with coronary angiograms. And that's why we generally start with things like a stress test or a stress echo, and then proceed to an angiogram if that appears to be abnormal. But there are occasions when you go straight to the angiograms as well, and we'll talk about that in more detail, especially when we talk about percutaneous transluminal coronary angioplasty in our ischemic disease lectures. So that's how we look at coronary pathology. What are some of the other tests that we use to evaluate atherosclerosis? So what if a patient has worsening leg cramping with exertion? Or maybe even a more obvious would be a chronic lower extremity ulcer or decreased pulses. So what would be the next best step in the diagnosis of that type of patient? Well, the answer is going to be a resting ankle brachial systolic pressure index, often referred to as an ABI. The patient is placed supine and the ankle systolic pressure is measured, and then the systolic pressure of the arm is then recorded, and the ABI is the ankle pressure divided by the arm pressure. And if that ratio is less than 0.9, then there is some peripheral artery disease present. Now, if you have peripheral artery disease, you have to worry about coronary artery disease as well. So if you have plaque in one place, you probably have plaque somewhere else. So another step after confirming the presence of peripheral artery disease would be probably to evaluate for coronary artery disease. You might want to do a stress test or maybe even an angiogram. Let's move on. What about a patient that might be having symptoms associated with a stroke or a TIA? How would we evaluate the presence of atherosclerosis in that type of patient? Well, the answer is probably going to be a carotid ultrasound. Now, we won't go into too much detail here because we have an entire lecture on strokes and TIAs. Okay, so that's a good start on how to look for atherosclerosis in the body. Now, how about we go about preventing or treating our atherosclerosis? Well, prevention is obviously the major priority here. So first, we have to stop tobacco abuse. So anytime you're smoking, you got to stop it. You want to normalize blood pressure. Anyone with hypertension needs to be treated. And we want to control our hyperglycemia. So any diabetic patients, get those sugars down. Control hypercholesterolemia. So you want to improve elevated LDL, improve elevated triglycerides, and you want to improve, meaning increase your HDL or your good cholesterol. And then we got to fight the typical American diet. We have to have a diet low in fats and cholesterol, low in sugar as well. And then good old-fashioned exercise is going to be good for us as well. So that's it. Most of this material is just a foundation for more detailed information that we'll see in the lectures on ischemic heart disease, on strokes, and other vascular pathologies. But right now I want you to take a look at the box in your study guide that says End of Session Quiz. At the end of each video, there's a short quiz to review some of the most important material covered in that video. So I want you to pause the video for a minute or two and try to answer these End of Session Quiz questions. Don't spend too long on them. Then once you've answered those questions, you can restart the video and we'll go over the answers together. First question, what symptoms are most associated with the development of atherosclerosis? So most often, until later in life, atherosclerosis is asymptomatic. But when you do have symptoms, the most common symptoms are going to be things like angina, lower extremity claudication, and then stroke symptoms. Next, a relatively healthy 58-year-old man complains of mild chest pain that only occurs after several minutes of intense exercise. He is now asymptomatic. What is the next best step in the management of this patient? Well, the answer here is going to be an exercise stress test. Now, other tests may include things like a chest x-ray, labs to evaluate for diabetes and hypercholesterolemia, but the most important next step is going to be that stress test. Next question, what is the biggest risk factor associated with an abdominal aortic aneurysm? So we talked a lot about plaque today. You would think it might be hyperlipidemia, but the answer is actually smoking. All right, guys, that brings us to the end of our lecture. I hope you learned something. I'll see you next time.
Oh no, it's...
That's right. I'm coronary heart disease. The leading cause of death in the United States.
But haven't you been on a steady decline since the 1960s due to advances in drugs for hyperlipidemia?
You silly human. I still kill 50% of people over the age of 65. My risk factors include smoking, hypertension, low HDL, and family history of premature CHD and age over 45.
No! What can I do? I know I will take a statin to decrease LDL, improve coronary endothelial function, inhibit platelet thrombus formation, and for its anti-inflammatory properties.
Dude, that was horrible acting. Gosh, you're not even trying.
It doesn't matter if my acting sucked, as long as we retain the information.
I am stomping and roaring my butt off over here to get ready for this exam, and you don't even care. You know what? I can't take this. I'm going in my trailer.
Well, someone's a diva.
Let's get started on the warm-up review for Cardiovascular 2. First question, what exercise stress test findings suggest ischemic heart disease? Findings that suggest ischemic heart disease include ST segment changes on the ECG, but also other changes you might see are a sudden decrease in the blood pressure with increasing work, and then other signs of ischemia may include chest pain, dizziness, or even severe shortness of breath. Next question. What is the beginning stage in the pathogenesis of atherosclerosis? Endothelial dysfunction, which is associated with smoking, hypertension, diabetes, and hypercholesterolemia. And the last question, what is the most appropriate next step in the evaluation of suspected peripheral artery disease? The ankle brachial index, or the ABI. That's it for this warm-up review. Let's move on to the lecture.
Hi, I'm Dr. Mike McInnes. Over the next several weeks, you're going to be seeing a lot of me. A lot. You're going to see more of me than you will your friends, your significant other, and possibly your household pets. Now, they're going to be fine without you. Just don't forget to feed them. Your pets, that is. But it's all worth it to get a great Step 2 or Level 2 score and then match into the residency of your dreams. I also need to address the elephant in the room, my beard. Despite the dozens of times I've teased Dr. Lewis about his unhealthy facial hair fixation, it's a little known fact that from time to time I also wear a beard. It kind of depends on my mood. Sometimes I just wake up and say to myself, "Self, you look good in a beard today." And then I grow one. What, like it's hard? So anyway, use the hashtag DITBeard and let us know who wore it better. Now in this video we're going to discuss hypercholesterolemia. Hypercholesterolemia technically means elevated serum cholesterol levels, but sometimes we'll talk about hyperlipidemia, which could also include high triglycerides, although this is less closely associated with atherosclerosis, or you might hear the term dyslipidemia, which includes low HDL, in addition to high LDL and high total cholesterol, which is important because low HDL is also a risk factor for atherosclerosis and ischemic heart disease. So let's briefly review the different types of lipoprotein particles and the distinction between LDL and HDL. Dietary lipids are first packaged into chylomicrons in the GI tract, and these chylomicrons are absorbed and transported to the liver. Then the liver takes those lipids from the chylomicrons and packages them into VLDL particles and HDL particles. And those VLDL particles, which are relatively high in triglycerides, can become IDL particles and LDL particles, which go back into circulation. LDL particles can be taken up by peripheral cells via endocytosis, which is part of the process of atherogenesis. HDL particles are able to go around and take up cholesterol from the periphery and kind of clean up the cholesterol that was deposited by LDL particles. That's why we sometimes call HDL good cholesterol. Hypercholesterolemia occurs due to a variety of genetic and environmental factors. Obesity and diet play a role, but multiple genes have also been linked to elevated cholesterol, and some single gene defects can lead to a dramatic elevation in cholesterol, such as we see in familial hypercholesterolemia. So what else affects our cholesterol levels? Well, secondary causes of hyperlipidemia include type 2 diabetes, excess alcohol, primary biliary cholangitis, chronic kidney disease, hypothyroidism, and certain medications including oral estrogens, thiazide diuretics, and beta blockers. Some of the atypical antipsychotics like clozapine and olanzapine are associated with obesity, hypertriglyceridemia, and diabetes. And remember that protease inhibitors can increase serum lipids. How does hypercholesterolemia present? Well, most of the time it's completely asymptomatic. Rarely, in patients with extremely high triglycerides and high LDL, you can see xanthomas, which are deposits of lipid in the tendons and under the skin. Another common site, not shown here, is the Achilles tendon. You can sometimes see something called xanthelasmas, which are lipid deposits around the eyes. And high cholesterol can also be associated with something called arcus senilis, which is cholesterol that's building up in the periphery of the corneas. You may also see cholesterol emboli in the retina on fundoscopic exam. Now, patients with familial hypercholesterolemia are more likely to develop symptoms like xanthomas, and they're more likely to develop high cholesterol earlier in life compared to patients with acquired hyperlipidemia. So if you're homozygous for hypercholesterolemia, your cholesterol level is going to be very high and you're more likely to have these xanthomas. And you might even have heart disease and myocardial infarctions as a teenager. We diagnose dyslipidemia with a fasting serum lipid panel, which includes the total serum cholesterol, LDL, HDL, and triglycerides. And it's very important to check the lipid panel fasting after an 8 to 10 hour fast because triglycerides especially can be influenced by what you've just eaten, and that's going to affect the calculation of the LDL. Now let's talk treatment. In general, the reason we treat hypercholesterolemia is to decrease the risk of atherosclerotic cardiovascular disease. Lowering high triglycerides may also reduce the risk of pancreatitis because remember, hypertriglyceridemia is a risk factor for acute pancreatitis. But again, the main focus here is reducing the risk of atherosclerosis. So in terms of lifestyle modification, we focus on things like weight loss, regular aerobic exercise, a heart-healthy diet that's low in saturated fats, low in trans fats, and low in carbohydrates. It's not clear how much dietary cholesterol intake really affects cholesterol levels, and it's not clear how much diet affects cardiovascular outcomes. But dietary changes may help with weight loss, which is probably the single most important lifestyle change you can get your patients to make. And then, of course, smoking cessation is an important lifestyle modification for everybody, mainly to lower the risk of atherosclerosis, not so much to lower the cholesterol. But for a lot of patients, lifestyle modification may not be completely effective, or patients aren't successful at losing the weight, and we have to add pharmacotherapy. So we're going to talk about the different classes of lipid-lowering drugs in a little bit, but first, a question that you might be tested on is how do we determine who needs to be treated with lipid-lowering drugs? Well, the rules have been kind of changing over the past several years. We used to focus on specific cholesterol numbers, if the LDL was over 130 or over 100, or some experts said over 70 in certain types of patients. But now we're using the 2013 AHA-ACC guidelines. And these guidelines really focus on statins as the primary medication used to treat hypercholesterolemia. And they specifically address which patients benefit most from statin therapy. The first group of patients are those with clinical atherosclerotic cardiovascular disease. So this includes patients with a history of acute coronary syndrome, myocardial infarction, stable or unstable angina, patients who have undergone revascularization procedures, patients with a history of stroke or TIA, and patients with peripheral arterial disease. So the guidelines state that all these patients need to be started on a moderate or high-intensity statin therapy. So high-intensity statin therapy means that the statin is going to lower the LDL by 50% or more. Moderate intensity means that the statin lowers the LDL between 30 and 50%. Now, examples of high-intensity statins include atorvastatin, 40 to 80 milligrams daily, and rosuvastatin, 20 to 40 milligrams daily. You don't really need to know the doses for step 2. I just want to emphasize that not all statins are created equal in terms of lipid lowering or in terms of risk reduction. So, moderate intensity statin therapy includes lower doses of atorvastatin or rosuvastatin or simvastatin, or even high doses of things like pravastatin, lovastatin, fluvastatin, or pitavastatin. There are a bunch of options for moderate and even low-intensity statins, and I wouldn't expect you to memorize all those, but it may be worthwhile to remember that atorvastatin and rosuvastatin are choices for high-intensity statins. So again, we start moderate or high-intensity statin therapy in patients with clinical atherosclerotic cardiovascular disease. We also treat patients with an LDL greater than 190, regardless of whether or not they've developed clinical cardiovascular disease. So if the LDL is over 190, you start high-intensity statin therapy. The next group of patients are those with either type 1 or type 2 diabetes who are between 40 and 75 years of age. So these patients should be on statin therapy almost regardless of what their LDL is. In terms of statin therapy, having a history of diabetes is just as high risk as having a history of clinical cardiovascular disease like a heart attack or a stroke. And then the last group of patients is patients with an estimated 10-year atherosclerotic cardiovascular disease risk greater than 7.5%. So there are calculators that are going to predict the 10-year risk of having an atherosclerotic cardiovascular event like a stroke or an acute coronary syndrome. So you plug in the patient's age and sex and race, blood pressure, their total cholesterol, their HDL, whether or not they use tobacco, whether or not they have diabetes, whether or not they're on blood pressure medication. And the calculator takes all these factors into account and gives you the 10-year risk of atherosclerotic cardiovascular disease. And if you're between the ages of 40 and 75 and you have an estimated risk of greater than 7.5%, you need to start moderate to high-intensity statin therapy. Now, you're not going to be expected to calculate that, but you may want to remember that 7.5% cutoff. And in general, I think it's good to know all these categories of patients that need to be on statins. Next, let's talk in more detail about the various classes of lipid-lowering drugs, starting with the statins. So we just mentioned that the AHA-ACC guidelines focus on statin therapy and deciding which patients need a statin. So the statins include lovastatin, pravastatin, simvastatin, atorvastatin, rosuvastatin, fluvastatin, and pitavastatin. They work by blocking the synthesis of cholesterol in the liver by inhibiting the enzyme HMG-CoA reductase. So sometimes you're going to hear these formally called HMG-CoA reductase inhibitors. Statins lower LDL better than any other class of cholesterol drugs. So if you want to lower LDL levels, you reach for statin first. They may help increase HDL modestly, and they can lower triglycerides a little bit as well, but the main effect is on LDL. There are a couple of rare but noteworthy side effects worth knowing about for your test. The first side effect is muscle injury. Affected patients may complain of proximal muscle soreness and tenderness, and less commonly some muscle weakness. They may report some cramping. Now, we don't completely understand how statins cause muscle toxicity. Statins affect the synthesis of coenzyme Q10, which plays a role in muscle cell energy production. And this might be a potential cause of the problem. So if you have a patient with muscle complaints and suspected statin-induced muscle injury, you can check for elevated serum CK due to muscle breakdown. And then statins can also rarely cause hepatic dysfunction. So it's recommended to check LFTs before you start a statin, and you can recheck LFTs if there's a clinical indication. So those are the statins, and again, that's the main class of drugs that we use to treat hypercholesterolemia. But you should also be familiar with a few other drugs. Ezetimibe is a drug that inhibits absorption of cholesterol in the intestine, both dietary cholesterol and cholesterol from the biliary system. But it inhibits reabsorption of cholesterol at the brush border of the intestine without affecting the absorption of triglycerides or fat-soluble vitamins. It mainly lowers LDL, and we can use it alone or in combination with a statin. Side effects of ezetimibe include myalgias and then possibly increased LFTs. So the side effects are similar to the side effects of statins. The ideal role of ezetimibe is not entirely clear. It tends to be used in patients that don't tolerate statins or in patients where you want to use a lower dose of statin and still get more reduction in LDL. Let's move on to the fibrates. The fibrates include the drugs gemfibrozil and fenofibrate. Their primary effect is on triglycerides, but they also act to raise HDL by 5 to 20%. But if you have a patient with very high triglycerides, you're going to reach for a fibrate. And again, what non-cardiac problem can high triglycerides predispose you to? Acute pancreatitis. The fibrates work primarily by reducing hepatic secretion of VLDL. The side effect of fibrates are the same as statins, myositis and elevated LFTs. So we have to be cautious when mixing fibrates with statins because together there's an increased risk of myopathy or hepatotoxicity. The next group of drugs are the bile acid sequestrants, sometimes called bile acid binding resins. Drugs like cholestyramine, cholestyramine, and colesevelam. Now, these are used to lower LDL, but they only reduce LDL by 10 to 20%. Remember, high-intensity statin therapy lowers LDL by more than 50%. Now, interestingly, colesevelam can also lower hemoglobin A1C by 0.5% or so in patients with type 2 diabetes. So it might serve a dual role in your diabetic patients. Now, the use of the bile acid sequestrants is limited by the fact that they cause a lot of GI side effects, such as nausea, bloating, cramping, and constipation. They can also cause elevated LFTs. Another unique scenario where you might see cholestyramine used is in C. diff colitis. So cholestyramine can be used to bind C. diff toxin. Now, we don't use cholestyramine as a primary treatment for C. diff, but it might be used as an adjunct for relapsing infections. The next drug is niacin. Niacin is one of the B vitamins. It's vitamin B3. And the primary use for niacin in treating cholesterol is to raise the HDL. Niacin raises HDL better than any of these other drug classes. But the side effects of niacin are somewhat unique. Niacin causes uncomfortable facial flushing in as many as 50% of patients. It's kind of like a hot flash. So to prevent that, you can have the patient take an aspirin or an NSAID, like ibuprofen, along with the niacin to kind of prevent that flushing reaction. You can also have the patient take their niacin at bedtime, which means they're not wide awake when the flushing is going on. Another tip is that the longer the patient stays on niacin, the less pronounced that facial flushing becomes. So try to encourage your patient to stick with the niacin and not give up, because that flushing will get better and better the longer they take it. And then finally, let's mention the omega-3 fatty acids. Omega-3 fatty acids are found in certain fish, and so patients may take an over-the-counter fish oil supplement, and there are also prescription omega-3 fatty acids. The main effect of omega-3 fatty acids is on triglycerides, and you can easily add these on to any of these other treatments. But the problem is that you have to take a lot of omega-3s to get much benefit. I've heard people say you have to take fish oil until cats are following you around the neighborhood. And then for side effects, patients will sometimes complain of a fishy burp. So they burp and they get kind of a fishy aftertaste in their mouth. Now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers. First question, which lipid-lowering agent matches each of the following descriptions? So side effect of facial flushing is niacin. Side effect of elevated LFTs and myositis is the statins, the fibrates, and possibly ezetimibe. Side effect of GI discomfort and maybe a bad taste in your mouth would be bile acid binding resins. The drug with the best effect on HDL is niacin. The drugs with the best effect on triglycerides are the fibrates. The drugs with the best effect on LDL and total cholesterol are the statins. And then the one that binds C. diff toxin is cholestyramine. Next, according to the 2013 AHA-ACC guidelines, which patients should be on statin therapy? These are patients with clinical atherosclerotic cardiovascular disease, including acute coronary syndromes, myocardial infarction, stable or unstable angina, patients who have undergone revascularization procedures, patients with a stroke or TIA, and patients with peripheral arterial disease. Another group would be patients with an LDL over 190, regardless of the absence of clinical atherosclerosis, patients with diabetes between 40 and 75 years of age, and patients with a 10-year atherosclerotic cardiovascular disease risk greater than 7.5% who are between 40 and 75 years of age. Because as you get older, that calculated risk gets very high. We're not going to start 85 and 90-year-old patients on statins. Last question. How can the flushing reaction of niacin be prevented? So you can give the niacin with aspirin or an NSAID. You can have the patient take the niacin at bedtime so that they can sleep through the side effects. And you can encourage the patient to tough it out and persevere. Even though it's uncomfortable at first, it usually gets better. And that's it for now. I'll see you next time.
Brah, you gotta start bringing some duct tape to the gym. 'Cause you're so ripped. What's the mechanism of action of statin drugs? They inhibit the enzyme HMG-CoA reductase, so they lower LDL cholesterol. What lab should you order before starting a statin? You check the liver function tests because statins can rarely cause hepatotoxicity. And it's also useful to order a baseline creatine kinase in case they get statin-induced muscle injury later on, although patients can develop muscle pain and weakness even without an elevated CK. Anybody thirsty? 'Cause I brought a six-pack.
Ready for another 3-question warm-up? Don't forget to answer the questions on your own first. So if you've already done that, let's go through the answers. First question says, which agents are used in a pharmacologic stress test for ischemic heart disease? So dobutamine is the classic drug used to stress the heart when the patient can't walk on the treadmill. But adenosine or dipyridamole can also be used under certain circumstances. Next, what are the most appropriate treatment options for elevated homocysteine? So it's controversial to use homocysteine for screening, but you can lower serum homocysteine levels by giving folic acid, vitamin B6, and vitamin B12. The last question, which medications can negatively affect lipid measurements? So this is a list worth knowing. Oral estrogens, thiazide diuretics, beta blockers, some of the atypical antipsychotics like clozapine and olanzapine are associated with obesity and hypertriglyceridemia and diabetes. And then the protease inhibitors can increase lipids as well. All right, that's it for now. Let's move on to the lecture.
Hello everyone and welcome to our Step 2 video on the diagnosis of ischemic heart disease. What's the biggest challenge to making a video? Knowing the material? No problem. Creating an engaging script? Easy as pie. Reading a teleprompter without pausing? Mostly good. Now the hardest thing is knowing what to do with your hands. You can't be too still because then you kind of look like a robot. You can't put them in your pockets because that looks creepy. And you really don't want to do the classic look at my boobs hands. But with enough practice, you too can be a professional looking lecturer like me. Okay, moving on. So let's talk about some ischemic heart disease. And we're going to talk about stable versus unstable angina. But before we get too far into the different types of ischemic heart disease, let's first talk about angina just in general. Now, most of you probably know that angina is chest pain, but a lot of things cause chest pain. Angina is chest pain that is associated with myocardial ischemia. And myocardial ischemia occurs when myocardial oxygen demand exceeds oxygen supply. So how does that occur? Well, in the vast majority of cases, this is due to atherosclerosis. Now, there is obstruction of blood flow to the myocardium. Now, other causes of decreased oxygen supply would include things like shock, hypoxemia, anemia, and coronary artery vasospasm, also referred to as Prinzmetal angina. Now, increased demand can also lead to angina, and this can occur with vigorous exertion, tachycardia, hypertension, ventricular hypertrophy, or increased catecholamines. So what are the typical clinical features of angina? Well, patients will describe their chest discomfort as a pressure sensation, or that something is sitting on their chest. Now, the location is usually left-sided or mid-sternal, but you can still have pain on the right side as well. Sometimes the pain will radiate to the back, or to the jaw, or to the left arm. Diaphoresis, shortness of breath, or palpitations can occur as well. Now, patients may present with atypical symptoms as well. Now, we see this more often in older patients, in female patients, and diabetic patients. Now, this can include just like generalized abdominal pain. You can get exercise intolerance, or even just kind of worsening generalized fatigue. So that's angina in general. So what is stable angina? Well, the word I want you to use and to remember is predictable. So these patients have predictable chest pain that resolves with rest. This pain begins at a certain level of exertion. Maybe it's jogging a certain distance or climbing a certain number of flights of stairs. But once they hit that level, they get that chest pain predictably. And then again predictably, they will have resolution of their chest pain after rest. And also, very important, these patients will not have initiation of their pain at rest either. So again, pain is predictable. So how do we diagnose stable angina? Well, these patients are less likely to present to the ER. They have milder symptoms and their pain is predictable and will resolve with rest. So most of the time I see these patients in my office and they tell me that they feel occasional mild chest pain when they exercise. So what's the best next step in the diagnosis of this patient? Should we immediately send them to the ER? Probably not, depending on how bad it is. If they have a normal exam, if they're asymptomatic and the history is reassuring. Should we get a resting ECG? Well, it would probably help to rule out an ST segment MI right then and there, but it will likely be normal because they have no symptoms or ischemia while resting comfortably in your office. So the next best step is going to be a stress test. And this can be an exercise or a pharmacologic stress test depending on their exercise tolerance. Labs, including things like fasting glucose, lipid panel, can also help diagnose other comorbidities. Now, the cardiac enzymes are always normal with stable angina. But to be clear, if you see a patient in the ER and they have what sounds like stable angina, you're still going to order the cardiac enzymes, you're still going to get the ECG to make sure they're not having atypical symptoms related to an MI. Now, what about unstable angina? Well, unstable angina is unpredictable chest pain that can occur at rest. Now, where stable angina was predictable, unstable is obviously unpredictable. Patients can be on their couch watching Thundercats, and out of nowhere, chest pain occurs. Now, this pain also occurs during exertion, but again, it's a bit more unpredictable. Maybe one day it starts after climbing 2 flights of stairs, but today it's happening just walking from the car to the grocery store. Now, usually this pain is more severe and lasting longer, 5 to 20 minutes, and is frequently caused by plaque rupture or hemorrhage or thrombosis in the coronary arteries. Now, this is important. 1/3 of these patients will have an MI within 3 years. Therefore, unstable angina is a very serious problem. Now, the physical exam for both stable and unstable angina can be completely normal, and any symptoms are usually nonspecific, like tachycardia, tachypnea, diaphoresis. The ECG can be normal for both stable and unstable angina. Sometimes in unstable angina, you can see some ST segment depression. So how do we diagnose unstable angina? So another patient comes into the outpatient clinic, my clinic, and they complain of unstable angina. What is the next best step here? Well, do we do the same thing as stable angina? Well, the answer is no, not really. With unstable angina, we give the patient an aspirin to chew up and swallow, and then we transport that patient to the emergency department. You can't tell the difference between unstable angina and an MI early on. Therefore, you have to work them up in the hospital. So what do we do there? Well, we won't go into the initial treatment yet because we'll cover that in the next video. But patients will have that initial ECG to look for signs of ischemia, and cardiac enzymes will be drawn as well. Now, both will be normal, or at least not show signs of acute ischemia or any ST segment elevation. Now, after the patient is stable and pain-free, then you can go a couple different directions. Many clinicians are going to order a stress test in the very near future, maybe even the next day. If the clinical suspicion is high enough, then some patients may even go for a cardiac catheterization right then and there. Next, we need to see how non-ST segment and ST segment elevation MIs fit into our ischemic heart disease definitions. So in both stable and unstable angina, there's not an appreciable amount of myocardial cell death. Yes, there is chest pain, and the long-term prognosis is not very good, but there isn't much cell death occurring at that very moment. Now, when a myocardial infarction occurs, there is now a significant amount of permanent myocardial cell death. So this is generally due to occlusion of the coronary vessels secondary to thrombus formation following a plaque rupture. Now, the symptoms are generally more severe when compared to stable or unstable angina. Most will present with chest pain. Classically, this is going to be that pressure sensation again, like someone sitting on their chest, but maybe it's going to be even more. The pain can radiate to the jaw, to that left arm again, or to the neck. Patients often have shortness of breath, diaphoresis, nausea, and vomiting, and most patients have this sort of feeling of impending doom or that they're going to die, because they kind of are. Examination findings might be a little more interesting this time. It may include things that are generalized like tachycardia, decreased or increased blood pressure, but you might hear some pulmonary ralls at this point. You might hear a new S3 or S4, maybe a new systolic murmur. Well, most of this, again, still mostly could be followed along with unstable angina, very similar symptoms. How can you tell the difference? Well, because now we have that myocardial cell death, we're going to see an elevation in the cardiac enzymes like troponin I and CKMB. Those enzymes are going to be normal in our stable and unstable angina, but abnormal with a myocardial infarction. So now, how do we diagnose a STEMI, or a ST segment elevation MI, to an NSTEMI, that non-ST segment elevation MI? Well, these again should be worked up in the emergency room. Patients are going to get an initial ECG. In fact, in the first 6 hours of symptoms, ECG is going to be the gold standard. That means that if you see ST segment elevation, then you have the diagnosis of that STEMI, and you can proceed to reperfusion treatment with either thrombolytics or cardiac catheterization. Now, the cardiac catheterization will determine where that occlusion is located, so which coronary artery, and the severity of that occlusion as well. Now, you don't have to wait for enzymes at that point. If it's early in the course of an MI, then the cardiac enzymes might actually still be negative anyway. Now, the other ECG abnormalities that can make the diagnosis of a STEMI is if you see a new left bundle branch block on that ECG. So this is where you're having an old ECG can be very, very helpful. You want to know if that left bundle branch block is new or old. If it's new, then again, you can proceed straight on to treatment. Now, if that initial or subsequent ECG shows maybe no ST segment elevation, but the cardiac enzymes are abnormal, then you have the diagnosis of the non-ST segment elevation MI. And the next step is usually cardiac catheterization to again locate that occlusion, then try to treat it. Now we've defined most of the common types of ischemic heart disease. Stable angina is predictable chest pain. Unstable angina is unpredictable, but normal cardiac enzymes. A non-ST segment MI has that elevated cardiac enzymes, but no ST segment elevation on the ECG. And then, of course, our ST segment elevation MI does have that specific ECG change. Okay, so now let's go into more detail on the cardiac enzymes. So what are the cardiac enzymes? Well, these include most popularly troponin I, CK&B, and then just good old CK or CPK. Now, as far as which are more specific for an MI, that CK or CPK is going to be elevated with just about any type of muscle damage, very nonspecific. Now, CK&B is more specific to cardiac muscle, but other types of muscle breakdown can still have some mild elevations in CK&B. The troponin I is going to be the most specific one. It rises after about 4 hours and is elevated for 1 to 2 weeks. Now, it's more specific than the other protein markers, and we use it a lot. So consequently, we really use that troponin I more than any other cardiac enzyme to make the diagnosis of MI because it pops up sooner, sticks around a lot longer than these other ones. If the first set is negative, then you're going to recheck another set of cardiac enzymes in maybe 3 to 6 hours, depending on your protocol, and then you will also get a third set as well. Now, be aware that there are other conditions that can elevate cardiac biomarkers, things like heart failure, rapid AFib, myocarditis, and even sepsis. So be sure to use your brain and look at the whole picture, including patient history, ECG, and cardiac enzymes. Okay, so now let's cover some more detail on ECGs themselves in relation to MI. So first, let's go over the evolution of a myocardial infarction on ECG, or at least the most ideal looking one. So it starts off with a normal ECG. You have your QRS segment and T waves normally elevated. And then with an acute MI, you can have an ST segment elevation. So that's what you're going to see. So as we said previously, there are different classifications of MI. Over here, we're looking over that classic ST elevation MI. So this is called tombstoning on the ECG. You would also see that in Prinz metal angina potentially as well. Now within hours, you might start to see a Q wave, and an R also decreases some as well. The Q wave is that first negative depression there. And sometimes you don't see the Q wave for about a day. And then on days 1 to 2, you're going to have T wave inversion. And Q waves are going to become deeper. Days later, ST segments are going to normalize, but the T wave remains inverted. And then weeks later, the ST and T waves are normal, but the Q wave persists. So these are the classic changes associated with an MI. Now, of course, in medicine, not everything is classic. And ideally, when you're looking at an ECG, you need to compare it to a previous ECG. You want to see if these changes are new or if they were present in the past. And so how often are you going to see these very, very classic ECG changes in an MI? Well, unfortunately, about 50% of the time when the patient is having an MI, will you see those ECG changes. So with that, if you see something on the ECG, you can make that diagnosis, but don't rely on it completely. Okay, now another important aspect of the ECG is determining the rough location of the MI. So first, anterior wall MIs may have abnormalities in V2, V3, V4, and then maybe sometimes V5. Now it's important to know which leads are associated with certain MI. So V2, V3, V4 is an anterior wall MI, and this area of the heart is supplied by the left anterior descending coronary artery. Now, if you have V1, V2, and V3 being abnormal, then this might indicate a septal MI, which is also supplied by that left anterior descending. If 2, 3, and AVF are abnormal, those are your inferior limb leads, which would potentially indicate an inferior wall infarct. The posterior descending artery will supply your inferior wall of your heart. And then we have 1 AVL, V5 and V6, that's going to indicate a lateral wall MI, which may indicate an LAD or maybe a circumflex occlusion. Okay, so those are your major characteristics of the most common types of ischemic heart disease. I want to switch over to yet another type of angina called Prinz metal angina, also known as variant angina. So this is a very different type of angina. It's not due to what we talked about before, atherosclerosis, but rather from coronary artery vasospasm. Now, smoking is a major risk factor here, and we tend to see this in patients less than 50 years of age. That is another very big difference when compared to our ischemic heart disease patients due to atherosclerosis. Prinz metal angina is also seen in patients with fewer coronary artery disease risk factors like hyperlipidemia and diabetes, but the one exception is smoking. That's still very high risk there. Now, chest pain usually occurs at rest and often in the middle of the night. And the chest pain is indistinguishable from classic angina. And each episode tends to last between about 5 and 15 minutes. Now, diagnosis will likely require significant investigation. So during the episodes of chest pain, the patient will often still have ST segment elevation on that ECG. Therefore, patients will likely go through a full MI workup, including a cardiac catheterization. So the diagnosis is made when the patient has these recurrent episodes of chest pain, especially at rest, if they have some transient ST segment elevation on ECG, but the big thing is no sign of high-grade coronary artery stenosis on coronary arteriography. So everything looks like a traditional ST segment elevation MI, but when you do the cath, there isn't much blockage in the coronary arteries. Okay, so that takes care of another type of angina. Remember that we'll cover all the treatments for all these problems in the next video. Next, I want to spend just a little bit of time discussing other causes of chest pain. Chest pain is very nonspecific. Many things cause chest pain. There are certain characteristics that should clue you in to that cause of chest pain. So I want to go through some high-yield chest pains that you might see on your test. Now, the most common cause of chest pain is musculoskeletal, or you could probably make an argument for GERD, gastroesophageal reflux disease. Now, in some types of musculoskeletal pain, patients will have inflammation of the cartilage that connects the ribs to the sternum, and that's called costochondritis. Patients will be able to kind of localize that pain to really very one specific point. Now, things like GERD, gastroesophageal reflux disease, and esophageal spasm can also mimic angina pretty well as well. Now, one thing about esophageal spasm is that nitrates will relieve symptoms of esophageal spasm. So you might be tempted to say, well, if the chest pain is relieved by nitrates, then that indicates that this is a coronary artery disease. But nitrates, again, will also relieve that pain due to esophageal spasm. So you can't rely on nitrates to diagnose coronary artery disease. So what are your other causes of chest pain as well? Cocaine intoxication, hyperventilation, herpes zoster, aortic stenosis can cause chest pain, trauma, pulmonary embolism, pneumonia, pericarditis, pancreatitis, angina, aortic dissection, aortic aneurysm, infarction as well. Neuropsych diseases like depression and anxiety can cause all that type of stuff as well. So it's definitely high yield for your test to be able to evaluate sort of those different scenarios, identify what's causing the chest pain based on those very specific clinical scenarios. So let's get some practice with this. Look into your study guide here. ST segment elevation only during brief episodes of chest pain. That's going to be Prinzmetal angina, or also called variant angina, coronary vasospasm. Next, we have the patient is able to point to localize the pain using just one finger. That's going to probably be musculoskeletal type of chest pain. So this could be something like costochondritis. Next, we have chest wall tenderness on palpation, also musculoskeletal pain. If you have a lot of tenderness there, you got to think about that. So in your physical exam, you're presenting with chest pain, make sure you press on that chest wall to rule out musculoskeletal pain. Next, we have rapid onset sharp pain that radiates to the scapula. That's pretty classic for aortic dissection. So this pain radiates to the scapula, or might radiate to the back with aortic dissection. Rapid onset of pain in a 20-year-old and associated with dyspnea. Think about a spontaneous pneumothorax in that case. So spontaneous pneumothorax tends to be more common in our young, thin males. Occurs after heavy meals and improves with an AS. That's going to be GERD, or it could be esophageal spasm. It's really severe, but don't get too overconfident. You still need to work up these patients for ischemic heart disease. Next, we have sharp pain lasting hours to days and is somewhat relieved by sitting forward. That's very classic for pericarditis. Next, we have pain made worse by deep inspiration or motion would be musculoskeletal pain or pleuritic chest pain, and which is that pain from the irritation of the lining of the lung. Chest pain in a dermatomal distribution, that's going to be herpes zoster. Most common cause of non-cardiac chest pain, again, think about things like GERD or musculoskeletal. Next, we have acute onset dyspnea, tachycardia, and confusion in a hospitalized patient. A little non-specific here. Anytime you hear those three things, I do want you to think of a pulmonary embolism. Pain began the day following an intense new exercise program, ease asking musculoskeletal. Widened mediastinum on chest x-ray would be aortic dissection. So anytime you see a widened mediastinum on chest x-ray, the next step is probably a CT scan of the chest, and that's going to assess for an aortic dissection. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through that together. First question, what are the defining characteristics of stable angina, unstable angina, an ST segment elevation, myocardial infarction, and a non-ST segment MI? So let's go through that just real quick. Definition-wise, stable angina, remember, predictable chest pain during exertion, resolves with rest, normal cardiac enzymes. Unstable angina, unpredictable chest pain, more severe, can occur at rest, still normal cardiac enzymes. ST segment elevation MI. ECG shows the ST segment elevation, the tombstoning, and abnormal cardiac enzymes. And then we have the non-ST segment elevation MI. Remember, no ST segment elevation. You might have some ECG changes, no tombstoning, and you're still going to see abnormal cardiac enzymes. Next question. Which patients are more likely to have atypical angina or no angina during an episode of myocardial ischemia? So we see this a lot more often in older patients, in female patients, and diabetic patients. Now this can include things like abdominal pain, exercise intolerance, or even just worsening generalized fatigue. Next, what is the gold standard for diagnosing a MI within the first 6 hours of chest pain? Remember, it's ECG. Early in the process of working up chest pain, you will rely on the ECG to decide whether or not that person needs to immediately go to the cath lab or if fibrinolysis is appropriate as well. After that, you're going to rely a lot more on cardiac enzymes. Next, what are the defining characteristics of Prinzmetal angina? So remember, it's due to coronary artery vasospasm, not atherosclerosis. You're going to see it in younger patients. It's often occurring at night. The risk factor is going to be smoking, and then of course the big thing is no high-grade coronary artery stenosis on coronary arteriography. All right guys, that brings us to the end of our lecture. I hope you learned something. I'll see you next time.
Let's go through the 3-question warm-up. First question. A 55-year-old man comes to the physician with his wife after receiving a report from a health screening the patient had after his lunch break at work. The report shows an elevated LDL, triglycerides, and total cholesterol. So what's the most appropriate next step? So you might be tempted to start this patient on a statin or another lipid-lowering drug. But before you do that, you want to check a fasting lipid profile. This patient's most likely eaten both breakfast and lunch before he had his lab work drawn. So the most accurate way to test serum cholesterol is after an 8 to 10 hour fast. So don't jump the gun here and start treatment based on non-fasting labs. Next, what's the utility of homocysteine screening in atherosclerosis? So elevated homocysteine is an independent risk factor for stroke, peripheral vascular disease, and coronary heart disease. But the caveat here is that most experts do not advise routinely checking homocysteine levels for screening the general population for atherosclerosis. And the last one, what are the physical signs of hypercholesterolemia? Well, you can see xanthomas, which are lipid deposits in the skin. You can see xanthelasmas, which are lipid deposits around the eyes. And there's also arcocinilis, which are lipid deposits in the corneas. And these physical signs are usually seen in individuals who have familial hypercholesterolemia. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 2 video on the treatment of ischemic heart disease. Let's get going on this one. So we already know how to identify our ischemic heart disease. Now it's time to keep people alive. So first, let's talk about the treatment of stable angina. Now recall that stable angina is that predictable chest pain that resolves with rest, doesn't initiate during rest either. Now there are 3 classes of anti-ischemic drugs that are used for angina. They are beta blockers, calcium channel blockers, and nitrates. So let's go through all these. So first we have our beta blockers. They act by decreasing heart rate and contractility. Now why do we do this? Well, this is going to reduce oxygen demand and thus decrease anginal symptoms. Now all types of beta blockers appear to be equally effective. And beta blockers have been proven to prevent reinfarction and improve survival in patients who have the big ones, the big MIs. Now what about our calcium channel blockers? Well, calcium channel blockers work by promoting coronary and peripheral vasodilation, and they reduce contractility as well. Diltiazem, verapamil, amlodipine, and felodipine are the preferred drugs. Now generally, we use the calcium channel blockers when a beta blocker is either ineffective or they can't be used because of some other contraindication. Now they can be used in combination with beta blockers, but you do need to watch out for heart block when you use both of those classes together. And then we have our nitrates, things like nitroglycerin. So sublingual nitroglycerin should be used for acute symptoms. Long-acting nitrates can be used and even added to beta blockers to help control angina over the long term. Now these can be taken long term, but we do see nitrate tolerance over time. Now, a common misconception is that nitrates work primarily by dilating coronary arteries. Now, nitrates actually do not dilate your coronary arteries that much during an episode of ischemia. Now, why is that? Well, when you're having ischemic chest pain, your coronary arteries are already going to try to be vasodilated as much as possible. So how do nitrates then affect very quickly in reducing that angina? Well, nitrates also work by causing that peripheral venous vasodilation, and that's going to actually decrease your preload. And by decreasing your preload, you're decreasing your oxygen demand of the heart, that work of the heart. So now let's move on to the treatment of unstable angina and those myocardial infarctions. So we're talking about unstable angina, and that's going to include the non-ST segment elevation MIs and the ST segment elevation MI. So why are we grouping all these together? Because they're all different diagnoses, right? Well, the initial treatment for all three of these is going to be the same. And some of these treatments are going to be implemented even before that diagnosis is even confirmed. Now, these patients have worrisome chest pain, and the quicker you start treatment, the better the outcome. Now, you may also hear these three grouped together and referred to as acute coronary syndrome. Don't get confused by that. Acute coronary syndrome is really just referring to acute chest pain like unstable angina, a non-ST segment elevation MI, and an ST elevation MI. So let's go through the initial management of acute coronary syndrome. Well, first, you're always going to start with that ABC, so airway, breathing, circulation. Make sure they don't need to be intubated if they're horribly ill. Every patient will certainly need IV access and in more than one site. And then the next thing we need to remember is MONA. That's our mnemonic here. MONA is going to start first with morphine, so IV morphine. Why are we using this? Well, this will decrease the stress of the patient. It's going to decrease the pain too, which may also decrease that cardiac oxygen demand. And then also the O is going to be supplemental oxygen, but we're only going to use supplemental oxygen if there's hypoxemia present. You're not just going to give it to everyone. Next, we have nitroglycerin, and nitroglycerin is going to decrease, again, that preload and the blood pressure, ultimately that oxygen demand on the heart. And then finally, on MONA, the last part of that A is going to be aspirin. Our next group of drugs that we're going to use for our acute coronary syndrome is going to be beta blockers. And this is only going to be if there's no signs of heart failure. If they have terrible heart failure, then you have to avoid those beta blockers. So what are our beta blockers going to do? They're going to decrease our blood pressure, they're going to decrease contractility and heart rate, and then consequently decrease oxygen consumption. That's always our goal here. Now, beta blockers will decrease the end diastolic volume and ejection time as well. And most importantly, it's going to decrease mortality following an MI. Now, you do have to be careful when using the beta blockers in patients with COPD or asthma because of the risk of bronchospasm with beta blockers. Also be aware that beta blockers will sometimes block the effects of hypoglycemia in your diabetic patients. Next, let's talk about adding on statins. So statins, that HMG-CoA reductase inhibitors, those should be instituted prior to discharge after someone's been diagnosed with one of these diagnoses. But some data actually supports starting that statin immediately at the diagnosis, even before you get to something like a PCI, a percutaneous intervention. Now, the medicine we're going to use most often is going to be atorvastatin, 80 milligrams. Our next step is going to be an antiplatelet drug, and this is an antiplatelet drug in addition to aspirin, so not including aspirin. This is in addition to aspirin. And the medicines that we use most often are going to be clopidogrel and ticagrelor. Now, for patients who are maybe at very high risk, so maybe this is recurrent ischemic pain, maybe this is dynamic EKG changes that you're seeing, or maybe a hemodynamically unstable patient, you might add on an additional antiplatelet medication like a GP2B3A inhibitor. So that's going to be things like eptifibatide or tyrofibin. Now, those are going to be really patient specific. I don't think you probably need to know that level of detail for your test. Next, we're going to give an anticoagulant to all patients. Unfractionated heparin to all patients undergoing a possible future PCI, that percutaneous intervention like going to the cath lab and having something done. You might use something like enoxaparin, a low molecular weight heparin, for patients that are not going to be managed with some sort of invasive intervention like PCI. Why the difference there? Well, you don't want to be overly anticoagulated if you're going to take someone to the cath lab. Now, you can turn off unfractionated heparin relatively quickly, and then, again, relatively soon, that bleeding time will normalize. Enoxaparin will last a lot longer, so you try not to use that unless you're confident that you're not going to need that cath later on. And then the final thing we're going to do is make sure you're monitoring your electrolytes. You want to administer potassium and magnesium. You want to keep that potassium above 4 and magnesium above 2. So any heart disease patient, especially someone who's having maybe a heart attack, you want to keep them at above these levels because the big risk is for an arrhythmia. And we'll talk about later about complications to our MIs. All right, so that's the initial management of acute coronary syndrome. So next you need to decide, is this unstable angina? Is this an ST segment elevation MI or a non-ST segment elevation MI? Now, if the cardiac enzymes are normal, then you're likely dealing with that unstable angina. Then you're probably done, at least in the short term. Except that patient will probably need further studies, like a stress test, or maybe even a cath in the near future. Now, if it's a STEMI, that ST segment elevation MI, then you have to pick a reperfusion strategy. And we only have really two ways to go here. So how do we get blood into the coronary arteries and perfuse that heart? Now, our percutaneous coronary intervention, the PCI that we've been talking about a little bit here, going to the cath lab is strongly preferred, especially for patients with any cardiogenic shock, any heart failure, late presentation, or in any contraindications to fibrinolysis. Now, if that PCI or the cath lab is unavailable, maybe you're out in the middle of nowhere, then you're going to treat with fibrinolysis as soon as possible. However, there are a bunch of exclusionary criteria that you need to go through for that fibrinolysis, but you don't need to memorize all those for your test. Now, in an MI, you can give thrombolytics up to 12 hours after the onset of symptoms. If you're in the middle of nowhere again, then sometimes you can even give that up to 24 hours depending on the situation, but that's still, again, situational. Now, don't get this confused with strokes. With ischemic strokes, you have to give thrombolytics within the first 3 to 4 hours. Now, speaking back on MI, sooner is always better. The ACC/AHA recommends a door to needle time of 30 minutes for the best results. So from the time that patient hits the emergency room door, no more than 30 minutes before that thrombolytic is then administered. So you really need to act fast. Now, the thrombolytic agents used most often nowadays are going to be alteplase, retiplase, and tenecteplase. Now, one wrinkle in all this is that we avoid fibrinolysis in patients with a non-ST segment elevation MI. Fibrinolysis is only for our STEMIs. The N-STEMIs or non-STEMIs will go to the cath lab, but no thrombolytics, even if the cath lab is unavailable for those N-STEMIs. Now, if significant coronary artery disease is found on that cath, then the patient may receive percutaneous transluminal coronary angioplasty, which is just kind of a long way of saying stenting, or if severe, then patients may be a candidate for a coronary artery bypass graft. So let's talk about this in a little bit more detail. So again, that PTCA stands for percutaneous transluminal coronary angioplasty, and that's most commonly done with stenting of the artery. So first, you do an angiogram, which takes a picture of the luminal diameter of the coronaries. Now you insert a catheter into that femoral artery, pass the catheter up through the aorta to the coronary arteries. And then you inject IV contrast into the coronary arteries so you can see stenosis or narrowing of that artery. Now, to perform an angioplasty, you then insert a wire and a balloon through that stenotic lesion and then inflate the balloon with saline. So that then balloon is going to force open the area of the stenosis. And then sometimes you'll put an expandable wire mesh tube called a stent over that balloon, and then when you inflate the balloon again, you expand the stent. Now, when you withdraw the balloon and the catheter, the stent stays in place and holds the stenotic area open. After a catheterization, there's a significant coronary artery disease present, then the patient again might benefit from a coronary artery bypass graft. So this is considered in patients who have a greater than 50% stenosis in the left main artery, if they have 3-vessel disease, or a failed attempt at that PCI, and then you're still resulting in ongoing ischemia. But overall, again, that PCI, going to the cath lab, is going to be the preferred method of revascularization. Now, a coronary artery bypass graft is a vein, usually the saphenous vein, taken from the patient's leg. You create a graft that diverts blood around the stenosis, so you are literally allowing blood to bypass the stenotic lesion. Or sometimes, instead of using a vein, you'll use the internal mammary artery, which already has arterial blood supply, and you then connect it distal to the stenosis. All right, so next, I want to spend a brief amount of time discussing some of the anticoagulants and the antiplatelet drugs that are being used in the treatment of myocardial ischemia. So this is likely not the only place where you're going to see these drugs in our course, therefore we're really just going to hit the highlights here. So the first drug we're going to talk about is aspirin. Aspirin is the most commonly used med in ischemic heart disease. So aspirin is a COX-1 and COX-2 inhibitor, and the inhibition of COX-1 is going to lead to the inhibition of thromboxane A2. And without that thromboxane A2, platelets can't aggregate. Next, we have the adenosine diphosphate, or the ADP receptor blockers. Now, the big ones that we've talked about so far are going to be clopidogrel. Also, ticlopidine is another one. Prasugrel is one, and then ticagrelor. Now these block the P2Y12 receptor on the platelets, and again, it's going to prevent those platelets from aggregating. And then the next class are going to be the glycoprotein 2B3A inhibitors, so abciximab, eptifibatide, and tirofiban. So these also work again, we're inhibiting platelet aggregation. So switching gears here, let's talk about heparin. So heparin catalyzes the activation of antithrombin. So this is not an antiplatelet drug, but rather an anticoagulant. And then we have its cousin, the low molecular weight heparin. Enoxaparin is an example there. That's again going to catalyze the activation of antithrombin. It's going to last longer than traditional heparin. And then a very commonly used medicine, warfarin. So warfarin is a vitamin K antagonist, which is critical for the formation of clotting factors 2, 7, 9, and 10. And then finally we have our thrombolytics, so alteplase, reteplase, tenecteplase. These are the recombinant versions of TPA, or tissue plasminogen activator. So they act to convert plasminogen to plasmin, which is the major enzyme that's going to do a lot of breaking down of our clots. Okay, so we covered a lot of detailed material regarding the acute treatment of acute coronary syndrome. Let's review it again in a Lewis Notes. All right, everyone, we're going to go over acute coronary syndrome treatment one more time. We're going to do a real attenuated version, just a listing of what you're going to do when you see someone coming in with chest pain. And remember that acute coronary syndrome is just going to talk about unstable angina, a non-ST segment elevation MI, and then a regular old STEMI as well. So let's go through this. You might want to write this down yourself just to get it into your brain. All right, so what's the first thing you're going to do when someone's coming in with these types of diagnoses? Remember, it's our ABCs. So ABCs, just like everything else, airway, breathing, circulation. And then our next mnemonic is going to be MONA. So remember, MONA was morphine. And there's a little bit of controversy about morphine, but people are still giving morphine to decrease that pain and to potentially decrease some of the oxygen demand on the heart. You're going to give oxygen, but that comes with a caveat there. You're only giving oxygen to patients who have hypoxemia. Nitroglycerin to everyone. That's going to decrease that preload and decrease oxygen demand. And then aspirin, antiplatelet is there. What's the next thing that we're going to do? The next thing that we're going to do is a beta blocker. So beta blocker, we're using oftentimes metoprolol is a commonly used beta blocker we use there. Again, it's going to decrease contractility, decrease the rate, decrease oxygen demand. So that's what we're going for here. The next step is going to be a statin. And a statin has been shown to improve overall statistics with heart attacks. And usually we're using something like atorvastatin, 80 milligrams. The next thing we're going to do is we're going to do an antiplatelet. So antiplatelet, and this is in addition to the aspirin. So this is plus something like clopidogrel or ticagrelor, one of those two, and that's in addition to our aspirin. And then our next thing is going to be anticoagulation. So anticoagulation, and that's again with all patients. And what are you going to use here? Remember, if you're going to go to the cath lab, you want to use something that you can turn off. So unfractionated heparin would be the first thing that you're going to think of. And you're probably going to use that most of the time. Now, say if you're out in the middle of nowhere or you have no chance of getting this person to the cath lab, then you could potentially use low molecular weight heparin in that situation. And then the next thing you're going to do is you're going to look at your potassium and your magnesium. So you want to make sure your potassium and magnesium are in decent shape. Why is that? Well, you want to decrease any possibility for arrhythmias. And remember, arrhythmias are a primary cause of death soon after a heart attack. So what are you going to do next? Well, next you're going to figure out what's going to be our reperfusion strategy. So most patients are going to be going to the cath lab, and that's especially if you have an in-STEMI or a STEMI. You're going to go in there and potentially you're going to go and do a stent if you find something that's occluded there. If you see tons of disease and you're like, well, stents just aren't going to do it, then potentially you're going to go to bypass. Now, there's another option here. Say if you have a STEMI, then you might want to think about thrombolytics. Now, remember how we said before, thrombolytics are only for STEMIs. They're not going to be for our non-ST segment elevation MIs, and you're definitely not going to use it for unstable angina. So that's just the real quick and dirty here. ABCs, MONA, beta blockers, statins, antiplatelet drugs, anticoagulation, potassium, magnesium, and to the cath lab to either get stents or maybe going all the way to bypass if they're in bad shape. And then thrombolytics is only going to be for our STEMI patients. All right, so that's just the real quick acute coronary syndrome treatment. Okay, so next, let's talk about the long-term management of myocardial infarction. Now, there can be a great deal of variability between patients, but if there's no contraindications, then most patients are going to continue many of the same medications that were started in the hospital. So these patients need to be on aspirin. They're also going to need to be on clopidogrel, probably indefinitely. That's going to depend on the scenario, did they get a stent or not. Now, beta blockers, ACE inhibitors, or even angiotensin receptor blockers are almost always used for long-term management after an MI. Potassium-sparing diuretics are also important, specifically an aldosterone antagonist like spironolactone. The HMG-CoA reductase inhibitors are statins, will be continued in almost every patient. Now, many of these medications have been shown to actually decrease mortality after an MI, and they include those beta blockers, the ACE inhibitors, and aspirin. And then sort of the no-duh stuff, exercise, smoking cessation, dietary modification are all important for risk reduction. So now let's talk about MI complications. What happens after you have an MI? What type of things can go wrong? So the biggest one is going to be cardiac arrhythmia. So this is common in the first few days after an MI because there's electrical irritability of the heart after that MI. Now, what's the most common lethal cardiac arrhythmia after an MI? It's going to be ventricular fibrillation. Got to remember that one. Next, we have the left ventricular failure and pulmonary edema. So the heart, if you on a big enough MI, is going to lose enough muscle in areas to actually decrease its overall function, and then you start to actually see a decrease in that ejection fraction. Then you end up with congestion in the lungs. Next, we have cardiogenic shock. So if a large infarct takes place, you can actually have very high mortality at this point. Basically, that goes back to that left ventricular failure. If the heart is not pumping blood, not perfusing well, then you're going to have low blood pressure. So it's just kind of a faster version of the first failure of the heart. Next is a ventricular free wall rupture. So this occurs when macrophages move into the area of an infarct and then they start degrading that scar tissue and remodeling things. Unfortunately, this leads to a weakened wall in some cases, and that wall can then rupture. You can get actual bleeding into the pericardium then, and this can cause a lot of cardiac tamponade. Next, you can have rupture of the papillary muscle. So how is that going to present? Well, it's going to present as severe mitral regurg. So be able to tie that together. If you see a patient with an MI and then maybe 5 days later you start hearing a very severe mitral regurg murmur, you need to suspect a rupture of the papillary muscle. Now, another complication is the interventricular septal rupture. This is going to cause a VSD, and of course that just makes sense. You're basically just breaking through the wall, separating the ventricles, and depending on the size will dictate how many symptoms you see. And then we have aneurysm formation. So after an MI, some of that heart muscle is replaced with scar tissue, and over time that weaker scar tissue can then balloon out and form an aneurysm. Next, we have fibrinous pericarditis. That can occur post-infarction, and that would present with a friction rub, and the timing is important here, maybe 3 to 5 days after an MI. And that can be very painful to the patient. Again, with pericarditis, sometimes that pain is actually somewhat relieved by leaning forward. And then we have an interesting one called Dressler syndrome, a very unique phenomenon. This is actually autoimmune, and it's resulting, in a fibrous pericarditis, but the timing is different here. It's several weeks after an MI. The fibrinous pericarditis we just talked about occurred maybe only 5 days after an MI, but Dressler syndrome occurs several weeks after an MI. And then finally here, let's talk about our outlier here, the treatment of Prinzmetal angina. So remember that Prinzmetal angina is caused by coronary artery vasospasm. So what are we going to do? Well, first, smoking cessation. Remember that smoking was the #1 major risk factor for Prinzmetal angina. How are we going to treat this otherwise? Well, 2 classes of medications are used. They're going to be the calcium channel blockers and the nitrates. Now, both are going to promote vasodilation in both the coronary arteries and in the periphery. So calcium channel blockers are generally used first line, and diltiazem is going to be the one that we most often choose to start with. Now, patients should actually avoid certain medications. They got to avoid non-selective beta blockers like propranolol because they can actually exacerbate vasospasm. Things like triptans that are used for migraines should also be avoided because they are associated with coronary vasospasm as well. And then even aspirin should be used with caution at low dosages because it actually inhibits prostacyclin. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through those answers together. First question, what is the benefit of beta blockers in patients with something like unstable angina? Well, beta blockers, as we've talked about before, decrease heart rate. They're going to decrease blood pressure, resulting in a decrease in oxygen demand. So beta blockers have been shown to decrease mortality in patients who have suffered a myocardial infarction. Next, in what time frame do thrombolytics need to be given in an MI? How does this differ from the time frame in which they need to be given for a stroke? So remember, in MI, the big number you got to remember, you can give thrombolytics up to 12 hours in most cases after the onset of those symptoms. With ischemic stroke, you have to give those thrombolytics within the first 3 to 4 hours. Now again, sooner is always better. Remember that AHA recommendations that door to needle time of about 30 minutes for the best results. So from the time the patient comes in the door, no more than 30 minutes until they're actually giving that thrombolytic. So you got to move fast. Next, what is the most common cause of death in patients with an acute myocardial infarction? So remember, it's going to be arrhythmias, and it's going to be ventricular fibrillation. So when someone just drops dead of a myocardial infarction, it's generally because of an arrhythmia. VFib is rapidly fatal because it deteriorates to asystole. Next, when should oxygen be used in a patient with suspected cardiac ischemia? So it used to be we'd give oxygen to everybody, but now it's only if the patient is experiencing hypoxemia. We don't give O2 to everyone anymore. All right, guys, that brings us to the end of our lecture. I hope you learned something. I'll see you next time. Hello, everyone, and welcome to another 3-question warm-up. Let's get going. First question here, which lipid-lowering agent is most likely to cause facial flushing? Well, that facial flushing is going to be a side effect of niacin. Next, which patient populations are most likely to experience atypical angina symptoms? That's going to be your older patients, female patients, and then diabetic patients. Next, what is the difference between the presentation of stable angina when compared to unstable angina? So remember, stable angina is predictable pain. It's also going to resolve with rest. That unstable angina is very unpredictable pain. It's going to be more severe, and it's also going to occur at rest. All right, guys, that's it for the warm-up. Let's get to that lecture now.
Well, it's the moment you've been waiting for. My first full video in the Step 2 course. I know, try to contain your excitement. In this video, we're going to talk about valvular heart disease and heart murmurs. Now, one important valvular pathology that we're not going to cover in this video is infective endocarditis. That's covered in another video. But valvular heart disease is a 5-star topic for Step 2. Remember, that means you can expect multiple questions on valvular disease, where you're asked to either diagnose or manage a patient with a valvular lesion. And you should expect at least a couple of audio questions, but don't panic. You don't have to be an auscultation expert. Usually you can just read the clinical scenario in the question stem and then move the stethoscope around on the illustration of the chest and be able to figure out the location where the murmur is best heard, and then be able to tell if it's systolic or diastolic. And those are the 3 things that are really going to help you. Number 1, what's the clinical scenario? Number 2, what's the location of the murmur? And number 3, is it a systolic murmur or a diastolic murmur? And nearly all the time you're going to be able to answer the question just based on those 3 pieces of information. So I'll highlight that information for you as we talk through all these heart murmurs. Now, one piece of advice I have is to play with the NBME practice software before you go in for your exam, so you know how to click on the different areas of the chest, you know what you're looking for, what you're listening for. The software actually has an illustration of a patient's chest, and you can click on the aortic position or the mitral position or whatever, and the sound you hear is going to change according to where you've placed your stethoscope. And then there's a separate window with a computer-animated patient. You can sort of see the chest rising and falling as the patient breathes, so you can pay attention to whether the murmur is louder with inspiration or whether there's paradoxical splitting of S2 or wide splitting or whatever. It's fairly sophisticated software, but it's not meant to be tricky. You need to know where on the chest different valves are generally best heard. A student suggested in the mnemonic, all patients take medication for aortic, pulmonic, tricuspid, and mitral. So when you listen at the right second interspace, you're listening to the aortic valve. When you listen to the left second interspace, you're listening to the pulmonic valve. The left lower sternal border is where you hear tricuspid murmurs best, and then the apex is where you hear mitral murmurs best, over in the 5th interspace in the midclavicular line. You also need to know which murmurs are systolic and which are diastolic. And rather than trying to memorize that, I find it useful to understand when blood is flowing through the various valves so you can kind of reason out which murmur occurs where. So right now, I want you to pause the video and try to answer questions 5, 6, 7, and 8 on your own. Then we're going to go through the answers. So number 5 says, which valves should blood be flowing through during systole? Well, that's the aortic valve and the pulmonic valve. The next question, which valvular lesions produce systolic murmurs? So you have aortic stenosis and pulmonic stenosis, because stenosis is impeding the free flow of blood across those valves that should be wide open during systole. Then you can also hear a systolic murmur with tricuspid regurgitation, mitral regurgitation, and mitral valve prolapse, which is often associated with some regurgitation. But those AV valves should be closed during systole. So if they don't close all the way and some blood is leaking back or regurgitating back through those valves, it's going to cause a systolic murmur. So if you hear a systolic murmur and you determine that that systolic murmur is loudest at the aortic position, that's most likely aortic stenosis. But if that systolic murmur is loudest at the mitral position, that's most likely mitral regurgitation. Now, those murmurs sound pretty different too, but even if you're not a superstar with your stethoscope, if you can tell the location and whether it's a systolic or diastolic murmur, you can make a pretty good guess about the lesion. Now, there are other things that can also cause systolic murmurs like a VSD or hypertrophic cardiomyopathy, but those aren't valvular lesions. We're going to talk about those murmurs elsewhere. Now let's talk diastole. So the next question says, which valve should blood be flowing through during diastole? Well, that's going to be the tricuspid valve and the mitral valve. So the valvular lesions that produce diastolic murmurs are tricuspid stenosis and mitral stenosis, and then also aortic regurgitation and pulmonic regurgitation. Now, the next couple of questions are just some clinical pearls that may be helpful for you. The first one says, which type of murmurs and heart sounds would you hear best with a patient in the left lateral decubitus position? So you have the patient turn over on the left side, and that makes the apex of the heart press up against the chest wall, so you're going to hear mitral murmurs best in the left lateral decubitus position. You can also hear left-sided S3 and S4 heart sounds better in the left lateral decubitus position. Then the next question says, what cardiac auscultation findings are considered benign when there's no evidence of disease? So there are 4 things. The first one is a split S1. So if there's no evidence of disease, a split S1 is not problematic. Now, if there is evidence of disease, that's a different story. But if there's no syncope or any symptoms of cardiovascular disease, you just happen to hear this incidentally, it's not a big deal. Next is a split S2 on inspiration. The third one is an S3 heart sound in a patient younger than 40. So if it's an S3 heart sound in a patient older than 40, there's likely to be some heart failure. But an S3 in a patient younger than 40 is generally benign, unless, again, there's some evidence of disease. And then the fourth one is an early, quiet systolic murmur. Early, quiet systolic murmur is not problematic. Now, if it's a holosystolic murmur, or if it's a loud murmur, or if there's some evidence of disease, that's not benign. And then diastolic murmurs are almost always bad news, but an early, quiet systolic murmur is generally benign, again, if there's no evidence of disease. So let's get started with some specific valvular lesions. Now, I'm not going to cover every possible valve lesion. I'm just going to cover the 4 or 5 highest yield ones that you definitely want to know for your test. And just like on your exam, we have some sample heart sounds for you to hear for each one of these. And you're probably going to hear them a lot better if you're wearing headphones. So before you write in and complain you can't hear the audio, go get some headphones. So let's get going with aortic stenosis. The most common cause of aortic stenosis is a congenital bicuspid valve. So normally the aortic valve has 3 leaflets, but if you're born with a 2-leaflet valve, that's going to predispose you to some aortic stenosis, usually around the age of 40. Then another common cause is senile calcification of a normal 3-leaflet valve. That typically occurs in elderly patients, especially patients over 60. Then rheumatic heart disease can cause some aortic stenosis, and so can tertiary syphilis, which is thankfully pretty rare. Syphilis causes aortitis and what we call tree barking of the aorta and some dilation of the aortic root. And that can cause a variety of problems, including aortic stenosis and also aortic regurgitation and thoracic aortic dissection. So syphilis is bad for the aorta. So how does aortic stenosis present clinically? Well, there are 3 main symptoms to watch for: dyspnea or CHF, syncope, and angina. And all of these tend to occur with exertion. So think about it. A tight, narrow stenotic aortic valve is going to restrict blood flow out to the brain or the rest of the body. And basically, when you get any one of those 3 symptoms, it's time to replace that aortic valve. Now, that's not true for all the rest of these valve lesions, but with aortic stenosis, as soon as you get symptomatic, you need a new valve, period. So on physical exam, you have a systolic murmur, so it occurs between S1 and S2. And it's called a systolic ejection murmur. So this is a diamond-shaped murmur that starts soft and it gets louder and then it gets soft again. Sometimes this is called a crescendo, decrescendo murmur. Those are musical terms. Crescendo means to get louder and then decrescendo means to get softer. Now this is best heard in the aortic position, the right second interspace or the right upper sternal border. And then it radiates up to the carotid. So if you listen over the carotids, you can hear the murmur kind of going whoosh, almost like a carotid bruit. I also want to call your attention to the fact that a systolic ejection murmur technically doesn't start right with S1. So think about it. what causes the S1 heart sound? Well, S1 happens when the mitral and tricuspid valves close. So right after those valves close, what's happening in the heart? Well, the ventricles are contracting, but at the very beginning, there's no blood moving across the aortic valve because this is the isovolumetric contraction period. Now, once that ventricular pressure gets high enough, it sort of pops open the aortic valve, and if there's aortic stenosis present, that's when you start hearing this systolic murmur. So systolic ejection murmurs don't start right at S1, they start a tiny bit after S1. And actually with aortic stenosis, you can actually hear that aortic valve pop open sometimes, and we call that an ejection click. So take a listen. Now that ejection click when the valve opens is often very hard to hear, but you don't really need to hear it to recognize this as aortic stenosis. So if you hear a systolic ejection murmur at the right upper sternal border, think aortic stenosis. If you hear a systolic ejection murmur on the left upper sternal border, what do you think that's going to be? Pulmonic stenosis. Now another minor diagnostic clue is if you have the patient Valsalva, that's going to reduce the preload and decrease the murmur of aortic stenosis. File that away for right now. We're going to come back to that in another video. Now one more classic physical exam clue that they might give you is that with aortic stenosis, the peripheral pulses are weak and prolonged or delayed. That's sometimes called pulsus parvus et tardus. And generally, when you hear a murmur that you think is pathological, what's your next step going to be? Well, the best test is going to be an echocardiogram. That's going to confirm your diagnosis and give you some idea about how severe the stenosis is. So for almost any murmur, the next step is going to be an echo. And then again, the treatment is valve replacement as soon as the patient becomes symptomatic. But treatment isn't really all that important for this test. Just be able to recognize the murmur. That's going to be the main thing. The other important systolic murmur to know about is mitral regurgitation. So mitral regurg happens because the valve is incompetent or leaky. When the valve closes, there's still a gap where blood can leak back into the left atrium. Now this might be caused by mitral valve prolapse, but not always. You can have prolapse without regurgitation. You can also have regurg without prolapse. So again, mitral valve prolapse does not always cause mitral regurg, but it can. We're going to come back to mitral valve prolapse in a moment. Rheumatic heart disease can cause mitral regurg, and that's a big cause of mitral valve murmurs, especially in undeveloped countries. Rheumatic heart disease can cause almost any type of murmur, but the mitral valve is going to be the one most commonly affected by rheumatic heart disease. Infective endocarditis of the mitral valve can classically cause mitral regurg. And we said that following an MI, you might have papillary muscle rupture or papillary muscle dysfunction, which could cause mitral regurg. And then left ventricular dilation, either from ischemic heart disease or other types of dilated cardiomyopathy, can actually pull the valve leaflets apart as the heart dilates, so that blood's going to leak back through the valve when it's supposed to be closed. Now, mitral regurg is often asymptomatic, even with severe regurgitation. And when these patients do have symptoms, they can be pretty vague: fatigue, exertional dyspnea, or as the left atrium dilates, the patient may develop atrial fibrillation. So that's one reason you always work up a fib with an echo to look for any structural heart disease. Now, the murmur of mitral regurgitation is called a holosystolic murmur or a pansystolic murmur. It starts immediately after S1 and it goes all the way to S2, so that's holosystolic. There's no gap between S1 and the start of the murmur like we saw with systolic ejection murmurs. So as soon as that mitral valve closes, the blood is regurgitating back through the mitral valve, so the murmur starts right at S1. And then the murmur really doesn't get louder or softer during systole. You can hear a holosystolic murmur with either mitral regurgitation or tricuspid regurgitation, but mitral regurg is much more common and much higher yield for step 2. Now, where is this murmur of mitral regurgitation heard best? At the apex, the fifth intercostal space in the midclavicular line. Now, the murmur may radiate from the apex to the axilla, so if you were to auscultate in the patient's axilla, you might hear the murmur up there. And we said that mitral murmurs are heard better in the left lateral decubitus position because that puts the mitral valve right up against the chest wall. So take a listen. Again, when you hear a murmur, the next step is to do an echo. And then even though the treatment of valvular lesions isn't all that high yield for step 2, I do want to point out that you do not need to give antibiotics for endocarditis prophylaxis to these patients. And unlike with aortic stenosis, where really the only treatment is valve replacement, in mitral regurgitation, we sometimes treat medically with vasodilators if there's left ventricular dysfunction, and with anticoagulation with warfarin if there's atrial fibrillation or a history of rheumatic heart disease. And if surgery is indicated, most patients get a valve repair rather than a mitral valve replacement. I also want to say a very brief word about mitral valve prolapse, which we said can be associated with mitral regurg, but it doesn't have to be. Now, mitral prolapse is very common, but it isn't usually very problematic clinically. Mitral prolapse occurs when you have large, floppy mitral valve leaflets that sort of billow up into the atrium like parachutes. Now, during systole, the mitral valve closes, but those big floppy leaflets are kind of prolapsing back into the left atrium, sort of expanding, then pop. The chordae tendineae reach their endpoint, and you hear this mid-systolic click. And then after the click, you might hear a late systolic crescendo murmur. It sort of gets louder and louder toward S2 because blood is rumbling within those ballooned out leaflets. Now let's talk about two diastolic murmurs, starting with aortic regurgitation. So lots of different things can cause this, like endocarditis, damaging the valve, or rheumatic heart disease again, or tertiary syphilis again. Remember, tertiary syphilis is bad for the aorta. Now, most of the time, aortic regurg is asymptomatic until it becomes very, very severe. And even then, it might cause some dyspnea and some heart failure because the heart's not pumping blood forward very efficiently. All that blood's regurgitating back into the left ventricle. Now, there are really some classic physical exam findings you need to know for aortic regurg. Because that blood is regurgitating back into the left ventricle, these patients will typically have a widened pulse pressure. So the systolic pressure is normal, but the diastolic pressure drops way off as that blood regurgitates back into the ventricle during diastole. Now, because of this wide pulse pressure, the patient may have bounding pulses. You may also see something called de Musset sign, which is a rhythmic bobbing of the head because of this bounding pulse in the carotids. It makes the head bob. And so to remember that, I want you to think about my little Dr. Lewis bobblehead. We better get you scheduled for an echo, Dr. Lewis. Now, the murmur is diastolic, so it starts after S2, and it starts immediately after S2, as soon as the aortic valve closes. It's often difficult to recognize. And the more severe the regurgitation, the longer the murmur is going to be. Not necessarily louder, but longer. And when that regurgitation gets really bad, it might even sound holodiastolic. The other thing to note is the location of this murmur. So it may be heard in the aortic position, the right upper sternal border, or it may be heard along the left side of the sternum because that jet of turbulent blood flow is pointed directly into the left ventricle. So don't let the location of the murmur trip you up. The wide pulse pressure and the bounding pulses are going to be an important clue. So if you hear that early diastolic murmur, even if it's on the left side of the sternum, think about aortic regurgitation. Now, treatment includes medical management for heart failure symptoms with ACE inhibitors and beta blockers and spironolactone, and then eventually aortic valve replacement when the regurgitation gets severe enough based on your echo. And again, we generally replace the aortic valve rather than trying to repair it. Then the last murmur I want to talk about is mitral stenosis. So the main cause is rheumatic heart disease, which means that mitral stenosis is pretty uncommon in the U.S. The main presenting signs and symptoms you need to know are dyspnea and CHF, and atrial fibrillation because of the dilation of the left atrium. And also know that most patients with mitral stenosis also have some mitral regurgitation and tricuspid regurgitation. That rheumatic heart disease causes all sorts of valve damage. It's also useful to know that pregnancy can tip a patient over from compensated asymptomatic mitral stenosis into symptomatic mitral stenosis with dyspnea and CHF, mainly because during pregnancy there's expanded blood volume, an increased heart rate, and increased stroke volume. So anything that increases cardiac output is going to worsen the hemodynamics of mitral stenosis. So what do you hear on exam with mitral stenosis? Well, early in diastole, you're going to hear an opening snap when that scarred stenotic valve snaps open. And then you're going to hear a late diastolic rumbling murmur. And where's that murmur heard best? Again, at the apex. So listen closely for that opening snap after S2 just before the murmur. Now, treatment is mainly to do a balloon valvuloplasty, where you put a balloon across the mitral valve and then you inflate the balloon, and that breaks those valve leaflets open. And for the most part, we do the balloon valvuloplasty for patients with CHF symptoms or asymptomatic patients with really severe mitral stenosis. Sometimes we have to give diuretics to control the CHF symptoms before you do the procedure, and sometimes we have to anticoagulate the patient to prevent thromboemboli due to atrial fibrillation. But ultimately, these patients need valvuloplasty. Did we cover everything, Dr. Lewis? Ready for the end of session quiz, Dr. Lewis? All right, first question. What's the next step in the evaluation of a low-grade systolic murmur in an otherwise healthy, asymptomatic patient? Well, remember, this is a quiet, low-grade systolic murmur in a patient with no symptoms, and these are usually completely benign, so no further workup is needed. But if this patient were symptomatic, or if this was a loud systolic murmur, or if it was any kind of diastolic murmur, then you would need to work that up, starting with an echocardiogram. Next, what's the next step in the evaluation of a diastolic murmur in an otherwise healthy, asymptomatic patient? Again, with a diastolic murmur, you definitely need to check an echocardiogram because diastolic murmurs are commonly pathological. And the last question, what type of valvular disease fits each of the following descriptions? So a diastolic opening snap followed by a late diastolic murmur, best heard at the apex, is mitral stenosis. A mid-systolic click followed by a late systolic murmur is mitral valve prolapse. Early diastolic murmur with a widened pulse pressure is aortic regurgitation. A holosystolic murmur heard at the apex radiating to the axilla is going to be mitral regurgitation. A systolic murmur heard best in the second right interspace peristernal is aortic stenosis. A systolic murmur heard best in the second left interspace peristernal is pulmonic stenosis. Valvular lesion associated with weak, delayed pulses is aortic stenosis. And a valvular lesion associated with bounding pulses, think about aortic regurgitation. That's it for heart murmurs and valve disease. We'll see you next time.
Whoa, I seriously need to know when you're going to let me borrow that top. Anyway, so during rounds today, I was presenting this patient with syncope from aortic stenosis, and Dr. Wilkerson was all like, describe his murmur. So I was like, it was a harsh, high-pitched grade 2/6 crescendo, decrescendo, systolic ejection murmur radiating to the carotids. And he was all like, did he have strong pulses? Trying to trick me. And I was like, cha, as if. The pulses were weak and delayed, classic pulsus parvis etardis, dude. My physical exam skills are like seriously legit. So we sent his butt into surgery. The patient, not Dr. Wilkerson. Okay, so when can I borrow that top? Seriously.
Hello everyone, it's time for another 3-question warm-up. Let's get going. First question here, which lipid-lowering agent is most likely to cause elevation of liver function tests and myositis? So those elevated LFTs and myositis is going to be a side effect of the statins, but also don't forget about the fibrates as well. Next, what is the difference between the cardiac enzyme profile in unstable angina when compared to the non-ST segment elevation MI? So there's actually a pretty big distinction here. So if you have elevated cardiac enzymes like CKMB and troponin I, that's almost always going to indicate myocardial infarction. Now in unstable angina, the cardiac enzymes should not be elevated at all. Next question. How long after the onset of an MI does troponin I begin to rise? And for how long does the level remain elevated? So it's going to be after about 4 hours it's going to rise, and then it's going to stay elevated for like 1 to 2 weeks. So troponin I is the first cardiac enzyme again to rise and is more specific, therefore it's relied upon pretty heavily. All right, that brings us to the end of our warm-up. Let's get to that lecture now.
In this video, we're going to review some basic cardiac physiology and hemodynamics so that we can better understand congestive heart failure in the next video. We'll also talk about different types of cardiomyopathies which can cause CHF. So let's start with cardiac output, which is basically just the amount of blood the heart pumps in a given unit of time, usually in liters per minute. Cardiac output is defined as stroke volume times heart rate. Stroke volume is the volume of blood that's ejected from the left ventricle during systole, during each stroke of the pump. Now, if you wanted to measure that, it would be end diastolic volume minus the end systolic volume. And then heart rate is how many times the heart beats per minute. So you can increase the cardiac output by increasing the stroke volume, increasing the amount of blood pumped with each beat, or by increasing the heart rate, increasing the number of beats per minute. But be aware that if you increase the heart rate too much, there's not enough time for the ventricle to fill during diastole, so you end up with decreased stroke volume and decreased cardiac output. Now there are three main factors that determine stroke volume: preload, afterload, and myocardial contractility. So preload has to do with how much the myocytes are stretched at the end of diastole, just before they contract. So preload is related to end diastolic volume. If you can stretch out the ventricle a little bit more, you'll be able to push a little bit more blood out. You can also think about preload as being related to return of venous blood to the heart. So having increased intravascular volume increases preload, and being dehydrated decreases preload, and that decreases stroke volume. When you're dehydrated, cardiac output might be low because you're not getting enough blood back to the heart. Afterload is the pressure or resistance that the ventricles have to contract against in order to eject blood. This is basically the pressure in the aorta, the systemic blood pressure. The higher the afterload, the harder the left ventricle has to work to pump blood. So decreasing afterload will increase the stroke volume because there's less pressure for the ventricle to overcome, so it's easier to eject blood. An increased afterload will decrease stroke volume. And then myocardial contractility is independent of both preload and afterload. Contractility is a function of the muscle itself, independent of the pressures and loads in the system. Now, contractility is influenced by catecholamines like epinephrine and norepinephrine. So this is your adrenergic response, your fight or flight response. It could be a catecholamine surge due to a stressor or due to anxiety or even exercise. Anything that increases catecholamines is going to increase the contractility and therefore increase the stroke volume. And blocking the adrenergic response is going to decrease the stroke volume. So beta blockers, specifically beta-1 blockers, will decrease your stroke volume. Contractility is also influenced by intracellular calcium. Calcium drives muscle contraction, so more calcium means more contractility. And the extracellular sodium concentration influences the myocyte membrane potential and the influx of calcium. Specifically, decreased extracellular sodium will increase contractility. This is how digoxin increases contractility. Digoxin blocks the sodium-potassium ATPase, and that causes a relative decrease in extracellular sodium and also an increase in intracellular calcium. Now, there's another way of expressing cardiac output using an equation called the Fick principle. The general equation for cardiac output is stroke volume times heart rate, but this other equation is the Fick principle. Cardiac output is equal to the rate of oxygen use divided by the difference between the arterial and venous oxygen content. So the rate of oxygen use can be determined by comparing the O2 content in the expired air to the O2 content of inhaled air, and then arterial and venous O2 content are measured directly from the blood. So on your exam, you might be asked to plug some numbers into this equation and come up with an answer. It's really not too difficult to do as long as you know the equation. So they might give you the rate of oxygen use and the arterial O2 content, the venous O2 content, then ask you to calculate the cardiac output. So if cardiac output is related to oxygen consumption, when you exercise, you start increasing oxygen consumption, you have to increase cardiac output as well. So when you start to exercise, the first thing that happens is an increase in stroke volume, which is basically hormonally mediated. Even before you start exercising, your brain anticipates that you're going to be exercising, and you start releasing catecholamines that increase stroke volume. Then later, as you continue exercising, you increase the heart rate, and that's what sustains that increased cardiac output. That's a point worth knowing. How does exercise increase cardiac output? Initially by increasing stroke volume, then later by increasing heart rate. Let's talk about mean arterial pressure as well. I want you to copy this down in your study guide. The mean arterial pressure is equal to the cardiac output times the total peripheral resistance. So as resistance goes up, the pressure is going to go up. Now, atherosclerosis will increase the peripheral resistance by making the vessels stiffer and less compliant. And that can lead to high blood pressure. An increase in cardiac output will also increase the blood pressure, or the mean arterial pressure. So there are a couple of equations to express mean arterial pressure. One way to express it is to say mean arterial pressure equals the diastolic pressure plus 1/3 of the pulse pressure. Another equation would be mean arterial pressure equals 2/3 of the diastolic plus 1/3 of the systolic. Now, if you do a little algebra, you can see that both of these equations are correct. You can plug in some numbers if you want to, but they both work. And that's definitely clinically useful because sometimes you have to calculate the mean arterial pressure when you're dosing certain vasopressors. And the pulse pressure is the difference between systolic and diastolic arterial pressure. As we're working our way toward a discussion of heart failure, we need to talk about ejection fraction. The left ventricular ejection fraction, or LVEF, is the fraction or percentage of blood in the left ventricle that's ejected with each stroke, with each contraction. Now, conceptually, that's pretty simple. If you start out with a certain volume of blood in the left ventricle at the end of diastole, the ventricle is as full as it's going to get, and then during systole, the ventricle expels, say, 60% of that blood, we see the left ventricular ejection fraction is 60%. So one way to calculate the ejection fraction is to take the stroke volume and divide it by the end diastolic volume. Another way to say that would be the end diastolic volume minus the end systolic volume, then divide that by the end diastolic volume. That's your ejection fraction. And a normal ejection fraction is somewhere in the vicinity of 55 to 75%. Once you get an EF below 50 or 55%, that's congestive heart failure. You also need to understand the concept of systolic heart failure versus diastolic heart failure. Systolic dysfunction means the heart isn't pumping enough blood forward. There's something wrong with the systolic contraction of the heart. The cardiac output isn't meeting the body's demands. Now, this could happen for several reasons. It could be increased preload because the heart simply can't deal with all that fluid. At first, increased preload increases stretch and you get a higher stroke volume, but at some point the preload just gets so high, the ventricle is so stretched that the myofibrils can't generate a good contraction anymore. So increased preload could cause systolic dysfunction. We also said that increased afterload is going to reduce stroke volume because the heart can't generate enough force of contraction to pump blood against all that increased systemic pressure. So again, that's systolic dysfunction. Then another cause would be decreased contractility, maybe because of a dilated cardiomyopathy where the muscle is just too weak to pump. Bradycardia or tachycardia can also cause systolic heart failure. If the heart rate's too slow, the heart's just not pumping enough blood. And we also said that if the heart rate's too fast, the heart doesn't have enough time to fill during diastole, so there's nothing in the heart to pump forward. There are also so-called high output conditions, where the cardiac output is actually high, but it's still not giving the body what it needs because of decreased oxygen carrying capacity, like in anemia, or because of increased metabolic demands, like in hyperthyroidism or beriberi. Remember, we said systolic failure is cardiac output that is inadequate to meet the systemic demand. So if you have high enough systemic demand, you can actually outstrip the ability of even the strongest heart to meet that demand. Then diastolic dysfunction is where the ventricle is unable to relax normally, so it can't fill normally during diastole. And when there's not as much blood to push forward, you get decreased cardiac output. So the ejection fraction might be normal or even increased, but the actual volume of blood that's being ejected is smaller because the heart isn't filling too well. Now, the most common cause of diastolic dysfunction is left ventricular hypertrophy, or LVH, which is usually due to chronic hypertension. So with hypertension, the left ventricle has to work harder to pump blood against that high afterload. So the ventricle is going to become thick and hypertrophied. And a hypertrophied left ventricle is a stiff, non-compliant left ventricle. So it can't relax and fill as well as it should during diastole. So you have chronic hypertension, then over time you get some LVH, and then you get diastolic dysfunction, and then eventually CHF. So that's hypertensive heart disease in a nutshell. Now, what heart sound would you hear with a stiffened left ventricle? An S4 heart sound. The left atrium contracts and pushes the last little bit of blood into the ventricle, and that little jet of blood sort of slaps against that stiff ventricular wall, and you hear an S4, which is right before S1. So if lub-dub is S1 and S2, then an S4 would be balub-dub, balub-dub, balub-dub. That ba is the S4, balub-dub, balub-dub. Or you could say Tennessee, 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 balub-dub, balub-dub. Now, while we're talking about gallops, just real quick, if an S4 is Tennessee, then an S3 heart sound would be Kentucky, or you could pronounce it Kentucka, Kentucka, lub-dubba, lub-dubba. So that last syllable is the S3. So Kentucka for S3, Tennessee for S4. And then what about a summation gallop where you have an S3 and an S4? It goes like this, balub-dubba, balub-dubba, balub-dubba. So the most common cause of diastolic heart failure is left ventricular hypertrophy from hypertension, and that S4. Now, less common causes of ventricular stiffening and diastolic dysfunction would include things like hypertrophic cardiomyopathy and restrictive cardiomyopathy. We'll talk about the diagnosis and management of heart failure in the next video. But right now, let's talk about the cardiomyopathies, which are frequent causes of heart failure. So a cardiomyopathy is a myopathy, a muscle pathology of the myocardium. So it's a cardiomyopathy. Now, there are three distinct cardiomyopathies that we're going to talk about: hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. Dilated cardiomyopathy is by far the most common of the three, but we're going to start with hypertrophic cardiomyopathy because that's the one you're most likely to be tested on. And it's particularly high yield, and it's pretty interesting. You may have heard it called by some older names like hypertrophic obstructive cardiomyopathy, or HOCM or HOCM, or you may have heard it called IHSS, which stands for idiopathic hypertrophic subaortic stenosis. But the preferred name is just plain hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, you have disordered hypertrophy of the left ventricle, so the muscle fibers are just a tangled, chaotic mess. So this is different from left ventricular hypertrophy. Remember, we talked about LVH being mainly due to chronic hypertension. But hypertrophic cardiomyopathy is primarily a congenital hereditary disease. About 50% of cases are autosomal dominant. The interesting thing here is what it does to the hemodynamics. You get a lot of hypertrophy of the interventricular septum, and because it's so enlarged, it's actually too close to the opposite wall of the left ventricle and too close to the mitral valve leaflets. And this causes left ventricular outflow tract obstruction, so the blood actually can't get out of the ventricle. So the symptoms are similar to valvular aortic stenosis: exertional syncope and dyspnea and chest pain. Hypertrophic cardiomyopathy is classically seen in young athletes who have sudden cardiac death. That's a fairly common scenario you might be tested on. They give you a high school football player or something who has sudden death during practice or during a game, and they want you to recognize that this is most likely hypertrophic cardiomyopathy. On physical exam, there's a systolic murmur because hemodynamically this is very similar to aortic stenosis. But remember, it's subaortic stenosis. You have outflow tract obstruction just like you would with aortic stenosis, but the problem is actually proximal to the valve. So you're going to hear a systolic murmur, and the murmur is louder with the Valsalva maneuver. Remember, we said that with aortic stenosis, Valsalva is going to make the murmur quieter. But in hypertrophic cardiomyopathy, Valsalva makes the murmur louder. So think about it. What does Valsalva do to preload? Well, when you Valsalva, you're increasing the intrathoracic pressure, you're reducing venous return to the heart, so you're reducing preload. That means that that hypertrophied septum is actually closer to the opposite wall of the ventricle, so the left ventricular outflow tract obstruction is worse. So the murmur gets louder with Valsalva. That's a great clue on physical exam that you can use to diagnose hypertrophic cardiomyopathy instead of aortic stenosis. Valsalva makes this murmur louder. And this murmur gets softer when the patient squats. So squatting increases afterload, and that helps to keep that outflow tract open. So squatting is going to make the murmur softer, and it may also help relieve symptoms. Now, your physical exam may show a forceful, enlarged apical impulse. So instead of the apical impulse being the size of a nickel, it's quarter size, maybe even silver dollar sized. If the history and physical suggests hypertrophic cardiomyopathy, what's the next step? An echocardiogram. That's going to clinch the diagnosis. And then for treatment, the main things to know are you give a beta blocker, because that's going to slow down the heart and prolong diastole and increase ventricular filling. You also need to restrict physical exertion and avoid volume depletion. Now, we're going to see in a moment that with other types of cardiomyopathy, we give diuretics, but in hypertrophic cardiomyopathy, we avoid volume depletion, so we're going to avoid diuretics. Next, let's talk about dilated cardiomyopathy, which is where the muscle pathology causes the ventricle to dilate, kind of like blowing up a balloon. So this is by far the most common type of cardiomyopathy. About 90% of cardiomyopathy is dilated cardiomyopathy, which makes sense because there are about a zillion things that cause it. Ischemic heart disease is the #1 cause of dilated cardiomyopathy just because it's so common. So most of the time when somebody has CHF from chronic ischemic heart disease, it's because they have a dilated cardiomyopathy. It's also pretty common for dilated cardiomyopathy to be idiopathic, where we don't identify any specific cause. But among the causes that we can identify, you need to remember that alcohol use can cause dilated cardiomyopathy, so can cocaine use, and also the cancer drug doxorubicin. You probably remember that doxorubicin is cardiotoxic, and that's why. Coxsackie virus B is another big cause because it causes myocarditis. So lots of different types of myocarditis can cause dilated cardiomyopathy. HIV can cause a dilated cardiomyopathy, and so can Chagas disease, which is caused by the parasite Trypanosoma cruzi. Beriberi, or thiamine deficiency, can cause it. And remember that it's called wet beriberi because of the edema and the volume overload you get with CHF. Hemochromatosis can cause dilated cardiomyopathy, and rarely you can see dilated cardiomyopathy with pregnancy, which we call peripartum cardiomyopathy. So the presentation is similar to CHF with fatigue, dyspnea, systolic dysfunction. These patients have an S3 heart sound because you have this dilated ventricle. They can also have systolic and diastolic murmurs because as the heart dilates, it can kind of pull all the valve leaflets apart, cause a lot of different valvular regurgitation. Chest x-ray might show a big, dilated, balloon-like heart. Sometimes we say this is a globular heart. And then treatment is just like treating heart failure. Diuretics, ACE inhibitors, beta blockers, that kind of thing. And then finally, there's the least common type of cardiomyopathy, which is restrictive cardiomyopathy. So this is where the walls of the ventricle are stiff and rigid and less compliant. So the ventricle doesn't relax and it doesn't fill very well. It's like something is restricting diastolic filling. And the walls aren't thick and hypertrophied and they aren't dilated, they're just stiff and rigid. So sometimes this is idiopathic, but most of the time there's some identifiable substance that's infiltrated the myocardium and makes it stiff and non-compliant. So the causes are infiltrative diseases, things like sarcoidosis or amyloidosis, or hemochromatosis with deposition of iron in the myocardium. So hemochromatosis more commonly causes a dilated cardiomyopathy, but it could cause a restrictive cardiomyopathy. Now, restrictive cardiomyopathy causes symptoms of predominantly right-sided CHF, like edema and JVD and possibly hepatomegaly and ascites. And we're going to talk about the difference between left-sided heart failure and right-sided heart failure in another video. To confirm the diagnosis, you need to do an echocardiogram, and then you need a myocardial biopsy to see what's infiltrating the myocardium. And then treatment is to identify and treat the underlying cause, plus diuretics and ACE inhibitors and beta blockers to manage the heart failure. Now we're ready for the end of session quiz. So pause the video and work through those questions, and then we'll go through the answers together. All right, first question. An ICU patient has a blood pressure of 120/78. Calculate her mean arterial pressure. So there are a couple of different equations you can use. You could say mean arterial pressure equals 2/3 of the diastolic plus 1/3 of the systolic. This patient's blood pressure is 120/78. So 2/3 of 78 is 52, and 1/3 of 120 is 40, so the mean arterial pressure is 92. Or you could say the mean arterial pressure equals the diastolic pressure plus 1/3 of the pulse pressure. And pulse pressure is systolic pressure minus diastolic pressure. So the pulse pressure is 42, and 1/3 of the pulse pressure is 14. You add 14 to the diastolic blood pressure of 78, and you get 92. Then there's a third formula for mean arterial pressure, which is mean arterial pressure equals cardiac output times total peripheral resistance. That's not going to help you with this question, but you should still know that equation. Next, what's a normal range for the ejection fraction? So it's 55 to 75%. LVEF lower than 55% or so indicates heart failure. Next, what disease causes signs of heart failure plus diabetes plus elevated LFTs? Well, this is hemochromatosis. So remember, you can get dilated cardiomyopathy or possibly restrictive cardiomyopathy. You can get iron deposition in the pancreas that causes diabetes, and you can get iron deposits in the liver, which causes elevated LFTs. And we're going to talk more about hemochromatosis in the GI videos on liver diseases. And the last question, which type of cardiomyopathy is most closely associated with each of the following? So ischemic heart disease, think about dilated cardiomyopathy. Sudden death in a young athlete should make you think about hypertrophic cardiomyopathy. Amyloidosis causes restrictive cardiomyopathy. Autosomal dominant inheritance causes hypertrophic cardiomyopathy. Doxorubicin causes dilated cardiomyopathy. Coxsackie virus B myocarditis causes dilated cardiomyopathy. And systolic murmur would be seen with hypertrophic cardiomyopathy. All right, that's it for this video. I'll see you next time.
Welcome back. Let's go through the answers to this three-question warm-up. Question number 1. Which lipid-lowering agent is most likely to cause bad taste and gastrointestinal discomfort? These are the side effects of the bile acid binding resins. Next question. A 35-year-old man is brought to the emergency department 20 minutes after the sudden onset of severe left-sided chest pressure and pain radiating to the jaw and left arm. He states that the pain started while he was watching television, while he was at rest. An ECG performed during the ambulance transport shows sinus tachycardia, and ST segment elevation and leads V2, V3, and V4. Cardiac enzymes, urine drug screen, and ECG performed in the emergency department show no abnormalities. Coronary arteriography shows no evidence of significant occlusion. What's the most likely diagnosis? This scenario is most likely princemetal angina, also known as variant angina. Whenever you see a younger patient with classic cardiac ischemic chest pain occurring at rest, you're going to want to place princemetal angina at the top of your differential diagnosis. Princemetal angina is diagnosed during coronary angiography, but you don't always see it there. And when you do diagnose it, you can treat it with nitrates and calcium channel blockers. And the last question, which ECG leads most likely show abnormalities with an anterior wall MI? Those leads would be V2, V3, and V4. That's it for this 3-question warm-up. Let's move on to the lecture.
Hello everyone and welcome to our video on congestive heart failure. Let's get going. So first we're going to start with a quick patient profile in your study guide. Here we go. A 75-year-old man with a history of hypertension and ischemic heart disease is brought to the emergency department for shortness of breath. He complains of dyspnea when climbing one flight of stairs for the last week. So that's dyspnea on exertion. He has difficulty breathing when lying flat, so he has begun sleeping propped up on 3 pillows. So what do we call that? Orthopnea. So that's when you're short of breath, when you're supine. Last night he woke up extremely short of breath several times and had to sit up on the side of the bed to breathe. So that's paroxysmal nocturnal dyspnea. Physical examination shows mild respiratory distress. He has jugular venous distension and ralls or crackles in the lower lung fields. The PMI is displaced laterally, which suggests his heart is enlarged. There's no murmur. He does have an S3 at the apex. The liver is enlarged and he has significant pitting edema. There is bilateral 3+ pitting edema midway up the tibias. Which of this patient's signs and symptoms are attributable to left heart failure and which are attributable to right heart failure? So I'm sure you recognize this patient has congestive heart failure, and we've discussed the difference between a systolic and a diastolic heart failure in other videos. But you also need to understand the difference between a left heart failure and a right heart failure, which is pretty easy to do based on the patient's symptoms and physical exam findings. So left heart failure versus right heart failure. So for left-sided heart failure, I want you to remember L for left and also L for lungs. Left-sided heart failure causes pulmonary problems. Now, when the left ventricle can't pump blood forward, that blood is going to back up into the left atrium and the pulmonary veins, and you get pulmonary problems such as dyspnea on exertion, which may also be called exertional intolerance or maybe just fatigue. You can also get orthopnea, so shortness of breath when lying supine or down. Paroxysmal nocturnal dyspnea. As the pulmonary vasculature gets more and more congested, then they can eventually develop full-blown pulmonary edema, which can cause the ralls or the crackles on the lung exam. Remember, L for left, L for lungs. And it's pronounced ralls, not rails. If you can't remember that, then maybe just say crackles. And if somehow you've never heard ralls before, one way to kind of mimic that sound is kind of rub some hair back and forth between your fingers. You can kind of get that sensation there. Now, this patient has a displaced PMI, which suggests that cardiac enlargement, and that isn't always present, but it can be. This patient also has an S3 heart sound located at the apex, which indicates a left-sided S3. So a right-sided S3 would be located along the right sternal border. Now, what does an S3 heart sound indicate? Well, it indicates dilated ventricles. Left heart failure is most often caused by ischemic heart disease and chronic hypertension. And we've talked about cardiomyopathies and valvular heart diseases like aortic stenosis or severe mitral regurgitation in other videos, but the big ones are still going to be ischemic heart disease and hypertension. So that's left heart failure, L for left, L for lungs. So what about right heart failure? Well, the most common causes of right heart failure is left heart failure. Now, with left heart failure, you get increased pulmonary pressures and increased pulmonary vascular resistance. And then the right ventricle starts to hypertrophy in order to pump the blood against that increased resistance. Then once that's stiff, hypertrophied right ventricle then starts to fail. And where does that blood back up to then? Well, we said that left ventricular heart failure causes blood to back up into the lungs, but right heart failure causes blood to back up into the right atrium, the vena cava, and then the systemic venous system. So the signs and symptoms of right-sided heart failure are going to include something else. JVD, jugular venous distension. You're also going to get hepatic congestion and hepatomegaly. You're also going to get lower extremity edema. So you might remember R for right and R for rest of body. So again, what's the most common cause of that right heart failure? We said left heart failure, but there are other causes of increased pulmonary pressure in right heart failure, and these include things like valvular heart disease. Again, think of that mitral stenosis. Pulmonary diseases like COPD. So what do we call that when lung disease leads to right heart failure? We call that cor pulmonale. Or they could have primary pulmonary hypertension as well. So now let's talk about diagnosis. So the next question in the study guide asks, what tests are going to help you make the diagnosis of CHF? Well, the single most important test is an echocardiogram. That's going to let you estimate the LV ejection fraction with that echo. Remember that an ejection fraction lower than 55% suggests systolic heart failure. You can also check the plasma brain natriuretic peptide, or B-type natriuretic peptide, or just BNP. The BNP will be elevated in an acute CHF exacerbation. BNP is a hormone produced in the cells of the cardiac ventricles in response to ventricular stretch, even though it's sometimes called brain natriuretic peptide. That's kind of weird. It's also actually produced in that cardiac myocyte when they get too much stretch, and it's supposed to do two things. So first, it causes some vasodilation. Second, it also is a natriuretic peptide, so it's going to cause increased excretion of sodium and water in the urine. So it is a very mild diuretic. So the ventricles are failing and the end-diastolic volume is rising and the ventricles are starting to stretch and the myocytes secrete BNP, so that BNP then causes little diuresis, little vasodilation, and both of those effects will potentially lower that preload, take some of the strain off of the heart. But we can measure that BNP in the blood as a diagnostic test for CHF. So say maybe our ER patient has a history of both COPD as well as CHF. So you've got to decide whether to give them albuterol nebs for a COPD exacerbation, which will make his heart work harder, or you need to start giving him treatment for CHF. So it's extremely important to make the correct diagnosis. So besides doing a careful history and physical, and while you're waiting on that echocardiogram, you check that BNP level. If the BNP is low, so less than 100, that's not going to be CHF. If the BNP is extremely high, greater than 400, then that's pretty likely going to be CHF. If the BNP is between about 100 and 400, that's the worst because that's intermediate and it doesn't really make a very reliable test in and of itself. So while you're checking labs, you would also want to check cardiac enzymes and ECG to rule out things like an MI as a cause of new CHF. An ECG can also give you clues about the presence of left ventricular hypertrophy, maybe AFib, even pulmonary hypertension, which might give you clues about the cause of the CHF. What about on a chest x-ray? Well, if the heart is enlarged, you would actually potentially see that, although the heart is not particularly enlarged all the time. But this patient does have some pulmonary edema. The pulmonary vasculature is really prominent, and the lung fields look hazy and opacified because the lungs are filling up with fluid instead of being full of air. Now you can also see cephalization of the pulmonary vessels. Cephalo means head, and cephalization means that the vessels in the upper lung fields near the head are becoming more prominent due to pulmonary vascular congestion. Now normally the pulmonary vasculature is hard to see in the upper lungs because gravity tends to pull blood downward into the bases. But with pulmonary edema, the pulmonary vessels are all engorged with all this extra blood backing up so that even those vessels in the upper lung fields then become pretty prominent. Now the other thing we sometimes see in CHF are going to be the curly B lines. So curly B lines are lines about 1 centimeter long, 1 millimeter thick in the periphery of the lower lung zones on the chest x-ray. It's basically thickening of the interstitium, the interlobular septa. Now several things can cause those curly B lines, but the most common cause is left ventricular failure and CHF. And then if the CHF and pulmonary edema are really bad, you might even just see pleural effusions. All right, so now we're ready to talk about treatment. And just like we separated systolic heart failure from diastolic heart failure, we separated left heart failure from right heart failure, we want to separate the treatment of acute decompensated CHF, what we call a CHF exacerbation, from a chronic treatment of CHF. So think back to our patient profile. This is a patient with recent onset shortness of breath, JVD, Rawls, pedal edema. This isn't a chronic state, hopefully. This is an acute decompensation that came on within the last few days. And say his BNP is through the roof. Chest x-ray shows pulmonary edema, like we all saw before. So how are we going to treat this patient? All right, so our mnemonic to help you remember the treatment options is going to be no lip, like don't give me no lip. So N is for nitrates. Think of things like nitroprusside. There's some other ones as well. Nitrates are vasodilators that dilate veins and reduce preload. Now they actually dilate arteries as well. They do the veins, but they dilate those veins a lot more. And in terms of pulmonary edema, that's a good thing because when you dilate the peripheral vasculature, blood is going to pool outside of the pulmonary vasculature. So you're taking blood out of that pulmonary circulation, pooling it elsewhere so that the patient can then breathe more easily. So you can give either sublingual nitroglycerin, you can give IV nitroglycerin, and that's going to help relieve that acute dyspnea pretty quickly. O is for oxygen. Supplemental oxygen is only indicated if the patient is hypoxic, and you titrate until the pulse ox is normal. You might start with a non-rebreather mask, or they might need a non-invasive ventilation, or they might need full-blown intubation. Now that non-invasive ventilation, or sometimes referred to as assisted ventilation, is where you deliver a positive pressure using just a face mask. And it actually has been associated with lower mortality, lower likelihood of needing intubation. L is for loop diuretic. So the idea here is that if they've got too much fluid in the lungs, you want to help that patient to urinate that extra fluid out of the body. And for your test, loop diuretics are probably going to be your go-to treatment for pulmonary edema, but maybe in practical terms, nitrates might actually be the better choice. So for one thing, loop diuretics take a relatively long time to work in CHF patients. You and me, an IV dose of furosemide is going to start working maybe 10 to 15 minutes later. But in a CHF patient with low cardiac output, that person isn't going to perfuse those kidneys very well, so it might take up to maybe 90 minutes to start working. And you don't want to just wait around an hour and a half to see if this patient is going to diurese, keeping your fingers crossed and hoping that the patient doesn't crash and have to be intubated. The other reason that nitrates might make more sense than loop diuretics is that the diuretics only benefit patients that are volume overloaded. And up to 50% of patients with cardiogenic pulmonary edema may be euvolemic or even hypovolemic. The problem isn't always that they have too much fluid on board, it's that the fluid is in the wrong place. Nitrates help redistribute the fluid from the lungs to the periphery, and they work faster. But again, for your test, diuretics are probably considered the first line choice for that type of pulmonary edema. So going back to our no-lip mnemonic, the I is for inotropic drugs. That's to increase myocardial contractility. So you stop their beta blocker, you start an adrenergic agonist, something like dobutamine, or a phosphodiesterase inhibitor like milurone. But really, these are last-ditch treatments. There are concerns about increasing mortality with these drugs. And then the P is for positioning. Positioning means that you sit the patient up on the edge of the bed so that blood pools in the legs, because lower extremity edema and blood pooling in the legs won't kill you, but pooled blood in the lungs might kill you. So reposition the patient with the legs down. So to recap, no lip is nitrates, oxygen, loop diuretics, inotropes, positioning. So those are your treatments for acute CHF pulmonary edema. Now let's talk about the treatment for chronic CHF. Let's go over that compensated CHF, not the treatment for that acute exacerbation, but the long-term management to prevent those hospitalizations and maintain a better quality of life. And the first thing I want to emphasize is that there are some drugs that help relieve symptoms, but they don't necessarily alter outcomes. Things like diuretics. On the other hand, some classes of drugs actually reduce mortality in CHF patients. So that's a good thing. Which drugs have been proven to reduce mortality? Let's go through those. So first, ACE inhibitors. Next, we have certain beta blockers, and we'll talk about which ones in just a moment. And also the aldosterone antagonists like spironolactone and also eplerenone. Now, all of these have been shown to decrease mortality in CHF, and they also reduce hospitalizations. So whenever you can, you want to try to get patients on each of these. ACE inhibitor, one of those three beta blockers, aldosterone antagonists. And take note, loop diuretics like furosemide, not on this list. Nitrates, not on this list. Those drugs will help relieve CHF symptoms, but they haven't been proven to reduce mortality. So let's talk about what is on the list in a little bit more detail. So ACE inhibitors. So ACE inhibitors will decrease preload and decrease afterload, and they will increase cardiac output. And this is a class effect. It doesn't matter which ACE inhibitor you use to get that mortality benefit. Now, if the patient gets a cough, a side effect from that ACE inhibitor, you could switch to an angiotensin receptor blocker, an ARB. Specifically, the ARBs, candesartan and valsartan, have shown efficacy in reducing hospitalizations, and there may be a small mortality benefit as well. So with ARBs, it really isn't a class effect. I don't know that they'll test you on those two drugs specifically, but do know that ACE inhibitors are preferred. The next group of drugs is the beta blockers, specifically bisoprolol, carvedilol, and just the extended release version of metoprolol. And you do actually need to know those three. Now, at first glance, it might seem a little strange to give a beta blocker. So I've had students ask me, if beta blockade is going to reduce myocardial contractility, why would you give a beta blocker to someone with CHF? That really doesn't make sense. Well, you're right. You actually never want to give or start a beta blocker in someone with decompensated CHF. But chronically, beta blockade improves survival and prevents cardiac remodeling. So you want to start with a low dose and gradually titrate the dose up. But you do have to be very careful. Beta blockers are definitely indicated for chronic CHF, but be careful. And then the third class of drug is going to be the aldosterone antagonist, spironolactone and eplerenone. So these are usually added on after the ACE inhibitor and the beta blocker. But they are definitely going to reduce mortality, especially in patients with more advanced heart failure. Now, beyond those three classes of medication, what else can we do for these patients? Well, there are some drugs that, again, help reduce those symptoms, improve quality of life, even if they don't reduce mortality. So these patients will often need to be on a daily dose of a loop diuretic, and that will reduce preload, help them to get rid of their fluid volume. We often have them weigh themselves daily, and if they gain 2 or 3 pounds in one day, they may need to take an extra dose of their diuretic that day because they've decompensated maybe just a little bit. You want to get that fluid off before they start getting to that shortness of breath phase. Digoxin can also be helpful. So digoxin is an inotropic drug, so it improves contractility. It does reduce hospitalizations and it improves exercise tolerance. There's just no proven mortality benefit. And occasionally you can use things like the vasodilators, like isosorbide dinitrate, which reduces that preload again. Hydralazine, again, reduces afterload, but not until you've really maxed out all of these other drugs. Now, one caveat to this, hydralazine does show a decrease in mortality in African Americans, so you may consider using that drug sooner in that patient population. And then cardiac resynchronization therapy, or that biventricular pacing. So this is a possible treatment for patients with more advanced progressed CHF. So about 25 to 50% of CHF patients, the septum and the lateral walls of the left ventricle, they don't contract simultaneously. Now, by putting a pacemaker with a wire going to each ventricle, you can resynchronize the ventricles so that the ventricles do contract simultaneously. Now, this can improve mortality and symptoms in patients with really low ejection fraction, so less than 35%. So if the EF is less than 35%, then you can consider a biventricular pacemaker. All right, that's it for the treatment of CHF. Now it's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. All right, first question here. What are the most common causes of left heart failure and of right heart failure? So the two most common causes of left heart failure are going to be ischemic heart disease and chronic hypertension. Then the most common causes of right heart failure, by far, left heart failure. Next, what lab marker is used to help diagnose acute exacerbations of CHF? Remember, that's that BNP. Next, what medications are important in the outpatient treatment of chronic CHF? So the drugs that are proven to reduce mortality in CHF are ACE inhibitors, certain ARBs, certain beta blockers, specifically the bisoprolol, carvedilol, extended release metoprolol, and also the aldosterone antagonists like spironolactone and eplerenone. And then some other important drugs to remember are the loop diuretics, that's going to help manage the fluid overload, maybe digoxin to improve contractility. Next, last question here. What is the treatment for acute exacerbations of CHF? Remember the mnemonic NO-LIP, which stands for nitrates, oxygen, loop diuretics, inotropes, and positioning. All right, that's it for the video for today. I hope you learned something. I'll see you next time. It's time for another 3-question warm-up. Let's get going. What is the most likely ECG change to occur first in the evolution of a myocardial infarction? Well, the first thing you're going to see is that ST segment elevation. Next, how do beta blockers work to reduce oxygen demand during an acute angina event? So your beta blockers are going to decrease the heart rate and contractility. Next, which two types of medication are most likely used to treat Prinz metal angina? So remember, that's that vasospasm, so we're going to combat that with calcium channel blockers, usually something like diltiazem, but you could also use nitrates. All right, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're going to be talking about shock, which is extremely high yield for step 2. This is a 5-star topic, so expect lots of questions on shock. Shock is basically circulatory collapse with extremely low blood pressure and inadequate perfusion. So it could be due to a decrease in cardiac output, like in acute heart failure, or it could be due to a decrease in systemic vascular resistance, like we see in anaphylaxis or sepsis. So we're going to talk about the different causes and mechanisms of shock in detail. But first, let's review what a patient in shock looks like. So first and foremost, the patient's going to have hypotension, low blood pressure. Very often, they also have some tachycardia, but not always. They may or may not have cool, clammy, possibly cyanotic skin, depending on the mechanism of shock. Decreased urine output is very common because they're not perfusing their kidneys. And altered mental status is another common feature because of inadequate perfusion of the brain. Think about war movies or cop shows where somebody gets shot and they're bleeding out and they become delirious. That's mental status change due to shock, circulatory collapse. So you want to monitor urine output and mental status very closely in patients that are hypotensive because those two features may indicate the onset of shock. Now, some patients with hypotension tolerate it better than others. Some people walk around with blood pressure of 90/50 all the time, and that's normal for them. Or if their normal is 110/75, they may still do okay at 90/50. But a couple of ways that you can determine how well they're tolerating that hypotension is by watching the urine output and the mental status. So, are they perfusing their kidneys adequately and they're making urine? Are they perfusing their brain? And then finally, metabolic acidosis can be another good clue about the presence of shock because of anaerobic metabolism and lactic acid that's building up. So when you check your labs, you may want to order an ABG to look for acidosis and look at the Chem 8 to look for any anion gap, and you may want to check a lactic acid level. Now let's talk about the different types of shock and mechanisms of shock. So it's important to be able to differentiate between these, not only for your test, but also for real-life patient care. So number 5 in your study guide is an enormous table that we're going to go through together. And we're going to look at the causes of shock and the treatment for each one first, and then we'll look at the hemodynamics separately. So hypovolemic shock is due to inadequate intravascular volume. So it could be due to hemorrhage, due to trauma, or maybe a massive GI bleed, or you could have skin losses of fluid from severe burns, or even GI losses from prolonged vomiting or diarrhea. So the patient loses a ton of intravascular volume, and that makes the cardiac output drop, and the patient's in shock. So the treatment is to give fluids to replace the volume. You're going to start with IV fluids and possibly give a blood transfusion if there was hemorrhage, which is probably the most common cause of hypovolemic shock. And then you have to also address the underlying cause, surgery to stop the bleeding or treatment of the burn or whatever. Now we're going to come back to the hemodynamics shortly, but for now let's move on down to cardiogenic shock, which is due to pump failure. The heart just isn't pumping blood forward adequately. That's what cardiogenic shock means. So this could be due to an acute MI or a dilated cardiomyopathy or an arrhythmia that's so fast or so slow that it impairs cardiac output. Or it could be some mechanical problem like a ruptured intraventricular septum or a ruptured papillary muscle that causes acute mitral regurgitation. So in general, the treatment of choice for cardiogenic shock is dobutamine, which is an inotropic drug with primarily beta-1 effect. We're going to talk about pressors and inotropes in the video on critical care medicine, but for now, just remember dobutamine is the drug of choice for cardiogenic shock. You might also use an intra-aortic balloon pump for really awful cardiogenic shock. And then depending on the underlying cause, the patient might need angioplasty if they had an acute MI, or they might need a pacemaker for the arrhythmia or whatever. Now, the one thing you don't see listed here is IV fluids. We're going to use IV fluids to treat lots of types of shock, but you have to be really careful about giving fluids to patients with cardiogenic shock because you don't want to cause pulmonary edema, because then they have shock plus respiratory stress and hypoxemia. So maybe you're going to give them a little fluid bolus, like 250 cc's, see if their blood pressure gets better or if they start to develop RALs and get pulmonary edema. So the next type of shock is obstructive shock or extracardiac obstruction. This is where there's something outside the heart that causes pump failure. So think about it. If you have a tension pneumothorax or massive hemothorax from trauma, that increased intrathoracic pressure is going to make it harder for blood to get back to the right side of the heart. It's like something is obstructing the flow of blood, and that reduces preload, and that leads to decreased cardiac output, because if nothing comes in, then there's nothing for the heart to pump out. Pulmonary embolism rarely causes shock, but that would be another type of obstructive shock, because a big PE could raise the pulmonary artery pressure enough to prevent filling of the right ventricle and the right atrium. Now, another cause would be cardiac tamponade, where blood or fluid fills up in the pericardial space and compresses the heart and prevents blood from returning to the right side of the heart. Now, we're putting that in a separate box because the hemodynamics are a little bit different, as we're going to see shortly. But for now, think about treating the underlying problem to treat this. For PE, you're going to give fluids, possibly give dobutamine or norepinephrine, and you're going to anticoagulate. For tension pneumothorax or hemothorax, you're going to put in a chest tube. For tamponade, you're going to do a pericardiocentesis. Then these last three types of shock are sometimes lumped together under the heading of distributive shock. So the common theme with these three is peripheral vasodilation, which causes the blood to be distributed incorrectly. So the problem is not low cardiac output, the problem here is low systemic vascular resistance because of all this vasodilation. And because of the vasodilation, these patients' skin may be warm and pink instead of being cool and clammy and cyanotic. Now, septic shock is where you have peripheral vasodilation because of infection, possibly due to various bacterial toxins and pro-inflammatory mediators. For treatment, you need to fill up the vascular space with IV fluids. You're going to give lots of IV fluids. And then if IV fluids aren't sufficient, then you could use a vasopressor to clamp down those dilated vessels. So what pressor do you reach for that causes a lot of vasoconstriction without increasing cardiac output much? Norepinephrine. Norepinephrine is the pressor of choice for septic shock. And of course, you also need to treat the underlying infection with antibiotics. Now, anaphylactic shock occurs due to a severe type 1 hypersensitivity reaction. So the patient is exposed to some allergen, and the pre-sensitized mast cells and basophils degranulate, and they release inflammatory mediators like histamine that lead to some vasodilation. Now, the drug of choice for treating anaphylaxis is epinephrine. It's going to cause some vasoconstriction, and it's going to also increase the cardiac output to raise the blood pressure. It's also going to help keep the airway dilated. So IV fluids are going to be very important for treatment. So again, the vasculature is dilated. You want to fill up that vascular space with lots of fluids, just like we did for septic shock. You also need to manage the airway because these patients can get angioedema and swelling of the tissue that can compromise the airway. So they may need oxygen. They may need to even be intubated. Now, you can also see H1 antihistamines like diphenhydramine given to these patients. And sometimes you'll see H2 blockers like cimetidine given. Now, these antihistamines aren't going to help with the shock. They're not going to help protect the airway, but they may help with some of the itching and hives that can develop. And then neurogenic shock is shock due to CNS injury, either brain injury or spinal cord injury. So the mechanism is autonomic dysregulation, which leads to peripheral vasodilation and bradycardia. And we treat it with IV fluids, vasopressors, and then if bradycardia is a problem, you can give atropine. Now, one type of question you might see about shock is where they give you some hemodynamic readings, and they ask you to identify the type of shock or choose a treatment plan based on the diagnosis that you made. Or they might give you a clinical scenario and ask you to choose the hemodynamics that are most likely to be found. So let's look at the hemodynamic side of this table. Again, shock is extremely high yield, so you definitely want to understand these hemodynamic parameters. The good news is you don't have to really memorize this by rote if you can just reason it out. So the MAP is the mean arterial pressure. SVR is the systemic vascular resistance, which is measured with a Swan-Ganz catheter. And then HR is heart rate. Now, we're going to talk more about Swan-Ganz catheters in the video on critical care. But the other thing we can measure with a Swan-Ganz catheter is the pulmonary capillary wedge pressure, which is a good estimate of the left atrial pressure. So how does that help us? Well, it's going to give you a clue about whether or not there's congestion in the left side of the heart. If there's left ventricular failure and cardiogenic shock, that fluid is going to back up into the left atrium, and that left atrial pressure will be high. But if you have hemorrhage and hypovolemic shock, or if you have sepsis and all that vasodilation, there's relatively little fluid in the left atrium, so the left atrial pressure will be low. So knowing the left atrial pressure and the wedge pressure can help you figure out what kind of shock your patient has, and then you have a better idea of how to treat it. So let's look first at the mean arterial pressure. We're talking about shock, right? So the blood pressure is going to be low, and the mean arterial pressure is going to be low for all of these. Next, look at systemic vascular resistance. So when is SVR low? Well, it's only going to be low when you have massive vasodilation, like distributive shock. septic shock, anaphylactic shock, or neurogenic shock. That's the mechanism of distributive shock, decreased systemic vascular resistance. In other types of shock, the SVR is generally high because one way the body responds to hypotension is to vasoconstrict and clamp down the arteries to raise the blood pressure and to shunt blood to vital organs like the brain and the kidneys. Now look at heart rate. We said that in neurogenic shock, the heart rate is low because of autonomic dysfunction. But for the most part, with any other type of shock, the body is going to compensate for hypotension by raising the heart rate, trying to raise the cardiac output. Now the other outlier here is that in cardiogenic shock, the heart rate is variable. Remember, cardiogenic shock is sometimes caused by arrhythmias, in which the heart rate could be high or it could be low. Or maybe the heart is damaged or stunned, so it may not be capable of raising the heart rate. Now for the wedge pressure, let's go one by one. With hypovolemic shock and hemorrhage, there's low intravascular volume. The pulmonary capillary wedge pressure or left atrial pressure is going to be low because the intravascular volume is low. And then if you give a fluid challenge where you give a little bit of IV fluid and then remeasure the wedge pressure just to kind of see what happens, in hypovolemic shock, when you give a fluid challenge, the wedge pressure won't rise until the patient is euvolemic again. But once you fill up that vascular space and replace the volume that was lost, then the pulmonary capillary wedge pressure will normalize. So again, the treatment for hypovolemic shock is fluids. Next row down is cardiogenic shock. Now usually we're talking about left ventricular failure because it's the left ventricle that perfuses the body. And with left ventricular failure, the blood backs up into the left atrium and then it backs up into the pulmonary capillary. So the wedge pressure is high. And then after a fluid challenge, it's actually going to go even higher. So fluids are generally not what you want to give to a patient with cardiogenic shock. Next we have obstructive shock due to extracardiac causes of pump failure like pneumothorax or hemothorax or PE. We said that leads to decreased preload. We said that the SVR and the heart rate are going to be high, but there's no real reason for the wedge pressure to be high. If there's not much blood coming into the right ventricle, there won't be much blood going into the left atrium, so the wedge pressure will be low or normal. And in the case of a massive PE, the right ventricle can't pump much out to the left atrium, so the wedge pressure is going to be low or normal with a PE as well. Now, a fluid challenge might raise the wedge pressure or it might leave it unchanged. But we specifically put cardiac tamponade on a separate row. Remember, with tamponade, there's excess pericardial fluid that's squeezing the heart, and this leads to equalization of pressures in all four chambers of the heart. So with tamponade, the left atrial pressure is much higher than normal, which means that the wedge pressure is higher than normal. And then after a fluid challenge, this is still going to be high because you haven't actually fixed anything. And then with the last three, septic shock, anaphylactic shock, and neurogenic shock, there's vasodilation, SVR is low, and the wedge pressure is generally normal. But after a fluid challenge, the wedge pressure will increase because, again, you're filling up that vascular space. So that's it for shock. You definitely need to know about shock for this test. So go ahead and work through the end of session quiz, and then we'll go over the answers. All right, first question. What lab value can be used as a biochemical marker of hypoperfusion and resultant tissue ischemia in shock patients? That's a lactic acid level. Next, what type of shock best matches each of the following descriptions? So type 1 hypersensitivity reaction to an allergen leads to histamine release. That's anaphylactic shock. Low cardiac output due to sustained ventricular tachycardia would be an example of cardiogenic shock. Decreased intravascular volume due to widespread third-degree burns would be hypovolemic shock. CNS injury leading to autonomic dysregulation and bradycardia and vasodilation, that's neurogenic shock. Reduced venous return to the right heart due to increased intrathoracic pressure would be obstructive shock. It could be a tension pneumothorax or hemothorax. Reduced venous return to the left heart due to pulmonary hypertension would be obstructive shock again. You can see increased pulmonary artery pressure from a PE or from primary pulmonary hypertension. And then widespread vasodilation due to bacteremia is septic shock. So make sure you understand each of these mechanisms. And then the last question, you're called to see an ICU patient who's developed significant hypotension. She's bradycardic, the SVR and wedge pressure are elevated. So what's the most likely cause of shock in this patient? So with a high SVR, you can rule out all the distributive causes of shock, where there's vasodilation and a low SVR. You can also rule out hypovolemic shock because the wedge pressure is low with hypovolemia. So this patient has cardiogenic shock, most likely due to bradycardia. Maybe she's developed a third-degree AV block. Remember, most patients in shock will have tachycardia, The two exceptions to that rule are neurogenic shock and some types of cardiogenic shock. So that's it for this video. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. Which lipid-lowering agent has the best effect on HDL? Remember, that one's going to be niacin. Next question. Which ECG leads most likely show abnormalities with a lateral wall MI? So think about 1, AVL, V5, and V6. Next, what ECG change most likely remains weeks after an acute myocardial infarction? So usually it's going to be the ST7 and the T waves. Those are going to normalize, but the Q wave can still be present weeks after an acute MI. All right, that's it for the warm-up. Let's get to that lecture now.
Great job on that warm-up quiz, Dr. Beard. I mean, Dr. Lewis. Whoops. Actually, he's a lot easier to work with since he grew that beard. In fact, let me show you a clip from the very first video Dr. Lewis ever recorded for doctors in training.
Next up are the aminoglycosides, and this is a big group of antibiotics, and it in years past was a go-to medication for severe gram-negative infections.
I give you Dr. Lewis, king of the super nerds. I don't even know what to say about Sprinkles, the psychedelic beanie baby unicorn. In this video, we're going to talk very briefly about a couple of critical care topics. So we've just been talking about shock, so I want to go over pulmonary artery catheters or Swan-Ganz catheters, then also want to go over the various pressors we use to treat shock. So a pulmonary artery catheter or Swan-Ganz catheter is an IV catheter that's placed in the pulmonary artery to measure pressures in the pulmonary artery and also to measure the pulmonary capillary wedge pressure. You can also use Swan-Ganz readings to calculate cardiac output and to calculate vascular resistance, which help you figure out what type of shock a patient's having. So you go in either through the internal jugular vein or the subclavian vein. The catheter is advanced through the superior vena cava and then into the right atrium. And there's a little balloon on the end of the catheter, and when you inflate the balloon, it kind of floats along and the blood carries the catheter and the inflated balloon from the right atrium to the right ventricle, then eventually into the pulmonary artery. And in the pulmonary artery, it continues until it can't go any farther. At the point where it stops, it's been wedged into one of the small branches of the pulmonary artery. And at that point, you have what we call a pulmonary capillary wedge pressure. So you've wedged that balloon into a branch of the pulmonary artery. The Swan-Ganz catheter has a pressure sensing device in the tip just beyond the balloon. So when the balloon's inflated, you're able to measure the pressure distal to the balloon. So that pressure is not coming from the right side of the heart because the balloon's inflated and you've blocked the right side of the heart from contributing anything to that pressure. You basically created a little balloon embolus with the Swan-Ganz catheter. So what pressure are you measuring just distal to the balloon? Well, you're measuring the pressure in the left atrium. The wedge pressure is an approximation of the left atrial pressure, which is generally also a good approximation of the left ventricular diastolic pressure. And of course, after you get those measurements, you need to deflate the balloon so you don't have that embolus in place for a long period of time. Now, the main reason we put in a pulmonary artery catheter is to help with managing shock, to know if you need more fluids or if you're maxed out on fluids, you need to diurese the patient. But the thing that's controversial about using Swan-Ganz catheters and measuring the wedge pressure is there's no proven benefit. This has never been proven to improve outcomes. We still do it because we use that information to guide treatment. So the most common sites to place a swan are the right internal jugular vein or the left subclavian vein. Remember, you've got to float this balloon into the pulmonary artery. Well, this isn't exactly a balloon on a string. The string here is actually a rubber catheter. It doesn't bend and twist every which way. So you want to pick a site that makes use of the natural bends of the catheter so it doesn't have to go around too many corners. If you go in the right IJ, the catheter just has to make a U-turn to go down into the ventricle and then back up the outflow tract. But if you use the right subclavian, it has to make a right turn from the right brachiocephalic vein into the SVC and then make that U-turn. But if you go in the left subclavian, it's a more natural curve. That left turn from the left brachiocephalic vein just flows naturally into the U-turn. So either a right IJ or a left subclavian are going to be the most common sites to place a pulmonary artery catheter. Now, once you've determined the cause of the patient's shock, you need to treat it. So let's talk about the vasopressors and inotropes that you might use to raise cardiac output and raise the blood pressure in a patient with shock. So you ought to know what each of these vasopressors is doing and have some idea about when to use them. Let's start with dobutamine, which is an inotrope, not really a vasopressor. It's the only pure inotrope we're going to talk about right now. Dobutamine is primarily a beta-1 agonist, so it increases heart rate, it increases contractility and cardiac output. It can also cause some mild reflex vasodilation. And we said that dobutamine is used primarily for cardiogenic shock. You wouldn't want to use dobutamine for septic shock because with septic shock the primary problem is too much vasodilation. Now, what drug do we say was the pressor of choice in septic shock? Norepinephrine. Norepinephrine is an alpha-1 agonist that causes vasoconstriction. That's going to counteract septic shock. But it also has some beta-1 agonist effect that will increase the heart rate and the cardiac output. And there have been lots of studies comparing this pressor to that pressor for septic shock, and there isn't really a clear winner, but norepinephrine is the classic go-to drug for septic shock. Now, one thing to be aware of when using pressors is that sometimes too much vasoconstriction for too long can cause some problems. It can cause ischemia and eventually necrosis of the fingertips and the toes. It can cause mesenteric ischemia, which affects the gut and the liver. And it can cause some renal insufficiency and decreased urine output. So be aware of that as a complication of using vasopressors, especially in a patient with low cardiac output and low intravascular volume. Now the next pressor is epinephrine. Unlike norepinephrine, epinephrine is an agonist for all of the adrenergic receptors, alpha-1, alpha-2, beta-1, and beta-2. Now at low doses, the beta-1 effect causes increased cardiac output, and the alpha-1 vasoconstriction is kind of offset by some beta-2 vasodilation. But at higher doses, that alpha-1 effect kind of overrides the beta-2 effect, so you get pretty good vasoconstriction at high doses. Now, which type of shock is epinephrine the drug of choice for? Anaphylactic shock. It causes vasoconstriction to raise the blood pressure, and it also causes some beta-2 mediated bronchodilation. We can also use epinephrine as a second-line drug for septic shock. If you start norepinephrine and it's just not cutting it, you might add epinephrine or switch to epinephrine. Another second-line drug for septic shock and also sometimes for anaphylaxis is vasopressin, or antidiuretic hormone. In addition to its action of causing water reabsorption in the collecting tubules of the kidney, ADH has a weak vasoconstrictor effect, which is why it's called vasopressin. It's a weak pressor. So it may be useful for distributive shock due to vasodilation, such as sepsis or anaphylaxis. Then another last-ditch drug is phenylephrine, which is a pure alpha-1 agonist. So it causes alpha-1 vasoconstriction, but with minimal effect at the heart. But when you raise the SVR and you're increasing the afterload without increasing myocardial contractility, you can actually see stroke volume and cardiac output decrease. So we really only use phenylephrine in patients with septic shock who just can't tolerate norepinephrine or epinephrine because they cause too many arrhythmias. And then finally there's dopamine. Dopamine is a beta-1 agonist at low doses and an alpha agonist at high doses, but it has weaker alpha-1 effect than norepinephrine does. Dopamine is primarily used as a second-line drug for cardiogenic shock or perhaps as an add-on pressor. Now, you may have heard dopamine referred to as a renal protective pressor, in that it might theoretically cause some renal vasodilation and protect against renal failure during shock. It does cause some selective renal vasodilation, but this has not been shown to have any particular benefit over using other pressors. And that's it for this video. Now it's time for the end of session quiz. So go ahead and work through those questions, and then we'll go over the answers. All right, first question. What complications can arise from the use of vasopressors such as norepinephrine in treating shock? So we mentioned ischemia and necrosis of the fingertips and the toes, mesenteric ischemia, and renal insufficiency. Next, which vasopressor matches each of the following statements? So high doses optimize the alpha-1 vasoconstriction. That's epinephrine and dopamine. Antidiuretic hormone, the other name for that is vasopressin. The best choice for anaphylactic shock is epinephrine. The best choice for septic shock is norepinephrine. And the best choice for cardiogenic shock is dobutamine. And the last question, pulmonary capillary wedge pressure is a good estimate of what other pressures? So we said left atrial pressure and left ventricular diastolic pressure. All right, that's it for now. We'll see you next time.
Let's go over this warm-up. First question, which lipid-lowering agent has the best effect on triglycerides? Those are the fibrates, like gemfibrozol or fenofibrate. These are the most effective at reducing triglyceride levels. Next, with a septal wall myocardial infarction, which ECG leads are most likely to show abnormalities? So you're going to look for changes mainly in V1, V2, and possibly V3. Last one, What is the most appropriate next step in the evaluation of a patient with suspected hypertrophic cardiomyopathy? Well, the next step is to get an echocardiogram, which is going to show thickening of the septum and confirm your diagnosis. Now let's get started with the lecture.
Hello everyone and welcome to our video on myocardial infections.
It's time to let you all know about the hidden war that's waging here at DIT. For what seems like eons,
Well, I don't know, like 2-3 years.
I have had a nemesis, a villain, a scoundrel to contend with. A man so evil that not even Darth Vader himself would call a friend.
Well, you know, when Darth Vader was bad in the first 2 3/4 of the original trilogy, not when he turned good at the end. And don't get me started on the prequels. And who is this demon of a man? Don't be fooled by his boring persona.
He goes by the name McGinnis.
So, onward to battle. Weapons will be honed, arrows will be notched,
Blood will be spilt.
Actually, we just kind of make fun of each other in the intro. Something like McGinnis likes Justin Bieber, Twilight, My Little Pony, you know, just stuff like that.
Let the battle begin.
All right, let's get going. First, let's talk about myocarditis. So myocarditis, this is an inflammation of the cardiac muscle. It's not necessarily in the valves, it's not in the endocardium, this is in the muscle itself. Now, most commonly, it's caused by infections like viruses, but things like bacteria, fungi, and parasites can also be causes as well. Now, there's quite a few viruses that you should at least be aware of that can cause this. Parvovirus B19, Coxsackie virus, echoviruses, adenoviruses, even Epstein-Barr and cytomegalovirus, and then good old-fashioned influenza virus can do it as well. Now, myocarditis in South and Central America is commonly caused by Trypanosoma cruzi. So this is known as Chagas disease, and this may also be associated with achalasia. Now remember, Chagas disease is where you have 3 major things. You have cardiomegaly, megaesophagus, and megacolon. So everything is getting bigger in Chagas disease. Now, myocarditis can also be caused by drug toxicity, and examples of this are going to include chloroquine, the penicillins, sulfonamides, cocaine, even radiation. I know it's not a drug, but it's still treatment. Several of the drugs that cause myocarditis are actually used in cancer therapy. I want you to think of cyclophosphamide, doxorubicin, and daunorubicin. Now, the presentation of myocarditis is really quite variable. Patients will range from asymptomatic to sudden death. And the most common symptoms are going to include fatigue, chest pain, heart failure symptoms. That's the big one. So you might see a lot of edema, shortness of breath. And then also things like palpitations and then fever. Now, on physical exam, patients may have an S3 or maybe even an S4 indicating impaired ventricular function. Now, patients will also have signs of congestive heart failure again. Remember, edema, pulmonary ralls, jugular venous distension. Now, the ECG can be normal in myocarditis. There can be some nonspecific ECG changes like atrial or ventricular ectopic beats. Patients might even have changes that look a lot like an MI. Patients might actually have regional ST segment elevations and even Q waves. Now, cardiac enzymes like troponin I will often be elevated, but not always. Then for radiology, cardiomegaly or maybe pulmonary congestion might be seen on a chest x-ray, but that's not always easy to see. Echocardiograms can be much more useful because they can detect the impaired ventricular function that would be present with myocarditis. Now, a newer modality is the cardiac magnetic resonance, so CMR. That can actually detect inflammatory hyperemia, edema, and myocyte necrosis in the myocardium. Therefore, it's actually quite helpful in the diagnosis of myocarditis. However, the definitive diagnosis is made by endomyocardial biopsy. So these biopsies can also be cultured for bacteria. We can also try to detect viral genomes by PCR. So how do we treat myocarditis? Well, the prognosis will vary widely. If you can treat the underlying cause, then do so. Treat bacterial causes with antibiotics, stop offending drugs, but most of these patients are going to have heart failure symptoms. Therefore, you're going to treat the heart failure symptoms like you would any CHF exacerbation. You're going to treat any significant arrhythmias as well. If the myocarditis is autoimmune, then immunosuppressive therapy might be needed. But in many cases, the only treatment is supportive because many of these cases are due to viruses. All right, so now let's move on to acute rheumatic fever. Now, this isn't exactly infectious in the sense that the heart is infected, but acute rheumatic fever can lead to rheumatic heart disease, which we're going to cover here. So acute rheumatic fever is a non-suppurative sequela of group A Streptococcus pharyngitis, and usually it's going to occur about 2 to 4 weeks following a bout of strep throat. Now, rheumatic fever only occurs in about 3% of untreated streptococcal infections. And that streptococcus infection can provoke autoantibodies, and they're going to attack the heart valves and even the joints. Now, the antibodies will attack the mitral valve more commonly than the aortic valve, which is more commonly involved than the right-sided heart valves as well. Now, these are sterile vegetation. So as we said before, this isn't actually an infectious process. This is an autoimmune process, though it does get a jump start by a group A infection. So the most important things to know with acute rheumatic fever is going to be the diagnosis. And then the diagnosis is made with the use of the Jones criteria. And they are composed of both major and minor criteria. Now, first, a patient needs to have a history of a recent strep infection. And then they need either the presence of 2 major or 1 major and 2 minor criteria. And there's a couple of nice mnemonics that we can use. So for the major criteria, we use the word Jones itself. The O has to be kind of shaped like a heart for it to work though. So J is going to be joints. So patients will get polyarthritis, hot swollen joints, not very pleasant at all. The O in Jones, which is shaped like a heart, remember, stands for pancarditis. So this can include pericarditis, endocarditis. And you can also get valve damage as well. The N is for nodules. So you get nodules in the subcutaneous extensor surfaces. Most of the time, these are painless, are found on the back of the wrist, the elbow, and the anterior knee. E stands for erythema marginatum, which is a painless rash, and usually it begins on the trunk, maybe on the medial aspect of the limbs, and the patient will get multiple lesions with central clearing. So it kind of looks like there's a bunch of kind of oblong-looking rings all over them. And the S is for Sydenham chorea, so you can think of this as the flinging, flinching chorea movements. And then we have our minor criteria, and we use the word PEACE, P-E-A-C-E, as our mnemonic here. So P is for previous rheumatic fever, so if they've had it before, they're more likely to get it again. E is for ECG with PR prolongation. A is for arthralgias. C is supposed to be for CRP, C-reactive protein, and also ESR, or erythrocyte sedimentation rate elevation. So don't get too wrapped up with CRP and ESR in general for diagnosis. These are very nonspecific inflammatory factors. But if you have a negative CRP and ESR, then that makes your diagnosis a lot less likely. And then E is going to stand for elevated temperature. So a lot of those are less specific. Let's move on to our labs. So patients will have increased ESR and CRP as we just talked about. They will probably have an increase in white blood cell count. 90% of these patients will have the anti-streptococcal antibodies, and you'll hear this referred to as an ASO titer. Let's move on to treatment. So first, we're going to use things like NSAIDs for joint inflammation. You can use corticosteroids if the carditis is very severe. Then you can use a good old-fashioned beta-lactam, something in the penicillin family, for antibiotics for any ongoing infections. It doesn't treat rheumatic fever, but if they have an untreated streptococcal infection and we think there might still be an infection around, then obviously you're going to want to treat that with one of the penicillins. Now, one sort of confusing topic we need to cover is that historically, patients with a history of rheumatic fever would then need prophylactic antibiotics before surgery or dentistry. There was a fear that these patients would develop endocarditis after surgery or those dental procedures. Now, however, endocarditis prophylaxis prior to dental work no longer recommended for patients with a history of rheumatic heart disease, unless they have already had a previous episode of infective endocarditis. So these new guidelines actually drastically reduced the number of conditions for which infective endocarditis prophylaxis is recommended. And so the following are the only now remaining indications. So remember, rheumatic heart disease now off the table. So the first one is prosthetic cardiac valve. So if they got a new valve in there, you're going to give them prophylactic antibiotics. A previous bout of infective endocarditis would obviously want you to try to prevent it in the future. And then there's a big one, congenital heart disease. That's going to be associated with a lot of different things. So they can have an unrepaired cyanotic congenital heart defect, including palliative shunts and conduits, completely repaired congenital heart defects with prosthetic material or device. So kind of similar with our previous prosthetic cardiac valve, but just from a congenital problem. You can have a repaired congenital heart disease with residual defects at the site or adjacent to the site of the prosthetic patch or prosthetic device. So that's a lot of detailed stuff. And in my mind, I just remember congenital heart disease. And yeah, there's some caveats there, but if you can remember congenital heart disease, that's all I would remember out of all that. And then cardiac transplantation recipients who have developed cardiac valvulopathy. Those are going to be another group of patients that are going to need that prophylactic antibiotic. So those are the major ones. And then if a patient does need that prophylaxis, the recommended regimen is a single 2-gram dose of amoxicillin given 30 to 60 minutes prior to the procedure. So that's all you got to remember there for endocarditis prophylaxis. Speaking of endocarditis, let's talk about this in more detail now. Endocarditis is inflammation of the inner layer of the heart, the endocardium. Now, it usually also involves the heart valves. And on those valves, we see vegetations, which are masses of platelets, fibrin, microorganisms, and inflammatory cells. And unfortunately, these vegetations can come loose from the valves and then embolize in other parts of the body. Now, most patients present with acute rather than chronic disease. Now, there are several ways to classify endocarditis. Now, one way is to divide them into infective and non-infective, and the more common is going to be the infective endocarditis. Now, infective endocarditis occurs much more often in patients who already have damaged heart valves. So historically, rheumatic heart disease was the most common cause of heart valve damage and is still very common worldwide. It's becoming less common in the US due to prompt antibiotic treatment of strep throat. Now, congenital heart disease, again, another major cause of damaged heart valves. And then there's some other risk factors involved as well, too. IV drug users, poor dentition, older patients, so age greater than 60 years, and then male sex, all risk factors for endocarditis. Now, patients will present with non-specific symptoms like fever, malaise, weakness, anorexia, maybe a new heart murmur, and then just weight loss. Now, the more specific physical signs that you may remember are the Janeway lesions, the Osler nodes, and the Roth spots. So the Janeway lesions are small erythematous macules or sometimes nodules on the palms or soles. Now, these are caused by septic emboli, which deposit bacteria, and they kind of form these little micro abscesses. That's how you see that there. And these are non-tender lesions. Now, the Osler's nodes are small, very tender nodules on the fingers and the toe pad. So remember, the Osler causes ouches. These are painful. And these are actually caused by immune complex deposition. And then you see these in about 10 to 25% of endocarditis patients, but they can also be seen in things like lupus and in disseminated gonococcal infections. Next, we have the Roth spots. So the Roth spots are retinal hemorrhages. They have very kind of pale centers. And these, like the Osler nodes, are caused by immune complex mediated vasculitis from bacterial endocarditis. But again, you can see these in other things like leukemia and maybe even diabetes. And then very nonspecific, you may see some subungual petechiae, also known as splinter hemorrhages. So those are actually not very, very specific at all for endocarditis. So if you see splinter hemorrhages, don't automatically think of endocarditis, but they could have it. All right, so let's talk about causes infective carditis. What bacteria are we going to see most often here? Well, far and away, the highest one is going to be Staph aureus. About 31% are going to be due to Staph aureus. Viridans group strep, 17%. Now, viridin strep is associated with dental procedures, so make that connection in your mind. Enterococci is about 11%, coag-negative staph is 11%, and strep bovis is about 7%. Now, if you don't culture anything, it doesn't mean that you absolutely can't have endocarditis, because you can have something called culture-negative endocarditis. Now, in the old days, up to about 10 years ago, the classic traditional culprits for culture-negative endocarditis were called the Hassic organisms, or the Hassic bacteria. And that stood for H, the Haemophilus, A is for Actinobacillus, C is for Cardiobacterium, E is for Eikenella, and K is for Kingella. Now, those are all pretty rare causes of endocarditis, but with modern lab techniques, they're actually much easier to culture than they used to be. So nowadays, the three most common causes of the actual culture-negative endocarditis are probably Coxiella burnetii, which is the bacteria that causes Q fever, Bartonella species, including Bartonella hensela, which causes that cat scratch fever, and then Brucella species, which is a zoonotic disease that you get from animals and unpasteurized milk. And then what characteristics do all three of those bacteria have? Well, they're all intracellular bacteria, and that's probably why they're not that easy to culture from the blood. So next, how do we diagnose infective endocarditis? Well, we're going to use the Duke criteria, a lot of criteria in this lecture here. So a definitive diagnosis of infective endocarditis can be made with a positive culture or histology from an actual vegetation. So you go in there, you get a biopsy of the vegetation on a valve, and it shows endocarditis. Now, otherwise, we have to use clinical criteria, and this is where we have both our major and, again, minor Duke criteria. So try not to get this confused with our Jones criteria that we just learned for our rheumatic heart disease. All right, so to get the diagnosis for infective endocarditis, that Duke criteria is going to include 2 major criteria, or 1 major and 3 minor, or just 5 minor criteria. So let's talk about these major criteria first. So first we're going to have serial blood cultures positive for organisms associated with infective endocarditis. So you're going to be checking these routinely, multiple sets. And what are those bacteria again? Remember, it was Staph aureus, it was Viridans group strep, it was Enterococci, it was those coag-negative staph, those Hasek bacteria. And now remember, if you don't always have a positive culture, you can actually have that culture-negative endocarditis. Next, we have the presence of vegetations or cardiac abscesses seen on echocardiogram. And this is probably really where you're going to first suspect endocarditis. You see a really sick person, you do an echo, you see vegetations on their valves, and then of course endocarditis is way up on the differential. It's also worth knowing that a transesophageal, going down the esophagus, that type of echocardiogram is much better than a transthoracic echo when looking at these valves. Now, another major criteria is evidence of new onset valvular regurgitation, and that's another way that these will present, especially on your test. The patient has a new murmur, and this is often a mitral valve murmur, so mitral regurg is what you might hear most often, especially on step 2 tests. And then the last major criteria, blood culture positive for Coxiella burnettii. So that bacteria is just very closely associated with endocarditis. So if you're able to culture that out, which is hard to culture, you can just about guarantee that the diagnosis is endocarditis. So next, let's cover the minor criteria. So it's a little bit harder to memorize all of these because they're a bit nonspecific. They'll include things like predisposing heart condition or intravenous drug use, fever greater than 38 degrees Celsius, a vascular phenomenon, and by that they mean arterial emboli, septic pulmonary infarcts, conjunctival hemorrhages, and those Janeway lesions. And then also immunologic phenomena like that possible glomerulonephritis, those Osler's nodes, and those Roth spots. And then another one is positive cultures not meeting requirements for major criteria. And then the last one is serologic evidence of infection without a positive culture. So really, remember the major criteria. The minor might not be quite as important. Know what they are, just kind of brush your eyeballs against those. But at least get those major criteria in your brain. And I would also still remember that the most commonly affected valve is the mitral valve. So let's move on to treatment. So this is going to be long-term antibiotics. So people are going to be on IV antibiotics for maybe 4 to 6 weeks. Initially going to start something broad spectrum, and then once you get your cultures back, you're going to switch to an antibiotic that's bug specific. And getting those blood cultures is very, 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 very important. Get at least 2, preferably 3 sets of blood cultures before starting empiric antibiotics. And empirically, you want a drug that covers staph, strep, enterococci. Therefore, most often we're going to start with vancomycin. And then once you get those cultures back again, you might change it to something else that'll treat it more specifically. But it is, again, a long-term treatment. Now, in the future, patients will need that antibiotic prophylaxis before surgery or dental work, as we mentioned before, especially if those valves are damaged. Remember that 2 grams of amoxicillin 30 minutes or an hour before the procedure. Valve replacement may also be necessary for severely damaged valves. And speaking of which, let's talk about the complications associated with endocarditis. So endocarditis can cause severe damage to the endocardium and the valves. Damaged valves might need to be repaired or completely replaced. Now, a big complication also during the active infection are those septic emboli. So you've got all these vegetations in the inside of your heart, and they can break loose and they can shoot out to other parts of the body. If the vegetation is on the right side of the heart, then pulmonary embolism is a likely complication. If it's on the left side of the heart, stroke becomes more likely. These can also go to the spleen, they can go to the kidneys, they can actually go just about anywhere. All right, so that's infective endocarditis. I want to very briefly mention non-infective endocarditis. So non-bacterial thrombotic endocarditis, or NBTE, is common. Well, not that common, but it's the most common one of the non-infective. It's also called merantic endocarditis, and this occurs on non-damaged heart valve. That's another difference here. The vegetations are sterile, and overall the patients do not become all that sick, like you see in our infective endocarditis patients. The vegetations can break loose and form emboli, though, so it's not completely benign. We're not entirely sure why this happens, but occurs in patients during hypercoagulable states, like in sepsis or pregnancy, and also patients with venous catheters, and it's also been seen in patients with mucinous adenocarcinoma. And then another type of non-infective endocarditis is called Liebman-Sachs endocarditis. Good test question there. Liebman-Sachs is a non-infectious endocarditis seen in patients with lupus. So make the connection there, Liebman-Sachs and lupus. And it's thought to be due to the deposition of those immune complexes. And again, these are going to be sterile vegetations. All right, that's going to get us to the end of the lecture here. It's time for that end of session quiz. Let's go through that together. First question here, what will most commonly be seen on echocardiogram in a patient with myocarditis? So remember, when you get that echo, you're going to see impaired ventricular function. So that heart is not pumping as well as it should, and that's why the most common severe presentation is going to be congestive heart failure symptoms. Next question, what are the major Jones criteria of acute rheumatic fever? Our mnemonic is Jones, and J is for joint, so that's polyarthritis. The heart-shaped O is going to be for that pancarditis, pericarditis, myocarditis, endocarditis, all the carditises. You can also get valve damage with that as well. N is for those subcutaneous nodules. E is for that erythema marginatum, and that S was for the Sydenham chorea. Next question, describe the following peripheral signs of endocarditis. So first we had Janeway lesions. Remember, those are going to be painless peripheral petechiae on the palms and the soles. The ossular nodes are going to be very painful tender nodules on the fingers and the toe pads. The Roth spots are the retinal hemorrhages, and that's due to vasculitis, due to immune complexes. And then you have those splinter hemorrhages, non-specific hemorrhages and petechiae that's underneath the fingernails. Next, what is the best study to visualize a vegetation on a heart valve? So remember, it's going to be the transesophageal echocardiogram rather than the transthoracic echocardiogram. All right, guys, that brings us to the end of our lecture. I hope you learned something. I'll see you next time. It's time for another warm-up review. Let's get going. Which lipid-lowering agent has the best effect on LDL and total cholesterol? Well, those are going to be the statins. So statins are first-line pharmacotherapy for treating hypercholesterolemia in general. Next, with an inferior wall myocardial infarction, which ECG leads are most likely to show abnormalities? So changes in leads 2, 3, and AVF should make you think of an inferior wall MI. Next, occlusion of the left anterior descending coronary artery is most likely to affect which walls of the heart? So the left anterior descending artery provides blood to much of the heart. Occlusion of the artery may affect the anterior wall, the septal wall, and the lateral walls of the heart. All right, that's it for the warm-up. Let's get to that lecture now.
Well, Dr. Lewis is at it again, trying to start up this ridiculous rivalry between us, calling me boring and saying I'm his nemesis. But think about it. Who's really the villain around here? Let me give you a little clue. It's always the guy with the beard. Osama bin Laden had a beard. Jafar has a beard. Satan has a beard. And he's the #1 most evil being of all time. And get this. On Star Trek, there was Mr. Spock. Normal, clean-shaven. But when they wanted to make Spock evil, how'd they do it? They gave him a beard. So, to sum up, beard, evil. No beard, good. It's just that simple. In this video, we're going to discuss some diseases of the pericardium, acute and chronic pericarditis, and also cardiac tamponade, which is due to fluid in the pericardial space. And we'll also discuss left atrial myxomas, which have nothing to do with the pericardium, but they really don't fit in anywhere else. So let's start with acute pericarditis, which is at least a 4-star topic. You're going to have at least one question on pericarditis. So take a look at number 4 in your study guide. Acute pericarditis is simply inflammation of the pericardium, which can be caused by a huge variety of things. Viral infections, which are probably the most common cause, although we can't always prove that. HIV is one virus in particular that causes pericarditis, which is a little bit surprising. Probably the most common bacterial infection that causes acute pericarditis is tuberculosis. Neoplasms are a relatively common cause of pericarditis, either metastasis to the pericardium or primary cardiac tumors. Trauma can lead to injury and inflammation of the pericardium, and that includes CPR and even cardiac surgery as a form of trauma. Anytime you open up the pericardium to get to the heart, that can lead to some local inflammation. You can also see pericarditis as a complication of an MI, which is called Dressler syndrome, post-MI pericarditis. And what's the time frame for Dressler syndrome? 2 to 4 weeks post-MI. Rheumatologic diseases like lupus or rheumatoid arthritis can often cause pericarditis, and so can renal failure, which we call uremic pericarditis. Radiation can cause pericarditis, and so can certain drugs, especially drugs that cause drug-induced lupus, like isoniazid, hydralazine, and procainamide. Now the next question asks, what are the main clinical findings that suggest a diagnosis of acute pericarditis? So pericarditis can be easy to overlook if you're not thinking about it. Patients almost always have pleuritic chest pain, which is sharp chest pain, usually in the anterior chest, And it's worse with coughing or with inspiration. It's worse when supine, so when they lie down. And then it gets better when sitting up and leaning forward. So that's a pretty good diagnostic clue. The classic physical exam finding is a pericardial friction rub, which is a rhythmic, scratchy or squeaky or leathery sound that's usually heard along the left sternal border, especially when the patient leans forward. So if you have a patient with this classic pleuritic chest pain pattern and you hear a friction rub, you've pretty much clinched the diagnosis of acute pericarditis. But friction rubs are notoriously difficult to hear, and they often kind of come and go over time, so you might miss the friction rub. Another diagnostic clue would be ECG changes, specifically diffuse ST segment elevation and also PR segment depression. Now, what do we mean by diffuse ST segment elevation? Well, if you see ST segment elevation in leads 2, 3, and AVF, that's an inferior MI. Or if you see ST elevation in 1 and AVL, that's a lateral MI. But if you see ST elevation everywhere, that's probably not simultaneous occlusion of all the coronaries at once. It's most likely going to be pericarditis. But even if the ECG looks classic for pericarditis, you still need to rule out MI with serial enzymes and serial ECGs. So here's an ECG from a patient with acute pericarditis, and you see ST elevation in leads 1, 2, VL, VF, V2, V3, V4, V5, V6, and also some reciprocal changes in AVR. So that's diffuse ST segment elevation. And you can also see some PR segment depression, especially in lead 2. An echocardiogram may show a pericardial effusion. So if you see an effusion, that's going to help support the diagnosis. But the absence of an effusion doesn't rule out acute pericarditis. It's kind of like a friction rub. It's helpful when it's present, but if it's absent, that doesn't mean much. Pericardial effusions are usually transudative, which means it's thin, watery fluid without much protein. An exudative pleural effusion is thicker with more protein and maybe more cellular components. That's going to suggest pericarditis due to neoplasm or bacterial infection like tuberculosis. But in practice, we actually don't do pericardiocenteses very often. Now, chest x-ray is usually normal in pericarditis, although if there's a really large effusion, the cardiac silhouette may be enlarged. Sometimes we call that a canteen heart or a water bottle heart, not like a flimsy plastic water bottle. This is like a big old-fashioned round army canteen, a canteen heart. But technically, the heart is not enlarged. It's the cardiac silhouette that's enlarged. So the main diagnostic findings are going to be pleuritic chest pain, a pericardial friction rub, those ECG changes we discussed, and possibly a pericardial effusion. If you have a patient with at least 2 of those, think about acute pericarditis, especially for your exam. And then the treatment for acute pericarditis is generally pretty straightforward. Since most cases of pericarditis are either viral or idiopathic, we treat empirically with NSAIDs like ibuprofen or indomethacin. And colchicine can sometimes be used as an adjunctive therapy. And if the patient doesn't respond to the NSAIDs after a week or 2, that's when you start looking for some underlying cause that you can treat, like a bacterial pericarditis or TB pericarditis or neoplasm or whatever. And obviously, if the patient has a known underlying medical problem that predisposes to pericarditis, like lupus or renal failure or recent MI or heart surgery, that's a different story. In those cases, you would treat the underlying cause. But most of the time, you don't know a precise underlying cause. And you don't need to spend a lot of time looking for one right away. Just go ahead and start the NSAID, start the colchicine. You can do a more extensive workup later if pericarditis is not resolving. Next, I want to talk about another 4-star topic, which is cardiac tamponade. Now, tamponade is often seen as a complication of acute pericarditis and pericardial effusion. Tamponade occurs when the pericardium becomes so full of fluid that it compresses the heart and decreases cardiac output. This could be from acute pericarditis and the pericardial effusion, or it could result from blood in the pericardium, which is called a hemopericardium. So a patient with chest trauma that causes bleeding into the pericardial space could present with tamponade, or an aortic dissection could lead to bleeding into the pericardium. Now, a patient with tamponade may have a lot of nonspecific cardiac symptoms like dyspnea and tachycardia, but they may look very sick. So you need to be able to recognize Beck's triad: hypotension, JVD, and muffled heart sounds. When you see that triad, think about cardiac tamponade. The other big physical exam clue that you may be given is pulsus paradoxus, which has to do with the blood pressure, not the pulse. Pulsus paradoxus is where the systolic blood pressure decreases by more than 10 millimeters mercury during inspiration. Let's review that for a second. When you take a deep breath, you decrease your intrathoracic pressure. When you decrease your intrathoracic pressure, you're able to bring more blood into your right atrium and right ventricle. But your heart is a relatively fixed size. So when you bring more blood into your right ventricle, that blood is going to push the septum toward the left. And then the size of the left ventricle is slightly smaller. And as a consequence, two things happen. Number one, when the heart finally does contract, you might have splitting of the S2 heart sound. The aortic valve is going to close before the pulmonic valve because the right ventricle is pumping out a little higher volume of blood than usual. So that's one thing, splitting of an S2 on inspiration. And again, that's normal. The second normal thing that happens is that the systolic blood pressure drops a few millimeters of mercury during inspiration. Again, because the septum is pushed over to the left and the left ventricular volume is slightly smaller. So it's perfectly normal for the systolic blood pressure to decrease slightly during inspiration by no more than 10 millimeters mercury. But if the systolic blood pressure drops by more than 10 millimeters during inspiration, that's called pulsus paradoxus, and that's commonly seen in cardiac tamponade. So say they give you a trauma patient with dyspnea and tachycardia and hypotension and JVD and muffled heart sounds and pulsus paradoxus. Well, what's your next step? Well, if the patient's unstable, you may need to perform an emergency pericardiocentesis to drain that fluid and restore cardiac output. We're going to talk about treatment shortly. But if you have to choose the best diagnostic test, that's going to be an echocardiogram. Not only can you see the effusion or the blood on the echo, but you can also see the ventricles collapse under that increased pericardial pressure. So echo is going to give you the diagnosis unequivocally. You may also be asked to recognize the ECG findings from cardiac tamponade, which include low voltage, so the QRS and T waves are just smaller than usual. And the other classic ECG finding is called electrical alternans, which is where you have this alternating amplitude of the QRS complexes. So one big QRS, then a small one, then a big one, then a small one. That's electrical alternans. And then the treatment for tamponade is to either perform a pericardiocentesis, where you put a needle and a catheter into the pericardium and you remove that excess fluid, or you can remove the fluid surgically by cracking the chest and placing the drainage catheter that way. Another type of pericardial disease that's somewhat similar to cardiac tamponade, although it's much less acute and less dramatic, it's also lower yield for your test overall, but that's chronic constrictive pericarditis. So this is where the pericardium becomes scarred over time, and instead of being a pliable, elastic structure, it becomes rigid and fibrous, which means that it constricts the heart and prevents the ventricles from fully expanding during diastole. So chronic constrictive pericarditis results in decreased diastolic filling and decreased cardiac output. Constrictive pericarditis can occur following cardiac surgery or following radiation, and is often idiopathic. It usually causes symptoms of heart failure, like exertional dyspnea and fatigue, and also some peripheral edema. Physical exam usually shows JVD and Kussmaul's sign. So let's review what Kussmaul's sign is. First of all, Kussmaul's sign is different from Kussmaul's breathing, which is that deep labored breathing that we see in patients with severe DKA. So what is Kussmaul's sign? Kussmaul's sign is JVD that occurs during inspiration. Normally, inspiration decreases the intrathoracic pressure, and blood in the jugular veins and the subclavian veins and the SVC all flows more easily into the right atrium. That means that during inspiration, the jugular venous pressure decreases. That's normal. So you kind of put the patient at about 45 degrees and have them turn their head so that you have a good view of the jugular vein, and you ask them to take a deep breath. Normally, when they take that deep breath, the jugular pressure is going to decrease, or the jugular vein may completely collapse. But with constrictive pericarditis, there's not really much room for the right atrium and the right ventricle to expand and fill with blood. So even during inspiration, the jugular venous pressure remains elevated and the jugular veins remain distended. So JVD during inspiration is called Kussmaul's sign, and it's very commonly seen in constrictive pericarditis. But you can also see Kussmaul's sign in other diseases that impair right ventricular relaxation and filling, such as restrictive cardiomyopathy, right ventricular infarction, tricuspid stenosis, massive pulmonary embolism, and possibly right-sided CHF. Now, what's not on this list? Cardiac tamponade. Cardiac tamponade rarely, if ever, causes Kussmaul's sign. Some experts even say it never happens with tamponade. So remember, Kussmaul's sign with constrictive pericarditis, pulsus paradoxus with tamponade. Kussmaul's sign is caused by decreased capacity of the right ventricle. Pulsus paradoxus is caused by decreased capacity of the left ventricle. Now you can confirm the diagnosis with an echocardiogram. You're going to see thickening of the pericardium, and most of the diastolic filling of the ventricles takes place in early diastole. A chest x-ray can also be helpful because you might see some calcification of the pericardium, which you see here indicated by the arrows. That's a very specific finding, but it's not very sensitive because a majority of patients do not have these calcifications. So If you see it, great, but if not, you can't rule out constrictive pericarditis. And then the treatment is basically surgical. You do a pericardiectomy. You have to go in and remove part of the pericardium to relieve the constriction. And unfortunately, this surgery has a very high mortality rate, around 10%. Let's wrap up by saying a word or two about left atrial myxomas. Again, not a pericardial disease and not terribly high yield, but if you're going to see any question about cardiac tumors, it's most likely going to be a myxoma. Myxomas are the most common primary cardiac tumor in adults, and by far the most common location is the left atrium. About 75 to 80% of myxomas occur in the left atrium. So remember the phrase left atrial myxoma. Now, as the myxoma grows, it can form this little ball of tissue in the atrium, and it often behaves kind of like a ball valve that obstructs the mitral valve, and that can cause syncope. So as blood is flowing into the ventricle during diastole, that myxoma ball obstructs blood flow from the atrium into the ventricle. So during systole, there's actually no blood in the ventricle to pump forward, and the patient has syncope. Now, rarely these myxomas can flop into the left ventricle at the beginning of diastole, and that causes an early diastolic sound called a tumor plop. And the diagnosis is usually made on echocardiogram, where you see a big ball-shaped structure in the left atrium. Then the treatment is to resect the myxoma, because even though it isn't malignant, that syncope and cardiac obstruction is certainly life-threatening. Now it's time for the end of session quiz. So answer those questions, and we'll run through the answers together. All right, first question. What ECG findings are suggestive of acute pericarditis, and what ECG findings are suggestive of cardiac tamponade? So in acute pericarditis, the ECG findings are diffuse ST segment elevation and PR depression. And then for cardiac tamponade, the ECG findings are electrical alternans and low voltage ECG. Next, what are the components of Beck's triad, and what diagnosis is suspected in patients with these findings? So Beck's triad is the triad of hypotension, JVD, and muffled heart sounds. And if you see that, you should think about cardiac tamponade. Next, what's the primary treatment for each of the following conditions? So for left atrial myxoma, you're going to do surgical resection of the myxoma. For acute pericarditis, we're going to treat empirically with NSAIDs and possibly with colchicine. For chronic constrictive pericarditis, you're going to do a pericardiectomy. And for cardiac tamponade, the primary treatment is pericardiocentesis. And the last question, what is pulsus paradoxus? Pulsus paradoxus is a decrease of systolic blood pressure by more than 10 millimeters mercury during inspiration, and it's most commonly associated with cardiac tamponade. Now, several other conditions can cause pulsus paradoxus, but the main one you should remember is cardiac tamponade. All right, that's it for now. I'll see you next time.
Let's go through the warm-up. First question, which lipid-lowering agent binds C. diff toxin? That's cholestyramine. But remember, this is only used as adjunctive therapy for relapsing C. diff infections. It's not the first-line treatment. Next, what's the significance of a new left bundle branch block in a patient with acute angina? So in a patient with chest pain, a new left bundle branch block on EKG suggests a myocardial infarction. Now, if you see left bundle branch block in a patient who comes in with chest pain, you need to try to compare an old EKG, and if the bundle branch block is old, then it's less worrisome. But if that bundle branch block is new, that could be significant. And the last question, how do calcium channel blockers work to reduce the ischemic effects of acute angina? Well, calcium channel blockers promote coronary and peripheral vasodilation, and they also reduce myocardial contractility, which helps to reduce myocardial oxygen demand. Now let's move on to the lecture.
Hello everyone and welcome to our Step 2 video on arrhythmias. Today is Mailbag Day. So every once in a while I like to read some of the feedback we get back from students. So here we have a letter from Mike. Dear Dr. Lewis, you are amazing. Well, thank you. Not only are you brilliant, but I laugh myself silly at all your ingenious intros. Sometimes I feel like you're the only one who really understands me. Do you think you could send me some of your beard trimmings? JK. But really, that would be cool. Oh, and it looks like he attached a picture here. Oh, Didn't realize he was such a fan? All right, well, let's move on. Today we're going to talk about some arrhythmias, but before we delve too deeply into abnormal ECGs, let's do a quick refresher on normal electrocardiography. Okay, so when you're looking at an ECG, there are tiny little boxes all over the place, and for every 5 boxes, you're going to see one of these big bolded boxes. Now, each tiny little box is 1 millimeter, and each 1 millimeter segment is going to represent 0.04 seconds, so not much time. And then for every 5 boxes, you have that bolded box, and that's going to be 5 millimeters, and then you just multiply it out. It's 0.2 seconds, or 200 milliseconds. So let's look at a normal ECG here. What is the first bump in the tracing? Remember, that's going to be your P wave. And the P wave is going to represent atrial depolarization. Now, the signal is starting in the SA node, and then it's going to travel through the atria and then get to the AV node. Now, after the P wave, we get to the QRS complex. But before we talk about that, we need to talk about the PR interval. So what is the PR interval? Well, it measures from the beginning of the P wave to the beginning of the QRS segment. Now, it's actually stopping at the Q, not at the R. That can be a little bit confusing, I know. Now, the PR interval is a measurement of the conduction delay through the AV node. Now, normally, the PR interval is less than 200 milliseconds. So if you see a PR interval that is longer than one giant bold box, then that is going to be a prolonged PR interval, which can then indicate maybe something like a heart block, and we're going to talk about that in detail later. Now, the QRS segment is a ventricular depolarization, which is how long it takes for the signal to get from the top of the ventricle to the bottom. Now, you'll notice that the amplitude of the QRS is much larger than the P wave, and that's because the ventricles have a much larger mass of muscle. Now, normally, your ventricles are depolarizing at the same time. The electrical signal goes through the Purkinje system and the bundle of His, and you have equal depolarization of both ventricles. Now, the reason why the QRS complex is very narrow and less than 120 milliseconds is because you are depolarizing the ventricles again at the same time. So how many boxes is 120 milliseconds? Remember, that's just 3 small boxes. Your QRS complex should be within 3 small boxes. Well, let's just say that you don't go through that Purkinje system, the bundle of His, and you depolarize maybe the right ventricle first, and then finally it's going to depolarize the left ventricle next. And that's going to take a lot longer and will result in what we call a widened QRS complex. This could be a ventricular rhythm, meaning that the signal is not originating from the AV node, but rather somewhere else in the ventricle. Now, the normal, very fast signal through that heart starts again from that SA node. It's going to travel down the AV node, and then the signal speeds down the bundle of His and the Purkinje system. Now, if that signal starts or travels in a wrong direction, then you usually get an abnormal and probably a widened QRS. Now, the T wave is what's going to represent ventricular repolarization. So this is the recovery of the ventricle so that they can then be depolarized again. Now, the ST segment connects the QRS complex and the T wave. The ST segment represents the period when the ventricles are depolarized. And as many of you already know, when we talk about myocardial infarctions, we look in this area for any elevation or depression. We'll talk again about that later. Also, T-wave inversion may indicate a recent MI. And those T-waves, again, can also be affected by potassium levels. So if you see peaked T-waves, that might, again, indicate high potassium levels. And then again, flattened T-waves might indicate very low potassium. And then there's another wave called the U wave, and that's thought to be the repolarization of the papillary muscles or the Purkinje fibers. So these are often not seen and only sometimes appear after the T wave. Now, prominent U waves may be associated with hypokalemia or hypercalcemia, and then maybe even hyperthyroidism. All right, so now let's move on to heart blocks. So there are different types of atrioventricular or AV heart blocks. But simply put, an AV block is an interruption or delay of the signal from the atria to the ventricles. Now, the atria and the ventricles are having that really hard time communicating with each other, and it looks weird on the ECG. Now, this can be a functional or an anatomic impairment in that signal conduction. So first, let's talk about the first-degree heart block. So when looking for a first-degree heart block, we need to concentrate on the PR interval. Now, the PR interval is beginning from the P to the beginning of the QRS. Remember, it's not actually from the P to the R. Now, the PR is the time the electrical impulse takes to travel from the sinus node through the AV node. Now, the PR interval in a first-degree block is going to be greater than 0.2 seconds, which is how many boxes? Remember, that's 5 little boxes or 1 big box. Now, first-degree heart blocks can be caused by AV nodal disease, an increased vagal tone, or by drugs that increase the refractory time of the AV node. Now, those drugs include calcium channel blockers, beta blockers, and digoxin. Now, usually first-degree blocks are asymptomatic and treatment is generally not even necessary. Now let's take another look at the ECG here. So you can see that the PR interval is prolonged. It's definitely bigger than one big box. So that's that first-degree heart block. Be able to recognize all of these different ECGs, definitely very high yield. You're going to have some form of ECG on your test for sure. Now let's move on to the second-degree Mobitz type 1 heart block, which is also called Winky Bach. So I think of Winky Bach, you can kind of pronounce it one key Bach to help you remember this is a Mobitz type 1 heart block. And also don't get confused, even though this is a Mobitz type 1, this is not a first-degree heart block. This is a second-degree heart block. And this is almost always caused by AV node disease. So again, like first degree, things like beta blockers, digoxin, calcium channel blockers can actually cause a Mobitz type 1. Also, Mobitz type 1 can be seen in just normal people, but you can also see it in athletes, older adults, and patients with other types of heart disease. And luckily, Mobitz type 1 is generally asymptomatic as well. Now, the hallmark of the Mobitz type 1, the important part here, is that the ECG shows progressively lengthened PR intervals until you eventually block an entire QRS. And then it resets and begins again, and then you drop it again. Another kind of stupid way to remember this is by imagining a cheerleader yelling, "Longer, longer, longer drop. That's the signs of Winky Bach." So you're getting that progressively longer PR. So look again at the ECG. The PR interval is slowly getting longer. It's even each subsequent beat, you're getting a longer PR interval, and then that beat is going to skip or drop. So you finally see a P without a QRS. Now, the treatment might include adjusting the dosages of medications associated with that heart block. Otherwise, treatment is generally not necessary again unless there is symptomatic bradycardia. And if there's symptomatic bradycardia, then really the only thing to do is to put in a pacemaker. So now let's move on to another second-degree block. This is a Mobitz type 2 block. So this is generally caused by an infranodal conduction problem or below the node conduction problem. So this would include the bundle of His or the Purkinje fibers. And again, most of the time this is going to be asymptomatic. Now the ECG is going to show randomly skipped QRS complexes without changes in the PR interval. So another way I remember Winky Bach, which we just talked about before, is that the W in Winky Bach, that W stands for warning because of those progressive lengthening of the PR intervals gives you a warning that you're about to drop a QRS. But in Mobitz type 2, there is no warning. You just drop that QRS at some point. So you can see this on the ECG again here. You see the PR interval is not changing, but then just randomly you skip a beat, you skip a QRS. And as I said before, the block is usually asymptomatic, but it can progress to a third-degree heart block, so patients will often get a pacemaker in this situation. Speaking of, let's move on to that third-degree heart block. The third-degree heart block is sometimes referred to as a complete heart block. So this is caused by an absence of conduction between the atrium and the ventricles. So no signals are getting from the atria to the ventricles. And finally, these patients are going to have symptoms. So they didn't have symptoms before, but now we're actually seeing them. So patients are going to have syncope. They're going to have maybe some dizziness, some hypotension. And then on the ECG, there is, again, no relationship between the P waves and the QRS segments. So the Ps are doing their own thing, and the QRS complexes are doing their own thing as well. The QRS can be wide, maybe indicating an escape rhythm. The signal to the ventricles will often have to come from that AV node, so you might still see narrow QRS complexes. And then the treatment for third-degree heart block is going to be avoiding medications causing those AV conduction blockages that we talked about before, calcium channel blockers, beta blockers, digoxin. And this one absolutely is also going to need a ventricular pacemaker as well. So just as a review, which of these heart blocks do you get a ventricular pacemaker? Remember, it's the Mobitz type 2 and then the third-degree heart block. You're definitely going to want a pacemaker for those patients. Now, the first-degree heart block and the Mobitz type 1, you really don't need to do much of anything unless they are symptomatic. So always look for medications, again, causing or exacerbating those blocks. That might be the answer to your question 2 on treatment. All right, so let's move on. We're going to next talk about paroxysmal supraventricular tachycardia, or SVT, or PSVT. This is defined as a heart rate greater than 100, and that's going to be arising from the atria or the AV junction. So to be clear, things like AFib, atrial fibrillation, with rapid ventricular rate, that's a supraventricular rate, but it's not considered a paroxysmal supraventricular tachycardia. So don't even worry about that yet. We'll talk about AFib in another video. So in this situation, in our paroxysmal situation here, would you have a narrow QRS or a wide QRS? Well, again, anything arising at the AV junction or above is going to be narrow because your ventricles are going to be depolarizing equally, which is the way your ventricles are supposed to be depolarizing. So your QRS is going to be narrow. On the ECG, you're going to see that QRS taking up less than 3 small boxes, less than that 0.12 seconds. Now, paroxysmal supraventricular tachycardia occurs mostly in younger patients with healthy hearts. Most frequently, this is going to be a re-entry anomaly. So there's 2 different types of re-entry that we'll talk about. There's an AV nodal re-entry, and then there's one that's just called AV re-entry, like something like Wolff, Parkinson, White. So let's talk about this for a second. Let's talk about the AV nodal re-entry first. So there are slow and there's also fast conduction pathways in the AV node. And the conduction is going to proceed quickly through the fast pathway, and then it's going to progress up the slow pathway in the retrograde fashion. And then a conduction loop can be created, and this is going to result in what we call the reentrant tachycardia. And then in the AV reentry, like with Wolff, Parkinson, White, this is similar to AV nodal reentry, but instead of the slow and fast pathways with the AV node, you have a separate accessory conduction. Now, the most famous one is the bundle of Kent, but there are different accessory pathways. But if this accessory pathway exists between the atria and the ventricles, the return is a conduction impulse to the AV node to set up, again, a reentrant loop in a tachycardia situation. Now, the ECG may also show what's called a delta wave. So a delta wave is an upstroke just prior to the QRS. And of course, there would be tachycardia, but again, this is going to be a narrow QRS segment. So how do these patients present? Well, most of the time they're going to have things like palpitations. They might have some sudden tachycardia, maybe some chest pain, maybe some shortness of breath, maybe even some syncope. So how do we treat our PSVT? Well, initially you can start with carotid massage or a Valsalva maneuver, and that's going to hopefully halt the acute arrhythmias. But next, if that doesn't work, you can use IV adenosine. So adenosine is going to slow that rhythm way down, and you're going to be allowed to diagnose it as well while you're treating it. Now, if that doesn't work, then you can use things like calcium channel blockers or beta blockers. If nothing is working, then you can try cardioversion, or you can even do a catheter ablation of the accessory conduction pathways, and that can be performed for long-term control, used very often actually. Let's move on to the multifocal atrial tachycardia, or MAT. This is another type of supraventricular tachycardia. Now, it is more common in older patients this time, and it's also associated with COPD exacerbations. Try to make that connection in your brain. Now, like the name implies, there are several foci initiating electrical signals here. So instead of just the SA node initiating the primary signal, we have several spots initiating signals all over the place. And that's why on the ECG we see P waves with variable morphology. So let's look at these ECGs. So these P waves all look different from one another. So one might be more peaked, one might have a longer PR interval, one might be more flattened. So the morphology of those P waves is different because the P wave, again, with each particular beat is arising from a different ectopic focus. Now, generally, you have at least 3 different P wave morphologies and a heart rate, again, greater than 100, and it's going to be that multifocal atrial tachycardia. So, how do we treat multifocal atrial tachycardia? Well, calcium channel blockers are the big ones. Specifically, we're talking about verapamil and diltiazem. These are the non-dihydropyridines. Beta blockers might also be used for that multifocal atrial tachycardia as well. You also need to correct any hypokalemia or hypomagnesemia. Keep your potassium above 4, your magnesium above 2, because that can actually be curative for MAT as well. Catheter ablation or surgery to eliminate those abnormal pacemakers can be a more definitive treatment if it keeps coming back. So it's actually pretty similar to our PSVT as well. And then finally here, just very briefly, let's talk about bradycardia. So bradycardia is heart rate that's less than 50. Some other definitions have it less than 60 or less than 55, depending on who you're reading. And this can be caused by increased vagal tone, or you can have nodal disease as well. Now this is more common in the elderly patient again, especially who have a history of coronary artery disease and patients on beta blockers or calcium channel blockers. Now patients will often be asymptomatic, but they can have weakness, syncope, and a lot of fatigue. Treatment is stop the precipitating medication, so if they're on a bunch of beta blockers, just stop it or decrease it. A pacemaker might be needed if symptoms are frequent or severe. All right, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through that together. All right, first question here. What type of heart block is described by the following statements? First one here, we have a PR interval prolonged more than 0.2 seconds, or those 5 small boxes. Remember, that's going to be a first-degree heart block. Next, we have no relationship between P waves and QRSs, so this is a third-degree heart block, sometimes referred to as a complete heart block. Next, we have PR interval becoming progressively longer until a beat is blocked. So that's going to be that second-degree heart block. But which one? Mobitz type 1 or Winky block. Remember, longer drop. That's one. Winky block. That one. And then the next one we have here is PR interval is fixed, but you get an occasional blocked beat. That's going to be your second-degree Mobitz type 2. All right, moving on. Next question here. Which heart blocks need a pacemaker? Remember, there was a couple who didn't need it and a couple that did. So remember, our first one was our Mobitz type 2, and then also the complete or third-degree heart block. Next, what is the drug of choice in paroxysmal supraventricular tachycardia? So you can try doing things like carotid massage and Valsalva, but if that doesn't work, the drug you're going to go for is going to be adenosine, and you're going to give that IV as well. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up. First question. An 18-year-old man is found to have a systolic heart murmur heard best at the apex and the left lower sternal border. The murmur increases in intensity when the man stands after squatting. So what's the most likely diagnosis? Well, this is classic for hypertrophic cardiomyopathy. The murmur is not increased in intensity while squatting, but rather standing after squatting. The murmur intensity will also increase with the Valsalva maneuver. Next, what's the best treatment for hypertrophic cardiomyopathy? Well, beta blockers will slow down the heart and prolong diastole to increase ventricular filling. Then you also need to restrict physical exertion and avoid volume depletion. And the last question. A 52-year-old patient with diabetes comes to the ER with classic anginal chest pain and you suspect an MI. While waiting for the EKG, which treatments do you initiate immediately? So while you're waiting for the EKG and the chest x-ray and cardiac enzymes, you definitely want to give the patient a nitrate, like nitroglycerin or nitropaste applied to the chest, and also an aspirin. In fact, those two things will likely be done by the EMTs en route to the hospital. And then, if the patient's hypoxemic, you can give supplemental oxygen, but that's only beneficial when the patient's pulse ox is low. So, now it's time for the lecture.
Hello everyone and welcome to our Step 2 video on Arrhythmias Part 2. Okay, so in the last video I might have lightly suggested that Dr. McGinnis was a beard-loving Dr. Lewis groupie. That maybe wasn't in the strictest terms the truth. So I'm sorry. But who is the real Dr. McGinnis? Let's look at some equations. Okay, here we go. Doctor plus color-coordinated shirts plus teleprompter equals Dr. McGinnis. All right, so that tells us just a little bit. Let's try another one. Dr. McGinnis plus sweater equals Mr. Rogers. Haha. All right, one more. Dr. McGinnis plus beard minus lameness multiplied by humor equals Dr. Lewis. See? We can't argue with math. All right. So let's move on today. We're going to finish up our arrhythmias. And the first one we're going to talk about is atrial fibrillation. So atrial fibrillation, AFib, is one of the most common cardiac arrhythmias. It is described as a rapid, irregular rhythm. Now on ECG, the RR intervals follow no repetitive pattern. And the reason for this is that there are uncoordinated atrial contractions. So those atria are so overstimulated with signals that there are only maybe a few normal, if any, atrial contractions. They just kind of quiver a bit, but they don't have real satisfying squeezes and those electrical signals aren't getting to the ventricles in an orderly fashion. So on that ECG, you might see some activity that might look like P waves, but by definition, there are no distinct P waves with AFib. Remember that. So what are the risk factors? Well, risk factors for AFib are going to include a lot of things. Pulmonary disease, coronary artery disease, hypertension, anemia, valvular disease, pericarditis, hyperthyroidism, rheumatic heart disease, sepsis, alcoholism. So a ton of stuff non-specific, but definitely hyperthyroidism is definitely a very high yield classic step question. So remember that one causing AFib. Now, what about some history and physical? Well, patients sometimes can be asymptomatic. They may not know they're in AFib, but others will have things like shortness of breath, chest pain, palpitations. They might actually notice that their pulse seems irregular. So again, looking at the ECG, important stuff here. You see no discernible P waves and an irregular QRS rate. So the QRS is going to be narrow, though, in atrial fibrillation. Even though the rhythm is off, the actual QRS complexes look pretty normal most of the time. They are going to be still very narrow. Now, what about treatment? So there's a few different ways that you can treat atrial fibrillation. First of all, if you have a patient with new onset AFib with a known duration of less than 48 hours, then you can actually cardiovert that patient to a regular rhythm right away. So classically, this is a patient that may be already in the hospital that's on a monitor. You can actually see that transition. Or maybe there's an ECG that was taken in the morning that didn't show AFib, and then later that patient started having palpitations, so you get another ECG, and then you see the AFib in that second ECG. So it doesn't happen very often, but that's where you can see that. But so what's the big deal? What's the danger of cardioverting beyond 48 hours? Well, because the atria are not contracting very regularly, I kind of think of them just kind of quivering, then you get stagnation of blood in the atria. And then that can form a thrombus. Now, if you then convert them into a regular rhythm all of a sudden, then you get a nice big atrial contraction, and then that could then dislodge a thrombus, which will then travel to the lungs or to the brain and cause major problems. So if it's been less than 2 days, then that's not enough time to generate an atrial thrombus. Therefore, it's safe to proceed with that synchronized cardioversion to get them out of that AFib right away. Now, cardioversion could be done a lot later on, but you have to anticoagulate that patient first and then cardiovert. Now, let's talk about something else. Now, what if someone has chronic AFib? Maybe you don't know when it started, or they haven't had success with cardioverting in the past. What are you going to do with these patients? Well, so we have two major treatment options here as well. So for both strategies, the patient will need to be anticoagulated, unless it's contraindicated for some other reason. You also want to know if a thrombus has already formed. So how do we rule out a thrombus in the atria? Well, you're going to want to get a transesophageal echocardiogram. The transthoracic echo is not sufficient. An echo through the esophagus is the only way to rule out that atrial thrombus completely. So, what are we going to use to anticoagulate our patient after that? Well, we generally use heparin and warfarin. Heparin, or low molecular weight heparin, which is used more often, has to be on board for a few days while that warfarin becomes therapeutic. Because warfarin inhibits protein CNS a little bit earlier than it inhibits the other coagulation factors 2, 7, 9, and 10. So consequently, when you start warfarin, you become maybe slightly hypercoagulable temporarily, which is why you always start heparin when you start warfarin. And then you can continue that heparin and then stop it once that warfarin becomes therapeutic. Now, after we anticoagulate the patient, we next need to decide to either rate control the patient or rhythm control the patient. Now, for rhythm control, we use medications like sotalol or amiodarone. Now, the goal is to get them to a sinus rhythm, out of AFib completely. Now, unfortunately, these medications have side effects, and they can even be pro-arrhythmic in some situations. But if you get the patient into a sinus rhythm, very stable, then you can potentially get them off that anticoagulation, which is great. Now, the other option is just to leave them to AFib. Don't try to get them out of AFib anymore, but just to rate control them so they're not symptomatic or have really high rate. So the patient doesn't have any symptoms. Now, the medications we use here are the beta blockers, and we can also use the non-dihydropyridine calcium channel blockers, and then also digoxin. Now, there isn't much difference between rate control and rhythm control in regards to mortality. Now let's move on to atrial flutter. So atrial flutter is another supraventricular tachycardia that is caused by a reentrant rhythm in either the right or the left atrium. Now the risk factors pretty similar to AFib: coronary artery disease, congestive heart failure, COPD, valvular disease, pericarditis. Again, pretty much the same things that cause AFib can cause a flutter, but AFib is a lot more common than a flutter. You're not going to see that one very often clinically. Now, what are you going to see on the history and physical? Well, possibly patients, again, might be asymptomatic. They may not know that they have this going on, but you're probably going to have things like palpitations, maybe even syncope when it becomes bad. And then the big stuff that you're going to be tested on, the ECG. So this is going to be a regular tachycardia, and it's usually greater than 150 beats per minute with occasionally set ratio of P waves to the QRS. So it's usually easy to identify the atrial flutter on ECG because you'll see the kind of that classic sawtooth pattern. If you see that, that's going to be atrial flutter. Sawtooth pattern is what you got to remember. Now, where AFib was kind of very irregular, A-flutter is a lot more regular. It's still abnormal in appearance, but it won't look as chaotic as the AFib. And then for treatment for this one, it's often rate control. So just like with our AFib, rate control with calcium channel blockers, beta blockers. You could do an electrical or a chemical cardioversion if you're unable to control it with medications. You might even go to catheter ablation. That can be used to remove those ectopic foci in some cases. Now, complication-wise, unfortunately, A-flutter can degenerate into AFib. Moving on to premature ventricular contractions. This is also referred to as ventricular premature beats. You'll probably hear this most often referred to as PVCs. We've been saying that forever. So this is caused by ectopic beats from a ventricular origin. Now, thinking about that, will the PVC have a narrow QRS or a wide QRS? Well, it's going to be a wide QRS, so this is originating in the ventricles. And unfortunately, these are frequently benign. So they can also be caused by things like hypoxia or abnormal serum electrolyte levels. So again, make sure that your potassium and your magnesium are normal when you're looking at PVCs. Hyperthyroidism and even just caffeine are other causes as well. So what are you going to see on your history and physical? Well, most of the time patients are asymptomatic. They don't know that they're having these at all. Maybe you have some palpitations, maybe some syncope. Patients will describe maybe a sensation of a skipped beat or one very hard or heavy or dramatic beat. Now on ECG, you will see early and wide QRS without a preceding P wave, and that's kind of followed by a brief pause in the conduction as well. And this makes sense. The atria are not producing this beat. The origin of the electrical signal is coming from the ventricle, so there is no P wave before this PVC. And the PVCs actually become concerning for the development of other ventricular arrhythmias if there's more than 3 per minute. So you got to look at that ECG and maybe a longer strip to kind of look at how many PVCs are actually having here. And then let's talk about something else. When PVCs become something called ventricular tachycardia, what's the definition there? Well, when there's more than 3 in a row, that's when it's, a PVC will become a ventricular tachycardic rhythm. So there's concerning there when you get more than 3 in a row. Now, how are you going to treat these? Well, really none. There's no treatment needed at all if a patient is healthy and doing well and not feeling symptomatic. If they do become symptomatic or maybe something else is going on, sometimes beta blockers are used in patients with coronary artery disease, but even then, not all of the time. Now, speaking of ventricular tachycardia, VTach, again, is a series of 3 or more PVCs, and usually that heart rate is pretty rapid, somewhere between 160 and 240, so very, very rapid, uncomfortable. Now, these patients might be asymptomatic if the episode is very, very brief, but most of the time, patients will have palpitations, they're going to have syncope, hypertension. They will not be doing very well for too long if this keeps going. Now, for treatment, electrical cardioversion. So we treat ventricular tachycardia with electrical cardioversion followed by anti-arrhythmic medications. And then for recurrent VTach, potentially an internal defibrillator might be necessary as well. Now, why is such the big deal? Well, because of the complications. The complications of sustained VTach, it can quickly deteriorate into VFib if not corrected, and that's bad. Now, another type of ventricular tachycardia that's interesting is torsade de pointe. So torsades is VTach with a sine wave morphology. So in torsades, the QRS segments are wide, and then the amplitude will kind of fluctuate between small and large amplitudes. Now, the name comes from twisting of the points, or sometimes people have used the imagined twisting of a ribbon. That's kind of the wave sign pattern that you're going to see there. Now, unfortunately, torsades carries a pretty poor prognosis. Now, for treatment, magnesium is going to be your first line. So normally when we give magnesium, we give it over a period of time, like over 2 hours, 4 hours, 6 hours, a long period of time, depending on how much mag you're going to give. But in torsades, you push the mag. You're going to give a rapid IV bolus of magnesium. So if that magnesium doesn't work, other treatment options will include things like the antiarrhythmics, and you're going to use more specifically things like lidocaine and phenytoin. So now let's move on to ventricular fibrillation. So this is a bad one. VFib is a lack of ordered ventricular contractions, and that's going to lead to no cardiac output. So their heart is not pumping blood at all. So do we need to shock VFib? We absolutely do. Now, we don't shock things like asystole, but we absolutely do shock VFib because they're dying. So what are you going to see on that ECG? On the ECG, you're going to see this erratic tracing. It'll look horrible. No P waves, no QRS complexes anywhere. The tracing is just complete chaos. The heart is not pumping blood, and that patient is dying very, very quickly. So what are you going to do? Well, you're going to do CPR because they're dying right there, but you need to get immediate shock cardioversion as quickly as you can. All right, so the next section we're going to talk about anti-arrhythmic medications. We're going to go pretty quickly through this. So there are different classes, class 1, class 2, class 3, class 4. If you have a hard time remembering the mechanism of action for each, the mnemonic that you might remember from our step 1 course if you took that, no bad boy keeps clean. So class 1 is the no for sodium channel blockers, that NA. Class 2, bad boy stands for beta blockers. Class 3, the keeps is for potassium channel blockers, and then the clean is, the C is for calcium channel blockers. And again, the calcium channel blockers, we're talking about the non-dihydropyridines, which include verapamil and diltiazem. Now, another good mnemonic that we've heard about is the some block potassium channels, so same order there, and that one's a bit more specific, but use whichever one you can remember best. Now, I think it's low yield to memorize all of the minute details on which antiarrhythmic to use in each individual situation. I think if you have a general idea where each class is used, then you'll be fine for your test. So first we have these sodium channel blockers, and they're actually broken into 3 groups just to make things more interesting. 1A, 1B, and 1C. Now the 1A include procainamide and quinidine. These are used for both supraventricular and ventricular arrhythmias. The 1B include things like lidocaine and toconide. They're going to be used for just ventricular arrhythmias. And then the 1C include things like flecainide and propafenone. Flecainide is used for paroxysmal AFib, but you're also going to use it for PSVT and for ventricular arrhythmias as well. Class 2, those are going to be your beta blockers, and they have many uses. So probably most commonly we're using them for things like blood pressure or ischemic heart disease. But for rate control in AFib and A-flutter, that's a great use for beta blockers. You can also use it for MAT, that multifocal atrial tachycardia. We're going to use those beta blockers as well. So think about atrial tachycardia when you think of beta blockers and arrhythmias. Now for the potassium channel blockers, amiodarone, sotalol, beryllium, these are used primarily for AFib and for A-flutter, and that's for rhythm control. So you're not just giving it to reduce the rate, you're going to actually try to convert them medically back into a normal rhythm. Now one high yield fact that you should know is that amiodarone can cause a lot of problems. They can cause things like pulmonary fibrosis. They can also affect the liver and the thyroid. So that's why when you're going to check things for amiodarone, you want to check your PFTs, pulmonary function test, LFTs, the liver function test, and the TFTs, which are the thyroid function tests. And then finally, our calcium channel blockers are used for rate control. Again, kind of similar to our beta blockers. We're using it for AFib, for A-flutter. We're using it for our supraventricular type problems. Okay. So that's a lot of information, though. I want to do a big arrhythmia review in our Lewis notes before we get to the end of session quiz. Hello everyone, and welcome to another Lewis notes, and this is going to be a tricky one. We have to remember all of our anti-arrhythmic classes. This is kind of a pain, but you should probably do something like this on your own a couple different times to make sure you really have this in your brain, because you do need to know it. So we've got all of our list of antiarrhythmics on the right. We're going to match them to their class on the left. So we have class 1A, 1B, 1C, 2, 3, and 4. So let's go through these. So the first one we have here is quinidine. So quinidine is one of those beautiful class 1A antiarrhythmics. Lidocaine, we're going right on the line here. 1B is going to go right there. Flecainide, we're still got a good trend here. Flecainide is going to be a 1C. And then next we have metoprolol. Metoprolol is a beta blocker. All the beta blockers are going to be our class 2. So we're getting a little bit of everything here so far. Next we have procainamide. Procainamide, where's that going to go? Remember, procainamide is going to be over here in class 1A. Sotalol. Sotalol kind of sounds like a beta blocker, but it's not. It's actually a potassium channel blocker, so that's going to be over here in class 3. Mexiletine. Mexiletine is a 1B antiarrhythmic, so let's remember that one that goes right there. Disopyramide. Disopyramide is going to be up here in our class 1A. Propafenone. Propafenone is going to be a 1C antiarrhythmic. Propranolol, this one is a true beta blocker, so that one's going to go underneath our class 2. Toconide. So toconide is going to be a 1B antiarrhythmic. Amiodarone. Amiodarone kind of plays a couple different roles, but it's primarily considered a class 3 potassium channel blocker. Diltiazem, so we're first in this class here, diltiazem is a calcium channel blocker, and the calcium channel blockers are class 4. Itabutylide is another potassium channel blocker, so we're going to put that one right there. And then we have verapamil. Easily, that one's going to be down here with diltiazem because it is a calcium channel blocker. All right, guys, so I know that's a bit of a pain, but try to go through those a couple different times so you can get them stuck in your brain. All right, that's it for the lecture. It's time for that end of session quiz. Let's go through that together. All right, first question. Which endocrine disorder can cause atrial fibrillation? Well, the big one is going to be hyperthyroidism. Whenever you have new onset AFib, you definitely want to check TSH. Next question. Which antiarrhythmic should be avoided in patients with pre-existing lung disease? And the answer here is amiodarone. With amiodarone, you actually need to check pulmonary function tests, also with maybe some diffusion capacity before you actually start it to make sure that you're not starting it on someone that already has lung disease. And then you need to check PFTs again every so often, maybe every 6 to 12 months, probably closer to more 12 months, while the patient continues on it. Now, there's no definite guideline there. Then also, what else do you have to check? Remember, you got to check your LFTs because amiodarone can damage the liver, and you want to check TFTs, thyroid function test, because it can cause either hypo or even hyperthyroidism. Next, what is the treatment for sustained ventricular tachycardia? So remember, this is electrical cardioversion. Also make sure afterwards, if they get out of that their potassium and their magnesium are normal. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Hello! Don't mind that. That's my new neighbor, Cal. He's fixing up his old motorcycle. You know, I used to date bad boys like that. The sound of it still gets my heart aflutter. Anyway, stay focused. Where was I? Oh, what are the classes of antiarrhythmics? Class 1, sodium channel blockers. Class 2, beta blockers. Class 3, potassium channel blockers. And Class 4, calcium channel blockers. Well, no bad boy keeps clean. No, they don't, do they? I mean, I'm just gonna go say hello. We're neighbors anyway.
It's time for another 3-question warm-up. Let's get going. How do nitrates work to reduce the ischemic effects of acute angina? So remember, nitrates are going to cause peripheral venous dilation, which is going to decrease preload, which then is going to decrease the oxygen demand of the heart. Remember, these don't primarily work to dilate the coronary arteries. During ischemia, those coronary arteries are probably going to already be pretty maximally dilated. Next question. What physical examination findings would be expected in a patient with pericardial effusion? So you might get some diminished heart sounds, so difficult to palpate apical impulses as well. Next question. What are 2 measures of the severity of hypotension in cases of shock? So the 2 big ones you've got to think about are urine output and mental status. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
Dr. Lewis minus beard times ugly divided by square root of stupid face. Since you've just been reviewing arrhythmias, including some pretty nasty ones like VTAC and VFib, let's spend a moment reviewing a couple of algorithms for advanced cardiac life support, or ACLS. Now, I'm not going to pretend to teach you everything about ACLS and how to run a code. I'm going to assume that you've learned that already, and hopefully you've already become ACLS certified. And if so, this video might be a breeze. If not, this is going to cover what you need to know for step 2. First of all, there are some basic things you do when you encounter an unresponsive patient. This is sometimes called BLS, or basic life support. First, you check for responsiveness. And then if the patient really is unresponsive, you activate the emergency response system. You call a code. Or if you're out of the hospital, you call 911 and you send somebody to get the automatic defibrillator, if there's one handy. Then at this point, we used to start with what we called the ABCs: airway, breathing, and circulation. And that's still the case in trauma patients: airway and breathing first, and then circulation. But with the basic life support protocols and ACLS protocols, we focus first on circulation and chest compressions rather than on airway and breathing, because we've learned that circulation is probably more important. And anyway, it's advanced cardiac life support. So instead of ABC, it's CAB. But notice, the first thing you're supposed to do is check for breathing and then check the pulse. And if there is a pulse, you're going to ventilate as necessary with rescue breaths or a bag valve mask or intubate if needed. And you need to keep checking the pulse every couple of minutes. And if you're in the hospital, you're going to get them on a monitor and address whatever the rhythm is. Is it SVT? Is it VTach? Is it bradycardia? But if you find somebody unresponsive and they don't have a pulse, that's when things really get going. You just start chest compressions or CPR immediately. So again, circulation is considered somewhat more important than airway and breathing. Now the key to correct chest compressions is to remember the buzzwords hard and fast. You need to compress the chest at least 2 inches, so you lock your elbows and you put your body weight into it, and you need to compress at a rate of 100 beats per minute or more. And then between each compression, you let the chest recoil completely. And if you're all alone, you need to remember 30 to 2. 30 chest compressions, then 2 rescue breaths, then 30 more compressions, and then 2 more breaths. 30 and 2. But in the hospital, there's always a huge code team around, right? You're not doing this by yourself. You've got one person doing the bag valve mask, putting in an airway. You got somebody else doing the compressions, so you don't have to count and switch. You just do them both simultaneously. And then somebody else is running the code, looking at the rhythm and deciding what drugs to give and what to do next. And while it's important to learn these algorithms, you should also have realistic expectations. Most codes for cardiac arrest are unsuccessful. The statistics vary from region to region, and they vary by what type of arrest the patient's experienced. But even under the best of circumstances, only about 40% of patients that undergo a sudden cardiac arrest will survive to hospital discharge. And often it's more like 15 to 20% survival. In some samples, it's as low as 3% survival. So be aware that outcomes are not that great. That's not to say you shouldn't try hard and do your best, but be aware that most of the time, things often don't turn out well. There are 2 algorithms that are highest yield for step 2. Ventricular fibrillation and pulseless VTach, and PEA and asystole. Now, if they ask you anything about ACLS, it's likely to be one of these 2 algorithms, and both of them have to do with a pulseless cardiac arrest. And both algorithms are relatively simple. So let's start with VFib and VTach. We treat ventricular tachycardia with a pulse differently from VTach without a pulse. So if you see VTach on the monitor, the first thing you have to do is check the pulse. If there's no pulse, you treat it just like VFib because this is a life-threatening rhythm. But even if there is a pulse and the patient is totally stable and totally asymptomatic, you still want to act quickly because VTach will eventually degenerate into VFib, and then that will degenerate into asystole. Some types of tachycardia can be tolerated for a fairly long time. And if the patient's stable, you might have time to sort of think about it and scratch your head and decipher the EKG for a little while. But with sustained VTach, you've got to be able to recognize it right away and start treatment, because with VTach, the patient won't be stable for very long. So what do you do for VTach with a pulse? Well, there's a question in the study guide that says, what drugs are used in treating a stable asymptomatic ventricular tachycardia? The drug I want you to know is amiodarone. Now, you could also use procainamide or sotalol, but remember amiodarone first line. And then, if the drugs don't work, you're going to do a synchronized cardioversion, not a defibrillation, which is unsynchronized. This is a low-energy shock that is synchronized to the peak of the R wave to avoid shocking on the T wave and sending the patient into VFib. Now let's look at this algorithm for an unstable patient with either VFib or pulseless VTach. Make sure you know this one inside and out. The first thing you do is shock the patient, unsynchronized cardioversion, also known as defibrillation. Then you start CPR, hard and fast, 30 to 2, for 2 minutes while the defibrillator is recharging and while you're getting IV access or putting in a central line. And then after 2 minutes of CPR, you stop and reassess the rhythm on the monitor. Check for a pulse. And if the shock and CPR worked, and now they're in a different rhythm or they have a pulse, then you switch to that algorithm. But if they're still in VFib, you're going to shock again and resume CPR. And while you're doing CPR, after 2 shocks, you can start to give drugs. And the main drug we're going to go to again and again is epinephrine. 1 milligram of epinephrine IV every 3 to 5 minutes. During a code, there are lots of nurses and code team people standing around, and one of them's writing down everything that you give the patient for the medical record. So when you order that first dose of epinephrine, you tell the recorder, notify me every 3 minutes it's time for another dose of epinephrine. And you can always ask if it's time yet. But there's no maximum dose of epinephrine, so you're generally going to keep giving it over and over again for as long as you run the code. So you're shocking every 2 minutes, and you're giving epi every 3 minutes between the shocks. And that's why those chest compressions are so important, to keep blood circulating a little bit so that the drugs can get to the heart. So you shock every 2 minutes, you give epi every 3, and after a third shock, you might consider amiodarone. You give a 300 milligram IV bolus of amiodarone, And then if you decide to repeat it later, the second dose is smaller, 150 milligrams. And you're still shocking every 2 minutes and giving epi every 3. And then the other important thing is that while all this is going on, you're going to try to think about the possible causes of the arrest, like MI, PE, tension pneumo, acidosis, hyperkalemia. We're going to talk about all those at the very end of this video. Most of the time, you won't figure out anything specific until the code is over. But if you can get some blood and you can do some basic labs, you might be able to figure it out and correct the underlying problem. VFib and pulseless VTAC are very common forms of cardiac arrest. Remember, VFib is the most common lethal arrhythmia following an MI. So this is common. And that's one reason to really know this algorithm inside and out. But be aware, most of the time the patient isn't going to stay in VFib or VTAC for minutes and minutes at a time. They're going to go into asystole or PEA or some other rhythm. That's why we always stop CPR and reassess the rhythm every 2 minutes. Because once they go from VFib to asystole, you're no longer supposed to follow the VFib protocol. You need to follow the asystole protocol. We'll talk about that one shortly. Let's review the treatment for one other type of tachycardia, which is supraventricular tachycardia, or SVT. Now, we're not going to go through the entire tachycardia algorithm. It's really convoluted, and it's not high yield for step 2. But what's the treatment for SVT? Well, the first line treatment is to attempt vagal maneuvers, which will suppress the tachycardia. So you can have the patient Valsalva. That's going to increase vagal tone, and it may slow down the heart and break the SVT. Or you can do a carotid massage, which is where you mash on the carotid sinus, and you're basically tricking the body into thinking that the blood pressure is really high so that you get a reflexive increase in vagal tone, which again is going to slow down the heart. When the heart slows down, you might be able to get a better look at the underlying rhythm, because if you've got tachycardia at 250 or 300 beats a minute, that's going so fast you can't really tell what's going on. So you do carotid massage, you do the Valsalva, and if you can get the rhythm to slow down from 250 down to around 100, you might be able to get a better idea of what you're dealing with so you can treat it. Or sometimes that increased vagal tone will simply break the SVT altogether. Then, if that doesn't work, you can give adenosine, a quick IV push of adenosine. Now, adenosine only lasts a few seconds in the body, so you have to give it very quickly. And adenosine hyperpolarizes the heart and actually stops the heart for just a moment. And then when it restarts, it may reset at a normal sinus rhythm, or maybe you're just going to slow it down enough to say, aha, this is WPW or A flutter or whatever. Now, one thing I want to mention is that even though the effects of adenosine only last 10 to 15 seconds, it causes some really uncomfortable side effects that you need to know about and you need to warn your patients about. So adenosine causes an intense transient flushing sensation and also some chest pain and hypotension. It only lasts a few seconds, but it's really uncomfortable. So warn your patients so they don't freak out and think they're dying. The other thing is it's working by stopping the heart, only for a few seconds, but still, it's a good idea to turn down the volume on the heart monitor. Otherwise, the patient gets this chest pain and this flushing sensation, and they hear the flat line on the monitor, and they think, I'm dying. So be aware of that. Now, you might try 2 doses of adenosine over the course of a couple of minutes. And if that doesn't work and there's still an SVT, you're going to try to slow down the heart rate with either a non-dihydropyridine calcium channel blocker like diltiazem or with a beta blocker like metoprolol. So the same drugs we typically use for rate control in AFib. The other ACLS protocol you should know covers 2 more types of pulseless cardiac arrest, PEA and asystole. Now, PEA stands for pulseless electrical activity. So there's some kind of electrical activity on the cardiac monitor, but there's no pulse. And asystole is flatline, right? So how do we treat this? You break out the paddles and shock the patient? No, never shock asystole, regardless of what you see in TV and the movies. Asystole is not a shockable rhythm. And we don't shock PEA either, unless that electrical activity is VTAC or VFib. So what do we do for asystole and PEA? This is pretty straightforward. You do your primary survey, check for a pulse and start CPR, hard and fast, 30 to 2. And then the drug you're going to use is epinephrine, 1 milligram every 3 to 5 minutes, just like we did with VFib. Then the other key part of this algorithm is the box that says evaluate and treat reversible causes. That means you need to run through this list of possible causes of asystole or PEA, and if there's any remote chance that one of these is going on, you're going to try and treat it. So we group these reversible causes into the H causes and the T causes. The H causes are hypovolemia. So if you decide that's the underlying cause, you can do rapid volume resuscitation through multiple IV sites or a central line. The next one is hypoxemia. So you can correct that via intubation or supplemental oxygen or put in a chest tube if there's a pneumothorax. The next one is hydrogen ions or acidosis. So you might give 1 or 2 amps of bicarb as an IV push.
This is commonly needed in a prolonged code because if you have extended periods of hypoxia, you're going to have some lactic acidosis. You can also have hyperkalemia, which is also common in prolonged codes because of the acidosis. So you're going to give IV calcium chloride or IV calcium gluconate to stabilize the myocardium. You can also give bicarb to raise the pH, and that's going to drive some potassium back into the cells. And you give insulin to drive the potassium back into the cells along with some glucose to prevent hypoglycemia. The next one is hypokalemia. So if that's present, you would administer IV potassium chloride. Next is hypoglycemia. So always check a finger stick during the code. And you can give an amp of D50 to treat that. And then the last H is hypothermia, which you treat by warming the patient. And then the T causes are tamponade. So if there's a massive pericardial effusion, you would do a pericardiocentesis to remove fluid from the pericardial space. Tension pneumothorax. So for that you would do a needle decompression and then a chest tube. And thrombosis can cause PEA or asystole. And really we're talking about two specific types of thrombosis, either an MI or a PE. So this first one is thrombosis MI. And here you do a cardiac cath or a thrombolytic like TPA or streptokinase. Then after that is thrombosis PE. So here you do a thrombolytic like TPA, or you could do a thrombectomy because this is a massive PE that's going to kill the patient if you can't get the circulation going again. The next T is trauma, and you're going to follow the trauma protocols to manage that. Then the last T is for toxins, some type of toxic overdose. So you might look at what meds the patient's been getting and see if there's a problem there. You definitely need to know these H's and T's and be able to think through them in any code. It's not enough just to resuscitate the patient. You really need to figure out why the patient coded in the first place.
Now, how do you know when to stop coding a patient? Well, there's no hard and fast rule, but the protocol suggests 20 to 30 minutes. In practice, you're going to ask that nurse who's recording everything how long the patient's been down, and then maybe ask the team who's there if anybody has any other ideas about interventions you can try, and then ask if anybody feels uncomfortable stopping the code. You don't ever want to stop a code if somebody on the code team thinks you haven't given it your best shot. But almost all the time, everybody recognizes the futility of continuing. So that's it for ACLS. Now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go through the answers together. First question, what's the maximum number of epinephrine doses that can be given when treating cardiac arrest? There is no maximum. Just keep giving it every 3 to 5 minutes. Next, in treating pulseless VTAC, what drug may be used after the first dose of epinephrine? That's amiodarone. The last question, what is the ACLS protocol for ventricular fibrillation? So you're going to start with emergency defibrillation and then start CPR. Then after 2 minutes of CPR, you check the rhythm, and then you shock again and resume CPR and start giving epinephrine 1 milligram IV every 3 to 5 minutes and shock every 2 minutes. And then after the first dose of epinephrine, you can give an IV bolus of amiodarone. And of course, evaluate those reversible H and T causes and treat if possible. That's it for now. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. A hospitalized patient develops atrial fibrillation with rapid ventricular rate. The patient has a prior history of chronic atrial fibrillation. Which study must be performed before the patient may undergo cardioversion? So the answer is going to be a transesophageal echocardiogram, or a TEE. So a TEE is the best way to rule out any atrial thrombus. Next question. What are the classic physical findings that might be presented in a patient with bacterial endocarditis? So you might see or hear a new heart murmur. You might see the Osler's nodes, splinter hemorrhages, Janeway lesions, Roth spots, and those conjunctival hemorrhages as well. Next question. Which drugs block transmission through the AV node? So think about beta blockers. Think of the non-dihydropyridine calcium channel blockers, things like verapamil and diltiazem. Think of digoxin, and then also think about adenosine. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Before we dive into hypertension, I want to say one more word about Dr. Lewis's beard. The thing is, he struts around all day, stroking his chin, checking himself out in the mirror, talking to his beard. It's creepy. And the way he goes on and on, you'd think he invented beards. Newsflash, Chris, anybody can grow a beard. So let's turn our attention to more important things like hypertension. Hypertension is very common and very high yield for step 2. In this video, we're going to discuss essential hypertension, secondary hypertension, and hypertensive emergencies. Then in the next video, we'll talk about the treatment of hypertension. So first, let's review some basic definitions. Normal blood pressure is less than 120/80. Prehypertension is defined as systolic blood pressure of 120 to 139 or diastolic blood pressure of 80 to 89. So these patients don't technically have hypertension yet, but they are at risk. We might recommend they lose weight if indicated. We might recommend that they increase physical activity, and reduce sodium in their diet, and avoid excess alcohol. But weight loss is probably the most important intervention, and most people don't seem to recognize that. And then hypertension is defined as blood pressure of 140 over 90 or higher. So either the systolic or the diastolic can be above that cutoff. And you need elevated readings taken on 3 separate occasions, like one screening and then at least 2 rechecks, at least a couple of weeks apart. So make sure you know that. 3 blood pressure readings at 3 separate appointments to diagnose hypertension. The vast majority of hypertensive patients have essential hypertension, which is basically idiopathic hypertension or primary hypertension. We're going to talk about the causes of secondary hypertension a little bit later. But most of the time when somebody presents with hypertension, it's essential hypertension. So risk factors for hypertension include advancing age. So the older you get, the more likely you are to have hypertension. Obesity and weight gain are huge risk factors. And along with that is a sedentary lifestyle and physical inactivity. Family history is also important, and so is race. Hypertension is more common and often more severe in blacks than in whites. And it's very common in whites too, but the prevalence is much higher in blacks. And it often starts at a younger age in blacks than it does in whites. Excessive alcohol consumption is a risk factor for essential hypertension, and so is a high sodium diet, at least for some patients. A lot of patients aren't actually all that salt sensitive, but in the right patient, especially blacks, sodium intake can definitely raise the blood pressure. Now, most patients with hypertension are asymptomatic, but even without symptoms, the blood pressure can be doing a lot of unseen damage. Without going into a ton of detail, let's talk through some of the common complications of uncontrolled hypertension. We know that uncontrolled hypertension is a major risk factor for atherosclerosis, including things like coronary disease and stroke. Uncontrolled hypertension is also a major risk factor for hemorrhagic stroke. And in the video on cardiac output, we talked about the role of hypertensive heart disease in causing left ventricular hypertrophy, or LVH, and how that stiff, thickened left ventricle doesn't relax normally, and that can lead to diastolic heart failure. So in patients with newly diagnosed hypertension, you want to listen for an S4 heart sound, and you want to check for evidence of LVH on EKG or on echocardiogram. Hypertension is also a big risk factor for thoracic aortic dissection and abdominal aortic aneurysms. We know that hypertension is a major cause of chronic kidney disease. And kidney disease can also cause hypertension, so it's a little bit of chicken or the egg. And then hypertension can also cause retinopathy, and it can worsen a lot of other eye diseases. And I want to briefly look at some common eye findings on fundoscopic exam, things like arteriovenous nicking, cotton wool spots, and retinal hemorrhages. Now, AV nicking, or arteriovenous nicking, is where the darker vein seems to disappear right where it crosses under the lighter colored arteriole. So you can think about chronic hypertension causing arteriolosclerosis, and then the arteriolar wall gets so thick that it kind of obscures the vein right where it crosses. Now, in this eye, we see cotton wool spots, which are due to microinfarctions of the retina. There are lots of different things that can cause cotton wool spots, but hypertension is one of the most common. And then in this image, this is a patient with diabetic retinopathy rather than hypertensive eye disease, but I want to point out these flame hemorrhages. So you can see flame hemorrhages in a lot of different eye diseases, including hypertension, diabetes, and also in central retinal vein occlusion. Now let's talk about secondary hypertension. Around 95% of patients with hypertension have essential hypertension, but now we're talking about secondary hypertension, which is hypertension due to some specific identifiable cause. So let's talk about some of these causes. The next question in the study guide is a clinical case. A 48-year-old woman with hypertension has persistently elevated blood pressure despite high doses of 4 antihypertensive drugs. So that's a clue that you might be dealing with secondary hypertension, when the blood pressure just won't get under control no matter what you throw at it. So physical exam reveals an abdominal bruit, and labs show hypokalemia. So first of all, what's the most likely diagnosis? Well, the most common cause of secondary hypertension is renal artery stenosis. And that abdominal bruit, or renal artery bruit, is a good clue for you. So is hypokalemia. So these patients can develop secondary hyperaldosteronism, where the narrowed renal artery basically reduces blood flow to the kidneys so that the kidneys think the blood pressure is low, and they start secreting renin, and they activate the renin-angiotensin-aldosterone system. So renin activates angiotensin 1, and that gets converted to angiotensin 2, Angiotensin II is a potent vasoconstrictor, which is why these patients have hypertension, because of vasoconstriction. But remember, angiotensin II also stimulates the release of aldosterone. And aldosterone causes retention of sodium in water and excretion of potassium in the urine. So when you see hypertension and hypokalemia, because they're excreting all the potassium in the urine, think about some type of hyperaldosteronism. Think about the possibility of renal artery stenosis. Now you should also know that there are two main types of renal artery stenosis. There's atherosclerosis, which is more common in patients over 50, and there's fibromuscular dysplasia of the renal artery, which is most common in younger patients, especially women. So say they give you a hypertensive patient with a renal artery bruit and hypokalemia, then they ask you what's the most appropriate test to make the diagnosis. Well, the best test is probably magnetic resonance angiography, or MRA, of the renal arteries. That's the most frequently used screening test. You could also do a spiral CT scan with IV contrast, or you could do a renal artery duplex scan, or even do a traditional renal arteriogram. And even though the arteriogram is considered the gold standard, the best test is the MRA because it's less invasive. Now, this is an angiogram of a patient with renal artery stenosis. And this patient actually has both atherosclerosis and fibromuscular dysplasia. So here's the catheter in the aorta, and it's injecting contrast into the renal artery. But there's a focal stenosis. That's the atherosclerotic lesion. Then here in the distal renal artery, there's an area that looks like beads on a string. That's the classic description of the findings for fibromuscular dysplasia. And then in this image, they've done angioplasty of the atherosclerotic lesion, and you can see the proximal vessel is now patent. So the third part of this question is about treatment options. Medical management is first line by just controlling the blood pressure. And I want you to make note that you have to avoid ACE inhibitors and ARBs in patients with bilateral renal artery stenosis because they're going to decrease the GFR and they can cause renal function to worsen. But in a patient that's failing medical management, like this patient who's already on 3 or 4 medications, blood pressure still elevated, the treatment's going to be angioplasty. And then in select patients, you would do bypass surgery. Now the next question is about other causes of secondary hypertension. We're going to go through these a lot faster. Chronic kidney disease or end-stage renal disease can cause secondary hypertension. That's usually not too difficult to diagnose. If the BUN and creatinine are elevated, you made the diagnosis. You can also see secondary hypertension from certain drugs and medications, especially oral contraceptive pills or OCPs, especially in women over the age of 35. And because of this, poorly controlled hypertension is a contraindication to starting OCPs. Then other drugs that can raise blood pressure include NSAIDs, antidepressants, and glucocorticoids. Think about it. If exogenous glucocorticoids can cause secondary hypertension, so can Cushing syndrome or hypercortisolism. So these patients are going to have Cushingoid features like truncal obesity, hirsutism, buffalo hump, abdominal striae, and so on. And then to work this up, you're going to check a cortisol level, an ACTH level, and you can do a dexamethasone suppression test. Now we're going to cover Cushing syndrome and all those tests in the endocrinology videos. This is just a quick summary. Another endocrine cause of secondary hypertension is primary hyperaldosteronism, or Conn syndrome. So we mentioned secondary hyperaldosteronism from renal artery stenosis. Well, primary hyperaldosteronism is where the adrenal glands are just pumping out too much aldosterone on their own. And the big clinical clue is a triad of hypertension plus hypokalemia plus metabolic alkalosis. Then the test for this is to measure the ratio of plasma aldosterone concentration to plasma renin activity. It's going to be high in a patient with primary hyperaldosteronism. The other adrenal cause of secondary hypertension is pheochromocytoma, which causes episodic hypertension associated with diaphoresis, tachycardia or palpitations, and also headaches. So how do we screen for pheo? We're going to check the 24-hour urine for catecholamines and metanephrines. And if that comes back positive, you're going to do a CT of the abdomen to see if you can find the tumor. Hypothyroidism and hyperthyroidism can both cause secondary hypertension, and so can hyperparathyroidism because of the hypercalcemia that you see with hyperparathyroidism. Remember, calcium drives smooth muscle contraction, and that causes peripheral vasoconstriction. Another cause would be coarctation of the aorta, which is where you have a focal narrowing in the distal aorta, like a kink in the hose. So coarctation is more common in Turner syndrome or in patients with congenital aortic valve pathology. It can also be associated with patent ductus arteriosus. So on physical exam, these patients may have high blood pressure in the arms, but then low blood pressure in the legs. They can also have weak dorsalis pedis pulses. And you can make the definitive diagnosis with an echocardiogram. And then finally, there's obstructive sleep apnea, which you would think of in an obese patient with daytime somnolence who snores a lot. And of course, you're going to diagnose that with a sleep study and most likely treat with a CPAP machine. Now let's talk about hypertensive urgency and hypertensive emergency, which is where the blood pressure spikes to dangerously high levels. Hypertensive urgency is usually defined as blood pressure over 180 over 120 with no symptoms and without evidence of end organ damage. So some sources call this severe asymptomatic hypertension. Then hypertensive emergency is blood pressure over 180 over 120 with end organ damage. So this could include renal disease, such as rising creatinine or hematuria, changes in mental status, which we sometimes call hypertensive encephalopathy. You can see papilledema from elevated intracranial pressure. You can have retinal vascular changes. You can have unstable angina or even an MI, aortic dissection, or pulmonary edema. So lots of very dangerous things. So if you have a patient with hugely elevated blood pressure above 180 over 120 and they're having chest pain, that's considered hypertensive emergency. Now the goal of treatment is generally to lower the blood pressure quickly, but not too quickly. I'll explain what I mean in just a moment. With hypertensive emergency, there are specific guidelines for lowering the blood pressure in aortic dissection versus stroke versus some of these other conditions. And there are specific drugs to use in each of those conditions. I think it's a little too much detail for step 2. But right now I want to talk about the treatment of hypertensive urgency. Our goal is to reduce the blood pressure to about 160 over 100 initially. And there's a theoretical concern that if you lower the blood pressure too much or lower it too quickly, the tissue won't be able to auto-regulate and you're going to get some ischemia. So in addition to lowering the blood pressure to this initial target of 160 over 100, we try not to reduce the mean arterial pressure by more than 25% in the first 2 to 3 hours to avoid that ischemia. Now it's a little easier to deal with this 25% target if you have an art line in that's measuring the blood pressure and calculating the mean arterial pressure for you on a beat-by-beat basis. So say the patient comes in with a blood pressure of 220 over 160. So that's a mean arterial pressure of 180. So 25% of 180 is 45. So you only want to lower the mean arterial pressure from 180 down to about 135 or so in the first 2 or 3 hours. So that could be a blood pressure of 180 over 110 or even 200 over 100 or whatever. So we're eventually trying to get the blood pressure down to 160 over 100, but you don't want to lower the blood pressure too much too quickly. And there are any number of drugs that are commonly used to lower the blood pressure acutely. You can use IV nitroprusside, you can use labetalol, you can use nicardipine. Sometimes we'll use clonidine or captopril or enalapril. It's not super important what drug you use, but you want to use something that works quickly and something you can titrate to avoid dropping the blood pressure too much. It's also important to start something for maintenance therapy at the same time you start that IV drug. So the ultimate goal is to get the patient off the IV medication, right? So when you start the IV drug, you should also start them on an oral drug. Then as the oral drug starts to kick in, you can wean them off the IV medicine. And your choice of drug may depend somewhat on what other comorbid medical problems the patient has, which we're going to talk about in the next video when we talk about antihypertensive drugs. See, Chris? Anybody can grow a beard. That was just in 20 minutes. All right, go ahead and work through the end of session quiz. First question. How many consecutive abnormally high readings are needed before prescribing blood pressure medications? So you need 3. Until then, you can recommend lifestyle changes like weight loss, low sodium diet, decreased alcohol intake, exercise. But don't make the diagnosis of hypertension based on a single reading. Next, what's the most common cause of secondary hypertension? Renal artery stenosis. And the last question, what's the most likely cause of secondary hypertension given each of the following findings? So high blood pressure in the arms, but low blood pressure in the legs. It's going to be coarctation of the aorta. Proteinuria suggests some type of renal disease. Hypokalemia, you're going to think about either primary hyperaldosteronism or renal artery stenosis, which causes secondary hyperaldosteronism. Tachycardia, diarrhea, and heat intolerance, that's hyperthyroidism. Hyperkalemia should make you think about renal failure. And then episodic sweating and tachycardia. So the episodic descriptor is a big tip-off that this is a pheochromocytoma. So that's it for hypertension. I think I'm going to go shave. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, what is the treatment for atrial fibrillation of unknown duration? Well, the answer is going to be rate control. That's going to be usually with either a beta blocker or a calcium channel blocker like verapamil or maybe even digoxin. Then you're also going to want to anticoagulate that patient. You're going to do this with warfarin and heparin. Next, which laboratory marker is used to help diagnose acute exacerbations of congestive heart failure? Remember, that's the BNP. Next, what two cardiovascular diseases are the biggest risk factors for CHF? So remember, it's going to be hypertension and ischemic heart disease. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about how to treat hypertension. I'm going to start first with the big picture, and then we'll dig into some of the details of specific drugs and classes. Now, by the big picture, I mean the JNC 8 guidelines for treating hypertension, which include both blood pressure goals and also recommendations for which drugs to use in certain patient populations. So we're going to start with the blood pressure goals first. Take a look at number 4 in your study guide. For patients under 60, the goal is to get the blood pressure below 140/90. For patients with diabetes or with chronic kidney disease, regardless of age, again, the goal is to get the blood pressure below 140/90. So the goal is the same. Now, we used to get more aggressive with these patients, but now the goal is just 140/90 or less. And then for patients 60 and older who do not have diabetes or chronic kidney disease, the goal blood pressure is less than 150/90. So in older, healthy patients, there's just no good evidence that lower blood pressure is really any safer. So basically, the goal is 140/90 for everybody except patients over 60 who do not have diabetes or chronic kidney disease. In those healthy older patients, the goal is 150/90. So it's pretty simple, even if it is a pretty big departure from previous guidelines. The JNC 8 guidelines also include some recommendations about choosing the right antihypertensive medication for your patient. Now we're going to go over those recommendations in a little bit, but first, let's look at the drugs themselves in this huge table at number 5 in your study guide. The first class I want to discuss is the ACE inhibitors. So these all end in pril: captopril, enalapril, fosinapril, lisinopril. There are a bunch of them. But ACE inhibitors lower the blood pressure by inhibiting the renin-angiotensin-aldosterone system. So let's review that for just a moment. Renin cleaves angiotensinogen into angiotensin 1, and then angiotensin-converting enzyme converts angiotensin 1 to angiotensin 2. And angiotensin 2 has two functions. It tenses angios, so it's a potent vasoconstrictor, and that raises blood pressure. And it also stimulates the adrenals to make aldosterone, and then aldosterone causes sodium and water retention. So ACE inhibitors inhibit angiotensin-converting enzyme, and they block the conversion of angiotensin 1 to angiotensin 2, so that results in less vasoconstriction, and the blood pressure decreases. Now, besides treating hypertension, ACE inhibitors are also indicated in post-MI patients and in CHF, and in patients with chronic kidney disease to prevent proteinuria. They're also used in diabetics to prevent progression of diabetic kidney disease and proteinuria. Now, you also need to know the side effect for all these antihypertensive drugs. Probably the most common side effect of ACE inhibitors is a persistent, dry, nagging cough, or maybe just a little persistent throat clearing. We think that's due to elevated levels of bradykinin. Angiotensin-converting enzyme not only converts angiotensin 1 to angiotensin 2, but it also breaks down bradykinin. So if you inhibit that enzyme, you're not going to be breaking down bradykinin, and the high bradykinin levels cause this dry cough. ACE inhibitors can also cause angioedema, which is also thought to be related to this excess bradykinin. Angioedema is swelling in the lips, and the tongue, and the oral cavity, so anywhere from the lips to the larynx. So it's potentially an important cause of airway compromise. So if you ever have a patient with ACE inhibitor-induced angioedema, you need to stop the ACE inhibitor immediately, and you can't ever start another one. ACE inhibitors can also lead to a little renal insufficiency, so you may see the BUN and creatinine kind of creep up a little bit. ACE inhibitors actually increase renal blood flow, which is why they're renal protective. But in doing so, they actually decrease the GFR because they're dilating the efferent arterioles. So decreased GFR means you're filtering less, so you're excreting less urea and less creatinine. So you're going to see a slight bump in the BUN and creatinine whenever you start an ACE inhibitor. Now, another important side effect is hyperkalemia. Renal insufficiency isn't necessarily a contraindication to ACE inhibitors, but hyperkalemia is a contraindication. So if you have a patient with kidney disease, they have a slight elevation of BUN and creatinine, you still want to try to get that patient on an ACE inhibitor if you can, because it's going to be renal protective. But if while they're on the ACE inhibitor they become hyperkalemic, then you have to stop it. And finally, don't forget that ACE inhibitors are teratogenic. And you can remember the teratogenic effect because we give ACE inhibitors to protect the kidneys, but in fetuses, they cause kidney damage. The next class of drugs is the angiotensin receptor blockers, or ARBs. So these all end in sartan. Candesartan, losartan, valsartan, and there's several more of these. These are very similar to the ACE inhibitors, except instead of inhibiting the angiotensin converting enzyme, ARBs directly inhibit the angiotensin receptor, which is downstream. And they're used for all the same indications as ACE inhibitors, and they cause a lot of the same side effects as ACE inhibitors, except cough. ARBs don't cause cough because they don't elevate bradykinin. ARBs don't inhibit angiotensin converting enzyme, so bradykinin is not going to build up. And if you don't have excess bradykinin, then you don't have the cough or the angioedema, theoretically. In theory, if you have a patient on an ACE inhibitor and they develop a cough or angioedema, you can stop the ACE inhibitor and then switch them to an ARB, and they should do okay. But in practice, of those patients that switch from an ACE inhibitor to an ARB because of angioedema, up to about 8% of those patients can still develop angioedema when they're taking the ARB. It's not really understood why, but it does happen. So personally, I don't feel comfortable switching to an ARB for a patient that had angioedema. For a cough, it's fine because coughs don't have the potential to kill people, but with angioedema, that's a different story. Now, for the purposes of step 2, feel free to use ARBs in place of ACE inhibitors in those angioedema patients. But in the real world, I say you need to be cautious. Now, one other antihypertensive drug that I want to just mention in passing is called aliskiren, and it's a direct renin inhibitor. Aliskiren acts even earlier in the renin-angiotensin-aldosterone system by inhibiting renin. Now, it doesn't get used as often as ACE inhibitors or ARBs get used, and it's only indicated to treat hypertension. It has not been proven to reduce post-MI mortality or to reduce CHF mortality or any of those other things. And I doubt you're going to see it on step 2. Another group of first-line antihypertensive drugs is the calcium channel blockers, which come in 2 flavors, dihydropyridines and non-dihydropyridines, which are really 2 very different types of medications. The dihydropyridines are drugs like amlodipine, felodipine, or nifedipine. And these block calcium channels in the vascular smooth muscle, so they cause some vasodilation. Besides treating hypertension, we also use dihydropyridines for prinzmetal angina, which is due to coronary vasospasm, and we use them to treat esophageal spasm, and also we use them for migraine prophylaxis. So all these uses are related to smooth muscle relaxation. And then the non-dihydropyridine calcium channel blockers are diltiazem and verapamil. These primarily block calcium channels at the heart. So they reduce cardiac output and they reduce heart rate, which is why we use them for rate control in AFib patients, sometimes in SVT. And again, verapamil can be used for migraine prophylaxis. Now for side effects, all calcium channel blockers can cause some peripheral edema, as well as headaches, constipation, and also some acid reflux because they're reducing smooth muscle contraction in the lower esophageal sphincter. And the non-dihydropyridines can also cause some bradycardia, which makes sense if they're slowing the heart rate in AFib and SVT. Next, I want to talk about thiazide diuretics. Now, we're going to cover diuretics more thoroughly in the nephrology videos, but we do use diuretics to treat hypertension, especially thiazide diuretics and sometimes potassium-sparing diuretics. Now, thiazides are one of the first-line options for treating hypertension. The thiazide that gets used most often is hydrochlorothiazide, or HCTZ. Now, there was an enormous head-to-head study called ALLHAT that showed that thiazides reduce the risk of stroke and other cardiovascular endpoints compared to several other classes of antihypertensives. But the catch is that the thiazide they used in the ALLHAT study was chlorthalidone. So you could make a pretty good argument that we ought to be using chlorthalidone instead of hydrochlorothiazide. Now, diuretics work by decreasing the intravascular volume initially, but thiazides also cause a little vasodilation, so the blood pressure remains lower even after the body corrects that initial volume depletion. Besides treating hypertension, we also use thiazides to treat volume overload states like CHF or kidney disease. The main side effects to be aware of with thiazides are hypokalemia and hyponatremia. Thiazides can also cause some hypercalcemia because they decrease the urinary excretion of calcium. You might remember the phrase loops lose calcium, thiazides retain calcium. So loop diuretics tend to increase urinary calcium excretion, but thiazides reduce calcium excretion. And thiazides are contraindicated in patients with sulfa allergy. Lots of diuretics are sulfa drugs. So those 4 classes, ACE inhibitors, ARBs, calcium channel blockers, and thiazides, are the 4 first-line options for treating hypertension according to the JNC8 guidelines. Now the rest of these classes would be less commonly used, starting with beta blockers, which may be a little surprising. The deal is that most studies show that beta blockers work just as well as ACE inhibitors or the calcium channel blockers, but some studies show a slightly increased risk of stroke. So JNC8 considers beta blockers to be a second-line option. Now, beta blockers are the happiest antihypertensives because they all end in LOL. You have atenolol, metoprolol, propranolol. There are non-selective beta blockers that act on both beta-1 and beta-2 receptors, and then there are beta-1 selective beta blockers or cardioselective beta blockers. You might remember that the beta-1 selective beta blockers generally begin with letters from the first half of the alphabet, like atenolol and metoprolol. And then the non-selective beta blockers begin with letters from the second half of the alphabet, like propranolol begins with P. Now there's also carvedilol, which ends in ILOL, and labetalol, which ends in ALOL. So that's going to help you remember that these aren't pure beta blockers. These also block alpha-1 receptors in addition to the beta receptors. Now, blocking the beta-1 receptors in the heart is going to decrease myocardial contractility, decrease heart rate, and also decrease cardiac output. And beta stimulation also stimulates the kidneys to release renin. So beta blockers decrease renin secretion, and that means they decrease some vasoconstriction. Now, beyond treating hypertension, we use beta blockers to treat CHF and coronary artery disease. Remember, anybody who has known coronary artery disease should be on a beta blocker. And we talked about how certain beta blockers have been proven to reduce mortality in patients with CHF. So which ones were those? Bisoprolol, carvedilol, and extended-release metoprolol. Now, propranolol can also be used to block some of the sympathetic symptoms of hyperthyroidism. It can be used for essential tremor and also for migraine prophylaxis. There's actually better evidence for using beta blockers than calcium channel blockers for migraine prophylaxis. And then sometimes performers will take propranolol to help prevent stage fright. So there are lots of different uses for beta blockers. Now, for side effects, non-selective beta blockers act in the lungs as well as the heart. So they can cause some bronchoconstriction. So those are going to be contraindicated in patients with asthma or COPD. Beta blockers reduce HDL a little bit, and they increase triglycerides, so that's not so good. And beta blockers can mask the adrenergic symptoms of hypoglycemia, such as tachycardia. So you have to use them cautiously in diabetics who are taking insulin or sulfonylurea because of the risk of hypoglycemia. Now, these drugs aren't strictly contraindicated in diabetic patients. You just have to use them with caution. And you may have heard that beta blockers cause some erectile dysfunction in men, but current research suggests that this might really be a placebo effect. Next up, we have the alpha blockers, the Zosins, like doxazosin, prazosin, and terazosin. These are alpha-1 adrenergic antagonists, which cause some vasodilation. Now, we don't really use them that much for treating hypertension, but we do use them for benign prostatic hyperplasia, because not only do they relax smooth muscle in the vasculature, but they also relax smooth muscle in the urethra and around the prostate. So they're going to help relieve urinary obstructive symptoms in patients with BPH. So if you have an older male patient with some urinary complaints from BPH in addition to hypertension, an alpha blocker wouldn't be a terrible choice. Side effects of alpha blockers include first-dose orthostatic hypotension, which is a classic side effect of these Zosins. You can also get some rebound hypertension when you stop them. There's also the drug clonidine, which is not on this table because it really isn't used that much, but you may run across it occasionally. Clonidine is an alpha-2 receptor agonist. Remember, alpha-1 receptors in the peripheral vasculature cause vasoconstriction, but alpha-2 receptors actually help to inhibit further norepinephrine release. So clonidine is an agonist to these alpha-2 receptors, so it's going to help to shut down norepinephrine release, and that's how it lowers blood pressure. Unfortunately, clonidine doesn't last very long, and it causes a lot of rebound hypertension. And it generally causes a ton of side effects like dry mouth and dizziness and drowsiness, sedation. So stay away from clonidine if at all possible. And the last group of drugs on your table are the vasodilators like hydralazine and minoxidil. These relax vascular smooth muscle in arteries and arterioles, and that causes some vasodilation. Now, both of these are second-line sort of adjunct drugs for hypertension. One of the brand names of minoxidil is Rogaine. It causes hypertrichosis or hair growth as a side effect. So sometimes minoxidil is used topically to treat male pattern baldness. But oral minoxidil is a particularly powerful antihypertensive. It works very, very well. Commonly, you're going to see it used third or fourth line in patients who are already on decent doses of 3 or 4 other meds, and you're just not getting the blood pressure under good control. I had a patient, a very sweet older lady, who was on 4 or 5 antihypertensives, and her blood pressure was still high. So I put her on minoxidil, and it worked like a charm until she started growing a little mustache, and we had to stop it. Then for side effects, vasodilators often cause some reflex tachycardia. They decrease the blood pressure, but since they're not really doing anything at the heart responds to that lower blood pressure by beating faster, so that's reflex tachycardia. And this could possibly lead to angina or an MI because as the heart rate rises, myocardial oxygen demand rises. So sometimes these vasodilators are going to be used in conjunction with a beta blocker to counteract that reflex tachycardia. And don't forget that hydralazine can cause drug-induced lupus. Now that we're familiar with the different types of drugs, let's go back to the JNC 8 recommendations about treatment. Number 6 in the study guide says, what are the JNC 8 recommendations for initial pharmacotherapy of hypertension in each of the following patient populations? So in patients with chronic kidney disease, the first-line treatment should be ACE inhibitors or ARBs. So we know that these drugs are renoprotective in general, so we're going to start with these drugs in patients with kidney disease. Now in blacks, specifically blacks without chronic kidney disease, treatment should start with a thiazide diuretic or a calcium channel blocker. In non-blacks, again, non-blacks without chronic kidney disease, you can still use a thiazide or a calcium channel blocker, or you can start an ACE inhibitor or an ARB. So in blacks, thiazides and calcium channel blockers improve cardiovascular outcomes a little bit more than ACE inhibitors do, so that's why those get preferred status. But again, in a black patient with chronic kidney disease, you'd want to start with an ACE inhibitor or an ARB. So those are the official recommendations in a nutshell. Beyond that, if the initial drug doesn't control the blood pressure adequately, you'd want to add another drug from these 4 recommended classes. And then ultimately, if you end up needing to use a different class, you might choose a drug based on the patient's comorbidities. For example, we've discussed how CHF patients and post-MI patients benefit from ACE inhibitors or ARBs, and also beta blockers, and aldosterone antagonists like spironolactone or eplerenone, because those drugs reduce mortality. In a patient with BPH, you might choose an alpha blocker like prazosin or doxazosin. In a patient with a history of migraines, a beta blocker might help prevent the migraines, or maybe a calcium channel blocker. On the other hand, if you have a patient with COPD or asthma, you might want to avoid beta blockers because of that bronchoconstriction. Or in a patient with CHF and a lot of peripheral edema, you might want to avoid calcium channel blockers because they cause some edema. And then in gout, you want to avoid diuretics because diuretics can increase serum uric acid and that can precipitate gout attacks. Now, JNC 8 doesn't specifically address treating hypertension in pregnancy, but some drugs are certainly safer than others. So the next question says, what antihypertensives are most commonly used in pregnancy and what antihypertensives are definitely unsafe in pregnancy? So a student sent us a great mnemonic for the most commonly used drugs. Hypertensive mothers love nifedipine. So the H is for hydralazine, the M is for methyldopa, the L is for labetalol, and the nifedipine is for nifedipine and other dihydropyridine calcium channel blockers. Now most OBGYNs use either methyldopa or labetalol first line. Hydralazine and nifedipine are used more as add-on drugs. And then the unsafe drugs are ACE inhibitors, ARBs, and aliskiren, that direct renin inhibitor. So we mentioned that these are contraindicated in pregnancy because they're teratogenic. You really want to stop these even before the woman becomes pregnant, if at all possible, if you know she's trying to conceive. Go ahead and switch to something else. So that's it for the antihypertensives. Now you're ready to pause the video and work through the end of session quiz, then we'll go over the answers together. All right, first question. What's the JNC 8 blood pressure goal in a 67-year-old black woman with a history of obesity, diabetes, and hypertension? So in healthy patients over 60, the goal is less than 150 over 90. But in patients with diabetes, the goal is less than 140 over 90. So that's your answer. Next, what drug classes are first-line options for initial antihypertensive therapy in each of the following patients? So a white woman with hypertension, you'd use an ACE inhibitor, an ARB, a calcium channel blocker, or a thiazide. In a black woman with hypertension, remember in blacks, the recommended first-line drugs are a calcium channel blocker or a thiazide. In a black woman with hypertension and chronic kidney disease, so remember in patients with chronic kidney disease, you want to start an ACE inhibitor or an ARB. And that's true regardless of the patient's race. And then the last one is basically our patient from the previous question, a black woman with hypertension, obesity, and diabetes. And here the answer is a calcium channel blocker or a thiazide. Diabetes is not an indication to use an ACE inhibitor or an ARB, according to JNC 8. Now, this is a black woman without chronic kidney disease, so you're going to use a calcium channel blocker or a thiazide. Now, if this patient has diabetic nephropathy and chronic kidney disease, that changes things. But as presented, an ACE inhibitor would not be recommended by the JNC 8 guidelines. And the last question, which antihypertensive drugs cause the following side effects? So first dose orthostatic hypotension is the alpha blockers. Hypertrichosis is minoxidil. Dry mouth, sedation, and severe rebound hypertension is clonidine. Bradycardia and asthma exacerbation could be seen with non-selective beta blockers. Reflex tachycardia would be the vasodilators. Cough would be ACE inhibitors. The ones you want to avoid in patients with sulfa allergy, lots of diuretics or sulfa drugs, including the thiazides. And then angioedema would be ACE inhibitors and possibly ARBs. In development of drug-induced lupus, that's hydralazine. What antibodies are seen in drug-induced lupus? Antihistone antibodies. All right, that's it for this video on antihypertensives. I'll see you next time.
What enzyme converts angiotensinogen to angiotensin 1? Renin. What enzyme converts angiotensin 1 to angiotensin 2? Angiotensin converting enzyme. What is the main action of angiotensin 2? Vasoconstriction and secretion of aldosterone. So blocking the action of angiotensin 2 will lower blood pressure. Who is driving this camera? You? Back up! Pay attention! Point the camera where I'm working and try to anticipate where I'm going to want it next. Is that so hard?
It's time for another 3-question warm-up. Let's get going. What is Bextrad for cardiac tamponade? So this is the triad. It's going to be hypotension, distant heart sounds, and then JVD. Next question. What are the 2 most common adverse effects of statin use, and which labs would reveal these effects? Remember hepatotoxicity, so you're going to do your liver function test, like your transaminases, that's going to be elevated. Usually it's going to be 2 times greater than normal. And then myopathy and myositis, so you could do a creatine kinase, or CK, that may be elevated in myositis, though it's often normal in just regular myopathy or just soreness of the muscles. Next, what is the treatment for endocarditis? So you're going to do long-term IV antibiotics required maybe about 4 to 6 weeks. Usually going to start with vancomycin initially. Now, once cultures come back, you can choose an antibiotic based on the sensitivity. And remember, the clinical pearl is this: get cultures before you start antibiotics. You want to know what you're going to need to treat. All right, that's the end of our warm-up. Let's get to that lecture now.
In this video, we're going to talk about vascular conditions such as aortic dissections and aortic aneurysms, atherosclerosis of the peripheral arteries, and DVTs, so a lot of big, important topics. So let's start with aortic dissection, which can occur anywhere in the aorta, from the chest down to the abdomen. An aortic dissection is a tear in the intima, the inner layer of the aorta, so that blood forces its way through the tear and into the media of the aorta, and it forms a false lumen. So anytime you see what looks like 2 lumens of the aorta, that's an aortic dissection. The main risk factor for a dissection is hypertension. High blood pressure helps to induce the tear in the intima, and then that pounding high blood pressure is what forces blood deeper and deeper into the media. Other risk factors could include diseases that weaken the aorta, such as Marfan syndrome, Ehlers-Danlos syndrome, and syphilis. Now, the classic clinical description of aortic dissection is that it causes severe, sharp, or tearing chest pain, often radiating through to the back. Now, if the dissection goes through the brachiocephalic trunk or the left carotid, it could impair circulation to the brain, and that would cause syncope or a TIA. Or if the dissection affected blood flow to the brachial arteries, you could see decreased peripheral pulses. So if you have a patient with tearing chest pain, you're going to want to check the pulses in the upper and lower extremities to check for any discrepancies. Now, what tests are you going to order on a chest pain patient? An EKG. And what's the EKG going to look like in aortic dissection? Well, it's going to be pretty normal. You might see some left ventricular hypertrophy, or LVH, because of chronic hypertension, but the dissection itself doesn't cause any EKG changes. So if the EKG is normal and the patient has that pain that's more tearing or ripping in nature, think about an aortic dissection. And then what other finding might tip you off to the presence of a dissection? Widening of the mediastinum on chest x-ray. Definitely be able to recognize that. If you ever get a chest x-ray for any reason and the mediastinum is wide, you need to figure out why. So what's the best test to order when you suspect a dissection? CT of the chest with contrast. So here you see a CT of the chest, and you first notice that the descending aorta looks huge. Then you notice this rim of darker tissue. That's the wall of the aorta outlining the true lumen, and then the large area is the false lumen of the dissection. Now, besides identifying whether or not a dissection is present, the CT is also going to help you classify it as either a Stanford A dissection or a Stanford B dissection. A Stanford A dissection involves the ascending aorta. It doesn't matter how far down it goes. If the ascending aorta is involved at all, it's called a Stanford A dissection. And you can remember A for ascending or A for the aortic arch. Now, if the dissection is confined entirely to the descending aorta, distal to the takeoff of the left subclavian artery, that's called a Stanford B dissection. So you can remember B for below the branches. And the reason that the Stanford classification is so important is that the location of the dissection determines therapy. So the first thing you want to do to treat an aortic dissection is to stabilize the blood pressure with a beta blocker, or possibly nitroprusside. But beta blockers are the drug of choice for aortic dissection because not only do they decrease the blood pressure, they also decrease the slope of the rise of the blood pressure. We call this anti-impulse therapy. It's the pounding of the elevated blood pressure that's really dissecting the aorta even more. So if you can sort of minimize that initial wave of pressure with a beta blocker, you can treat this better than with other antihypertensives. These patients may also need morphine for pain control. And then for definitive therapy, Stanford A dissections, again, those dissections that involve the ascending aorta, those are generally higher risk. So those need emergency surgical repair. So you're going to control the blood pressure first and then operate. But Stanford B dissections, which are confined to the descending aorta, can be treated medically with beta blockers, unless the dissection were to rupture or if the dissection causes pain after you've controlled the blood pressure, or if you just can't get the blood pressure under good control, or if there's any evidence of lower extremity ischemia or visceral ischemia. But in general, a Stanford B dissection is going to be treated medically. Let's move on to aortic aneurysms, specifically abdominal aortic aneurysm, or AAA. So you can get an aneurysm anywhere in the aorta, but they're about twice as common in the abdominal aorta. An aortic aneurysm is a focal enlargement or dilation of the aorta, and in terms of abdominal aortic aneurysms, they usually occur distal to the renal arteries. The number one risk factor is tobacco use, and age greater than 55 is another big risk factor. These are more common in men, especially white men. Other important risk factors include atherosclerosis, hypertension, and family history. AAAs are usually asymptomatic. Now, once the aneurysm has progressed significantly, it may cause abdominal pain or some lower back pain. And on physical exam, you might feel a pulsatile abdominal mass, or you may hear an abdominal bruit. Now, if the aneurysm ruptures, which is the main complication we worry about with a AAA, the patient's going to present with hypotension and severe abdominal pain. But again, that's usually a late presentation. But be aware of that classic triad for a ruptured AAA: hypotension, abdominal pain, and a pulsatile mass. Now, if you suspect a AAA, what's the best first test? An abdominal ultrasound. It's quick and easy, and it allows you to measure the diameter of the aneurysm. Then, if the sono is positive, a CT or an MRI is going to provide a more accurate measurement of the aneurysm size. But often, AAAs are found incidentally on CT scans that are ordered for other reasons. You should also be aware that we use ultrasound to screen for a AAA. The current recommendations are to do a one-time screening abdominal ultrasound on all men ages 65 to 75 who have any history of smoking. Then, once you've diagnosed a AAA, what are you going to do about it? Well, if the aneurysm diameter is less than 5.5 centimeters in men or less than 5 centimeters in women, the risk of rupture is very, very low. So all we do is monitor this periodically by doing an ultrasound every 6 months and watching to see if the aneurysm gets any bigger. And then what are the indications for the surgical repair of a AAA in order to prevent future rupture? Well, you want to operate before these things rupture, because if they rupture, these patients are generally going to die. A ruptured AAA has over 90% mortality. So when do we do surgery? Well, you do surgery if the diameter of the aneurysm is greater than 5.5 centimeters in men or greater than 5 centimeters in women, or if the diameter has increased by more than 0.5 centimeters in a 6-month interval. This is why we do that sonogram every 6 months in someone with a known AAA. And then the other reason to do surgery is if the aneurysm is symptomatic, if there's any tenderness or pain. Next, we're going to discuss something really common, which is peripheral artery disease, or PAD. Sometimes you'll hear it called PVD, or peripheral vascular disease. PAD is atherosclerosis of the peripheral arteries, classically in the legs, but it could be anywhere, really. It's caused by the same things that cause coronary atherosclerosis or carotid atherosclerosis: smoking, hypertension, diabetes, hyperlipidemia. In fact, most of these patients are at higher risk of an MI or stroke than they are of some terrible complication of the peripheral disease. Just remember that PAD is a marker for severe atherosclerosis. The classic symptom of PAD is something called claudication, which is leg pain that comes on with activity and then improves with rest. Definitely be able to recognize that. It's kind of like angina of the legs. These patients may have wounds or ulcers on their feet that don't heal because there's not adequate blood supply. They may complain of erectile dysfunction because if there's atherosclerosis in one part of the body, there's increased risk of atherosclerosis elsewhere in the body. Physical exam may show diminished pulses in the legs, popliteal pulses, posterior tibial pulses, dorsalis pedis pulses. They may also have some skin changes on the legs and the feet, like dry, shiny skin and decreased hair growth on the legs. The first-line diagnostic test is to measure the ankle brachial index, or ABI. So that's the ratio of the systolic pressure at the ankle to the systolic pressure at the brachial artery. So you just measure the blood pressure in the calf and also in the arm and then calculate the ratio. If the ABI is less than 0.9, that means there's some vascular insufficiency at the ankle. And if the ABI is less than 0.4, that indicates severe disease. So definitely be familiar with the ABI. Then if the ABI suggests there is some PAD, you do an ultrasound or a CT angiogram or an MRA to locate areas of stenosis. And then if that shows disease, you need to do an arteriogram. So once you've diagnosed PAD, what are you going to do about it? Well, the next question says, what are the components of conservative medical management of peripheral artery disease? So smoking cessation is very, very important. Glucose and blood pressure control if there's any diabetes or hypertension or even pre-hypertension. Daily exercise is going to help increase collateral flow. And then cilostazol is a drug that improves blood flow to the lower extremities and decreases claudication. So it's an arterial vasodilator, and it also inhibits platelet aggregation. Now this is much more effective than pentoxifylline, which is a drug that's supposed to make the red cells more flexible so they can kind of squeeze through those narrowed vessels a little easier. But cilostazol seems to work a little better for these patients. And cilostazol is contraindicated in patients with heart failure. These patients should either be on daily aspirin or clopidogrel to reduce cardiovascular events. They should be on a statin to reduce cardiovascular events and to increase pain-free walking distance. Then back on number 7, patients who don't respond to medical management may require surgical treatment such as angioplasty or a bypass graft or even amputation if there's prolonged ischemia. And many of these patients have concurrent coronary disease or carotid disease. So prior to surgery, they need some kind of cardiac stress test to see if they need a coronary intervention prior to surgery. Now let's switch from arterial vascular diseases to venous diseases, starting with deep vein thrombosis, or DVT. So this is a blood clot that develops in one of the deep veins, most commonly in the calf, although DVTs in the femoral or popliteal veins may actually be more important clinically. There are several important risk factors for venous thromboembolism, and I want to remind you of Virchow's triad, which is a classic triad of hemostasis plus hypercoagulability plus vascular endothelial injury. So hemostasis could involve prolonged inactivity, like immobilization from illness or from surgery or prolonged travel. A couple of classic scenarios would be someone on a long flight, like a transatlantic flight, or maybe a long-haul trucker who's stuck in his truck for hours or days at a time. Another classic setup for DVT would be prolonged immobilization following recent surgery, which is why we order TED-HOs and SCDs and why we try to get those patients up and moving as quickly after surgery as we can to prevent blood clots from forming. Hypercoagulability could include inherited hypercoagulable states, cancer, and also high estrogen states such as pregnancy and oral contraceptives. And then endothelial injury could include any kind of vascular trauma or injury. Now, DVTs can often be asymptomatic, but they may present with pain, warmth, and swelling in the leg, especially in the calf. Sometimes we'll measure the circumference of one calf and then compare it to the circumference of the other calf. You may have learned to check for Homan's sign, which is calf pain that occurs when you passively dorsiflex the foot, but this is a very unreliable sign for DVT. You might test for it, but if Homan's sign is negative, that doesn't really prove anything. Another common test with sort of iffy usefulness is a D-dimer. Patients with DVT usually have an elevated D-dimer, but D-dimers are often positive in patients without a DVT. For example, a D-dimer is completely useless in a post-op patient because all post-op patients have high D-dimers. But a negative D-dimer will pretty much rule out a DVT. So if you really suspect a DVT, the best test is a lower extremity ultrasound. Then for treatment, we elevate the leg to reduce swelling, and we give a low molecular weight heparin or unfractionated heparin initially, and then switch to warfarin, usually for 3 months. Now the body's going to gradually resorb the blood clot over time, and the anticoagulants don't really speed that up. All the heparin and warfarin do is prevent the clot from growing or expanding so that the body can resorb it. There are lots of other anticoagulant options like fondaparinux and rivaroxaban and dabigatran. You're not going to be asked to choose one of these over the other. That's way too advanced for step 2. And nobody's ever going to fault you for simply starting a low molecular weight heparin like enoxaparin and then switching to good old warfarin. And then if the patient has some contraindication to anticoagulation, you might have to put in an IVC filter to reduce the risk of pulmonary embolism. So PE is probably the most important complication of DVT. We're going to cover PEs in the pulmonary videos. But if you have a patient who's at high risk for falls or has some other contraindication to anticoagulation, you can put in an IVC filter. So an IVC filter is a wire mesh that kind of sits in the IVC to catch any thrombus that might break off from the DVT down to the leg and try to embolize up to the lungs. Now the downside of the IVC filter, instead of using warfarin, is that the DVT is still going to be there and that DVT could potentially grow. Finally, let's talk about varicose veins. This is where you have leaky valves or incompetent valves in the peripheral veins that allow the veins to become dilated and kind of tortuous. Now, I'm sure you've seen varicose veins before. They're usually asymptomatic, although they can occasionally cause some pain if the patient's on his feet for a long time. More commonly, patients just kind of complain about the way they look. You know, an 80-year-old woman comes in saying, "What can we do about these ugly varicose veins? I look like a little old lady." Number 10 in the study guide says, what options are available to treat varicose veins? So weight reduction, avoidance of prolonged standing, and leg elevation, all that's going to reduce the pressure on those veins. Then compression stockings. They sell support stockings over the counter. You can also order prescription compression stockings that apply specific amounts of pressure to the legs. These compression stockings can often be difficult to put on, and it may take some time for the patient to get used to walking around with these compression stockings on, but they really do work pretty well. Normally, we get blood back to our heart from our legs through a combination of muscle contraction and then those valves in the veins. But if those valves are incompetent, these stockings can help to compress the veins and force the blood back up to the heart so it's not kind of pooling in the legs. You can also do something called sclerotherapy, where you inject a substance directly into the vein that causes injury and thrombosis to scar down those varicose veins. You can do thermal ablation of the veins with a laser, either externally on the skin or internally inside the vein. And then as a last resort, you might opt to do surgery or ligation of the saphenous veins. Now we try not to remove the saphenous vein or do sclerotherapy of the saphenous vein because you might need the saphenous vein for a cardiac bypass graft sometime down the road. All right, that's it for this video. Go ahead and work through the end of session quiz, then we'll go over the answers together. First question. A patient comes to the ER following a motor vehicle collision and chest x-ray reveals widening of the mediastinum. What imaging study would you do to confirm your diagnosis? So what's the diagnosis we're thinking about? Aortic dissection. Anytime you see widening of the mediastinum, think about aortic dissection. Then the next step is going to be to order a CT of the chest with contrast. Next, what study should be ordered for a patient suspected of having a AAA? You're going to do an abdominal ultrasound. That's the quickest method to establish the presence of a AAA, and it's also going to give you good information about the location and the size of that aneurysm. Next, what patient should be screened for an abdominal aortic aneurysm? So you're going to screen all men 65 to 75 years of age with any history of smoking. That's for screening. Also, any patients with symptoms suggestive of a AAA, like a pulsatile abdominal mass, should also be evaluated with an abdominal ultrasound. Technically, that's not screening because here you're actually evaluating a complaint or some exam finding. And the last question, what's the next step in the management of a patient with a DVT that has a high likelihood of falling? Well, with that high likelihood of falling, you do not want to anticoagulate the patient because of the risk of hemorrhage. Instead, you're going to put in an IVC filter. So that's it for this video. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. A previously healthy 47-year-old man is brought to the emergency room 30 minutes after a sudden onset of dizziness and syncope. His pulse is 40 per minute and a blood pressure is 100/60. An electrocardiogram shows complete independence of P waves and QRS complexes. What is the next step in management? So for the clinical picture and the ECG especially, you should suspect a 3rd-degree heart block. And in this case, a pacemaker would be your next step. Next question. What is the treatment for cardiogenic shock? Well, the exact treatment is going to depend on the cause of the cardiogenic shock, but the main thing to remember is you need an inotrope, something like dobutamine, to improve cardiac contractility. Next, when might subclinical mitral stenosis from a rheumatic heart disease become clinically apparent? Well, this would be any time that cardiac output is going to be increased. And what is cardiac output? Remember, it's the heart rate times the stroke volume. So you can start to get symptoms like dyspnea when you have tachycardia or in situations where the stroke volume is increased, for example, maybe during pregnancy. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to shed some light on vasculitis. How about this? In this video, we're going to blow the lid off the vasculitides. Note to self. Don't let Dr. Lewis help with lecture intros anymore. Okay. We're going to cover a bunch of different types of vasculitis in this video. Vasculitis is very high yields for the board, so rather than give you a lot of extraneous details, I'm going to keep things as simple as possible by focusing only on the high yield associations and findings. So as we go through these, all we're going to put in the study guide are the key features that help you distinguish one type of vasculitis from another. So first up, let's talk about giant cell arteritis, which is also known as temporal arteritis. You need to be familiar with both of those names. And I'm starting here because giant cell arteritis is very high yield. It always seems to come up on exams because it's the most common type of vasculitis in the US. So first off, in giant cell arteritis, you see granulomas. Now we're going to find granulomas in several of these different types of vasculitis, but the reason I pointed out here is that in granulomas you often see multinucleated giant cells where macrophages cluster together and they fuse their membranes like this. So that's why we call this giant cell arteritis. So most of these vasculitides have what I call a high yield history, a fairly specific type of patient with a specific classic presentation that's almost going to give you the diagnosis. Now for giant cell arteritis, the high yield history is that it's more common in women than in men, especially elderly women. And it's also associated with polymyalgia rheumatica, which we're going to talk about in the musculoskeletal section. So if you see an elderly woman with a history of PMR who presents with headache, tenderness of the temples, or jaw claudication, that high yield history should make you think about giant cell arteritis. Now, jaw claudication means that the patient has pain in the jaw while eating or chewing due to insufficient arterial supply to the jaw muscles. Another important clinical feature is transient or permanent vision loss, both as a presentation and also as a potential complication. One reason we don't mess around with giant cell arteritis is it can lead to blindness. So in any patient with a headache, if the clinical picture is at all suspicious, you need to consider the possibility of giant cell arteritis and rule it out by checking a SED rate. So here's a photo of a patient with temporal arteritis, and you can see this prominent temporal artery, and it might be tender to palpation. You can also tell that this is an older patient. So this is a situation where you'd be worried about temporal arteritis and you'd want to rule it out. Again, the best first test to order is an ESR, or a SED rate. Then if the SED rate's elevated, you need to get a temporal artery biopsy. So if you suspect giant cell arteritis from the H&P, what's your next step? Well, you can't wait for that temporal artery biopsy to come back before you start treatment because the consequence could be permanent blindness. So what most of us do is draw the SED rate and then go ahead and start treatment with prednisone. If the SED rate comes back high, you're thinking it might be temporal arteritis, and then you'd go ahead and get that temporal artery biopsy. And then you're going to continue the prednisone until the biopsy results are available a few days later. But if the SED rate comes back normal, then you've ruled out temporal arteritis, and you can go ahead and stop the prednisone. Now, if you do confirm the diagnosis, you're going to keep the patient on high-dose prednisone for 1 to 2 months, followed by a long taper over the course of 9 to 12 months. We also give aspirin to reduce the risk of vision loss or stroke from vessel occlusion. We often give calcium and vitamin D supplements to reduce the risk of osteoporosis from prolonged high-dose steroid use. Like I said, these patients may be on steroids for up to a year, and anybody who's on steroids that long has an increased risk of osteoporosis. So, to summarize, with giant cell arteritis, you're going to see granulomatous inflammation of the temporal artery or other branches of the carotids, especially in elderly women. It's associated with polymyalgia rheumatica. It causes headache, tenderness of the temporal artery, and jaw claudication. It may lead to vision loss. You're going to start the workup with a SED rate and then get a temporal artery biopsy to confirm the diagnosis. And the mainstay of treatment is high-dose prednisone. Next, let's go over Takayasu arteritis. Both giant cell arteritis and Takayasu arteritis are types of vasculitis that affect large vessels. I'm kind of grouping these diseases by the size of the vessels that they typically affect.
Specifically, Takayasu arteritis affects the arch of the aorta and the three major branches that come off the aortic arch. Now, I like to remember all the A's in TA, KA, YA, SU for disease of the aorta. Now, the typical patient population is young Asian women ages 10 to 40. I associate the Japanese name Takayasu with young Asian women. When you inflame and occlude these branches of the aortic arch, that can lead to cerebrovascular ischemia, or it might cause myocardial ischemia by involving the coronary arteries. There might be symptoms of syncope, fever, vertigo, but the classic finding is poor pulses in the upper extremities. This is sometimes called pulseless disease because those branches off the aortic arch perfuse the upper extremities. Now, you can do a CT angiogram or an MR angiogram to look for stenosis of vessels, and we're going to treat with glucocorticoids and possibly bypass of the obstructed vessels if necessary. But the main points to remember are that Takayasu arteritis affects the aorta and the aortic arch and its branches. It's seen in young Asian women, and it causes poor pulses in the upper extremities. Next, let's move from large vessel vasculitis to vasculitis of medium-sized vessels. We're going to talk about Kawasaki disease, polyarteritis nodosa, and thromboangiitis obliterans. So let's start with Kawasaki disease, which is a 3 or 4 star topic that always seems to come up on boards because it has a fairly memorable constellation of findings. First of all, Kawasaki disease is a disease that affects infants and young children, especially children of Asian descent. Make note of that. That's your high yield history. And it's easy to remember that again because Kawasaki is a Japanese name. Now, the next question in the study guide lists the diagnostic criteria for Kawasaki disease, which is also called mucocutaneous lymph node syndrome. Be able to recognize this constellation of findings is very important. It's probably the highest yield part of all this. So let's talk through all these diagnostic criteria first with some pictures, and then we'll put up the answers at the end so you can fill in the blanks. To make the diagnosis of Kawasaki disease, you have to have fever lasting at least 5 days, in addition to 4 of the following 5 symptoms. And the mnemonic for these symptoms is crash. So C is for conjunctivitis, bilateral, non-exudative, painless conjunctivitis. The R is for rash on the trunk, which you see on the upper left. A is for adenopathy of the cervical lymph nodes, which isn't really pictured, but remember this is called mucocutaneous lymph node syndrome. S is for strawberry tongue, which is on the upper right, this beefy red tongue with a coarse texture to it. And then with that, you can have diffuse erythema of the mucous membranes, which you see on the bottom left. This child's lips are just all red and irritated looking. So there's the mucocutaneous part of this, changes in the lips and the oral mucosa. And then H is for hands and feet, which can have erythema or desquamation. You see that on the bottom right, the desquamation of the fingertips. That's another big clue for Kawasaki disease. There aren't too many things that will cause that. So again, the blanks to fill in for crash are conjunctivitis, rash, adenopathy, strawberry tongue, and hands and feet. And some people like to say crash and burn because the burn reminds you of the fever, which is another important diagnostic criterion. And then the last bullet talks about coronary artery aneurysms. About 25% of these kids will develop coronary vasculitis, which can lead to coronary artery aneurysms, an MI, or sudden death. These coronary artery aneurysms can either rupture or they can develop thrombosis inside of the aneurysm. An extension of that thrombosis is going to cause an MI, and either one of those is bad news for a patient with Kawasaki disease. But the note here says that these aneurysms may not develop for weeks, and you don't need to have aneurysms to make the diagnosis. This is an angiogram of a coronary aneurysm in Kawasaki disease. So they might show you an angiogram and expect you to first recognize that this is an aneurysm, and then remember that coronary aneurysms are associated with Kawasaki disease. The next question says, how is Kawasaki disease treated? So in general, you don't need to know a lot about treating most of these diseases, but Kawasaki disease is an exception. The initial treatment is IVIG, ideally within the first 10 days of illness. Then the unique treatment to remember is high-dose aspirin, which is continued until 48 hours after the fever resolves, followed by low-dose aspirin until the inflammatory markers return to normal after a few weeks. This is one of the few times that we give aspirin to children. In fact, if you look right in the middle of the word Kawasaki, you see ASA, which is shorthand for aspirin, acetylsalicylic acid. Now, steroids are not indicated and are of no proven benefit. So this is one type of vasculitis where we don't give steroids. And you can do an echocardiogram in the acute phase and then again 6 to 8 weeks later to make sure there are no coronary aneurysms developing. The rest of these medium vessel vasculitides aren't nearly as involved. The next one we're going to cover is polyarteritis nodosa, which is often abbreviated PAN. PAN causes necrotizing inflammation of small and medium-sized arteries, which leads to ischemia of the affected tissue. Now, PAN can affect almost any tissue, but it often affects the kidneys and the GI tract. It can also affect the skin, the heart, the muscles, the nerves, the joints. And it's worth knowing that PAN classically spares the lungs. So if you see vasculitis with pulmonary involvement, it's probably not polyarteritis nodosa. You should also remember that PAN is associated with hepatitis B and hepatitis C. So that's your high-yield history. If they give you a Hep B or Hep C patient who has proteinuria or hematuria, which suggests some type of renal disease, think about PAN. Another fairly specific clue is that PAN patients are ANCA negative. A positive ANCA is pretty much going to exclude polyarteritis nodosa as the diagnosis, which can be pretty helpful. And we're going to talk about some types of ANCA positive vasculitis in a few moments. One last clue is that angiography may show aneurysms in various vessels, especially in the abdominal organs. So this is a renal angiogram from a patient with polyarteritis nodosa, and you can see several aneurysms within the vessels. So again, the key points for PAN are involvement of many tissues, especially the kidneys and the GI tract, but sparing the lungs. It's associated with hepatitis B and C. ANCA will be negative, and angiography may show aneurysms in all those affected tissues. There's also a type of vasculitis called thromboangiitis obliterans, or Berger disease. Now, this is not the same as the kidney disease called Berger disease, which is IgA nephropathy. That's B-E-R-G-E-R. This is B-U-E-R-G-E-R, Berger disease. I'm getting hungry just talking about it. Can I get some fries with that? Anyway, thromboangiitis obliterans is vasculitis of small and medium-sized arteries and veins, and it's seen in heavy smokers, especially young male smokers in their 30s and 40s. Now, that may not seem so young to you, but it sounds pretty good to me. So that's your high-yield history. Vasculitis, heavy smoker, 40-year-old male, Berger disease. And again, this is thromboangiitis obliterans, so it's going to obliterate those vessels, so you're going to get ischemia of the digits, which causes pain and sometimes ulcers on the fingertips and the toes. They can also have cold sensitivity and Raynaud's phenomenon. So here's a photo that shows ischemia of the digits and some gangrene and autoamputation. And the treatment is simply to stop smoking. When the patient stops smoking, the vasculitis goes away. Now we're moving on to purely small vessel vasculitis, which includes Henoch-Schönlein purpura, or HSP, mixed cryoglobulinemia syndrome, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. So let's start with Henoch-Schönlein purpura, or HSP. It's also sometimes called IgA vasculitis, which we'll come back to shortly. The high-yield history here is it's usually a disease of children rather than adults, particularly children with a recent upper respiratory infection, especially strep infections. Now, there's a classic tetrad of 4 main clinical findings that are worth knowing for HSP. The first one is palpable purpura of the lower extremities in a patient without thrombocytopenia or coagulopathy. So here's a patient with HSP, and you can see all these prominent purpura. Palpable purpura is kind of a buzzword for vasculitis in general. So when you see or hear palpable purpura, think vasculitis. And again, HSP is a disease of children, as you can see. The other parts of the tetrad include arthritis and arthralgias, abdominal pain due to intestinal hemorrhage, and renal disease with microscopic hematuria and maybe some mild proteinuria because of IgA deposition in the kidneys. Remember, HSP is also called IgA vasculitis. So when that IgA gets deposited in the kidneys, that starts to cause problems. This is basically identical to the IgA nephropathy or Berger disease, B-E-R-G-E-R, which we're going to see again in the nephrology section. And it may be worth knowing that HSP is generally a self-limited illness, so no specific treatment is needed, just hydration and pain control. So the summary here is it's a disease of children with a recent upper respiratory infection, and you look for the tetrad of palpable purpura, arthritis and arthralgias, abdominal pain, and renal disease from IgA nephropathy. Another type of small vessel vasculitis is called mixed cryoglobulinemia syndrome. It's also gone by the name essential mixed cryoglobulinemia. Now, this one may not be super high yield, but it has been known to turn up on practice questions and on the board, so it's definitely fair game. Cryoglobulins are immunoglobulins that precipitate out of the blood at cooler temperatures. That's why they're called cryoglobulins. And this is called mixed cryoglobulinemia because it's not just IgA or IgG or IgM. It's a mix of several different immunoglobulin classes. Usually it's IgG plus some IgM antibodies directed against those IgG antibodies. And these are polyclonal IgG antibodies, which means that it's a bunch of different antibodies against a bunch of different antigens. It's not a monoclonal antibody like we see with multiple myeloma or Waldenstrom's macroglobulinemia. Mixed cryoglobulinemia syndrome is most commonly seen in patients with hepatitis C. About 80 to 90% of patients with mixed cryoglobulinemia also have hepatitis C. Now, this can occur with hepatitis B or with HIV infection, but mainly I want you to remember hepatitis C. The clinical presentation you need to know is called Meltzer's triad, which includes palpable purpura, weakness due to peripheral neuropathy, and arthralgias. And because this is cryoglobulinemia, you can remember that these patients may develop Raynaud's phenomenon. And most of these patients develop liver involvement, which makes some sense if you associate this with hepatitis C. I also want you to know that 20 to 30% of these patients eventually develop renal disease, so they may have hematuria and or proteinuria. So our summary is polyclonal IgG and IgM antibodies, Meltzer's triad of purpura, weakness, and arthralgias, and then look for renal disease in a minority of patients. Continuing our trend of 2 names for each type of vasculitis, the next one is granulomatosis with polyangiitis, which is sometimes called GPA, and which was formerly known as Wegener's granulomatosis. Now we're also going to cover Wegener's granulomatosis in the pulmonology section because it causes vasculitis in the lung. But you can tell by the name that granulomatosis with polyangiitis causes granuloma formation. And the 3 sites of involvement that you should associate with it are granulomas in the lung, which may cause pulmonary nodules or pulmonary infiltrates or possibly some hilar lymphadenopathy. You can also see granulomas in the upper airway, so the ears, the nose and throat, the soft palate, and also involvement of the kidneys. There aren't too many diseases in which you get prominent lung and kidney involvement. Granulomatosis with polyangiitis is one of them. The other important one is Goodpasture syndrome. But if you see involvement of the lungs and the kidneys and the upper airways, that's going to be granulomatosis with polyangiitis. The other important feature to know is that GPA is usually C-ANCA positive, so that's pretty helpful. But ultimately, you're going to need a biopsy to make the diagnosis, either a kidney biopsy or a lung biopsy. And the last disease we're going to cover has a very similar name, eosinophilic granulomatosis with polyangiitis. Now you may know it better by the name Churg-Strauss syndrome. They keep changing the name. It went from Churg-Strauss syndrome to allergic granulomatosis with angiitis, and now it's called eosinophilic granulomatosis with polyangiitis. The high yield history here is that it's associated with asthma. Definitely know that association. These patients often have asthma and some type of lung involvement from the vasculitis, like lung opacities and nodules, plus upper airway disease like we saw in Wegener's. So those are really the big things: asthma, pulmonary disease, and upper airway disease. They often also have nonspecific skin findings like tender skin nodules or palpable purpura again, and about 20% of these patients can have renal involvement. It's not nearly as prominent as in Wegener's. Now, one way to distinguish Churg-Strauss from Wegener's is that Churg-Strauss is P-ANCA positive. We said that Wegener's is usually C-ANCA positive, but Churg-Strauss is P-ANCA positive. Another clue is in the name. It's eosinophilic granulomatosis with polyangiitis. So these Churg-Strauss patients have peripheral eosinophilia, which goes along with asthma too, and they also have eosinophilic inflammation on the biopsy. This is a lung biopsy from a patient with pulmonary infiltrates and upper airway disease, and you can see all this granulomatous inflammation around the pulmonary arterioles, but you also see these pretty red eosinophils all over the place. So this is eosinophilic granulomatosis with polyangiitis, or Churg-Strauss syndrome, rather than Wegener's granulomatosis. And again, this patient is going to most likely have a positive P-ANCA and a history of asthma. Now, before we do the end-of-session quiz, I want to do a quick whiteboard review to lock down all this information. All right, first of all, I want us to match our high-yield histories to the different types of vasculitis. So the first high-yield history is a 2-year-old Asian female, which should make you think about Kawasaki disease. And then in a 20-year-old Asian female, you should think about Takayasu arteritis. The vasculitis that's associated with asthma, think about eosinophilic granulomatosis with polyangiitis, or again, the old name is Churg-Strauss syndrome. In a young male smoker, you're going to think about thromboangiitis obliterans, or Berger disease. Then the vasculitis associated with PMR or polymyalgia rheumatica is temporal arteritis, or the other name for that is giant cell arteritis. The one that's associated with IgA nephropathy is HSP, or Henoch-Schönlein purpura. And then the one that's associated with hepatitis B is polyarteritis nodosa. Now we're going to match different types of vasculitis to the various clinical presentations. So the first clinical presentation is an elderly woman with jaw claudication and vision loss. That one should make you think of temporal arteritis or giant cell arteritis. Next one is strawberry tongue, which we said was associated with Kawasaki disease. And desquamation of the hands and feet is also associated with Kawasaki disease.
Poor pulses in the arms, that's pulseless disease, or that disease of the aortic arch branches, which is Takayasu arteritis. Remember all those A's for the aortic arch. Palpable purpura in the legs. Palpable purpura, again, is a buzzword for vasculitis in general, but when you see them on the back of the legs, think about HSP or Henoch-Schönlein purpura. Then vasculitis of the kidney and the GI tract, but spares the lungs. Anytime you see vasculitis that specifically you're told it spares the lungs, think about polyarteritis nodosa. And finally, vasculitis that affects the kidneys and the upper airway and the lungs. That triad should make you think of granulomatosis with polyangiitis, or the old name is Wegener's granulomatosis. And since you did so well on that one, I'm going to give you a little treat, a nice steaming hot bowl of vasculitis alphabet soup. Now go ahead and work through the end of session quiz, then we'll go over the answers together. First question, which type of vasculitis fits the following descriptions? So occlusion of the ophthalmic artery can lead to blindness, that's giant cell arteritis. Infants and young children, it involves the coronary arteries, that's Kawasaki disease. Young male smokers is thromboangiitis obliterans. Young Asian woman with weak radial pulses, that's pulseless disease, which is Takayasu arteritis. Associated with hepatitis C infection and Meltzer's triad, that's mixed cryoglobulinemia syndrome. Most common vasculitis in the U.S. is giant cell arteritis. Vasculitis associated with peripheral eosinophilia is eosinophilic granulomatosis with polyangiitis, or Churg-Strauss syndrome. Vasculitis that is P-ANCA positive, that's eosinophilic granulomatosis with polyangiitis again. And vasculitis that is C-ANCA positive, that's granulomatosis with polyangiitis, or Wegener's. And which type of vasculitis do we specifically say is ANCA negative? That's polyarteritis nodosa. Next question. A 76-year-old woman comes to the physician with unilateral headache and jaw claudication. What's the most appropriate first diagnostic test? So what's your suspected diagnosis? Giant cell arteritis or temporal arteritis. So the most appropriate test would be a SED rate. And if that comes back positive, the next test would be a temporal artery biopsy. But if you have a strong suspicion, don't wait for the biopsy before you start treatment. And that brings us to the last question. What's the treatment for each of the following types of vasculitis? For giant cell arteritis, the treatment is high-dose prednisone, usually for several months. For Kawasaki disease, it's IVIG and aspirin. And remember, steroids are not beneficial in Kawasaki. For Henoch-Schönlein purpura, it's supportive care. Remember, this one's self-limited. And then for thromboangiitis obliterans, the treatment is smoking cessation. That's it for this video. I'll see you next time.